Record.
بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good afternoon وجمعة مباركة للجميع. بفضل الله سبحانه وتعالى أرحب بكم في المؤتمر الثالث للمستجدات ولمستجدات الآسكو Annual Meeting، ونقول لكم برضو كل عام وانتم بخير بمناسبة العشر المباركة وشهر ذو الحجة المبارك والوقفة المباركة وعيد الأضحى المبارك والسعيد على الجميع بإذن الله سبحانه وتعالى. بداية أحب أن أوجه شكري للجان العلمية واللجنة المنظمة، وعلى رأسها أستاذتنا ودكتورتنا الدكتورة ميرفت محروس، الدينامو المحرك خلف هذا المؤتمر والمؤتمرات الأخرى، وبقية الزملاء الذين بدأوا شرارة هذه المؤتمرات وهذا نجاح، الدكتور عبد العزيز الحمد، وكافة الزملاء في قسم الأورام بمدينة الأمير سلطان الطبية العسكرية، ودعم إدارة مدينة الأمير سلطان الطبية العسكرية، ودعم الخدمات الصحية بوزارة الدفاع، وعلى رأسها سعادة المدير العام الدكتور أحمد العامري، وسعادة اللواء الطبيب سعود الشلاش مدير مديرة الأمير سلطان الطبية، وكافة الإداريين والزملاء في المستشفى على دعمهم المتواصل اللامحدود. كما أوجه الشكر إلى الشركات الداعمة بفضل الله سبحانه وتعالى، ثم بفضل دعمهم وجهود الزملاء تقام مثل هذه المناسبات. شكرا لكم تواجدكم، وبعد قليل إن شاء الله حنبدأ البرنامج العلمي. I'd like to welcome you all to the third update of the ASCO annual meeting, which is the third on the row. And I'd like to extend my thanks to the higher administration of the Department of Health Services at the MSD, Ministry of Defense, and to my colleagues within the Department of Medical Oncology and Radiation Palliative at the Prince Sultan Medical Military City. And I'd like to extend warm thanks to Dr. Mirfat Mahrous for organizing such an event, and for my colleagues, Dr. Abdulaziz Al-Hamad, who started this success 3 years back, and to all the colleagues in the Department of Oncology at PSMMC, and also to extend the thanks to the higher administrations at PSMMC, and namely to the Lieutenant General Dr. Saud Al-Shlash, and to the General Director of the Health Department at the MSD, His Excellency Dr. Ahmed Al-Amri, and to all the colleagues in the department as well as in the city. And I'd like to extend my thanks to the supporting companies. Without their support, this event will not see the light of the day. And I'd like to welcome you all and to extend my congratulations on Al-Eid, on the Hijjah month, and on Eid al-Adha, the blessed Eid al-Adha, which is coming after almost like 8 days. And thank you very much for you attending the conference, and for the online attendees as well. Without any further ado, we'll start the meeting today. First, I'd like to introduce the chairpersons of the first session, which is themed for breast cancers. First, we have with us Dr. Aisha Al-Harbi. Aisha is a consultant medical oncologist at the King Fahd Military Hospital in Jeddah for the time being. And next to her is Dr. Munir Al-Majid. Dr. Al-Majid is a consultant medical oncologist at PSMMC with a special interest of breast and gynecological cancers. And also warm welcome to Dr. Majid Al-Jahil. Majid is the director of the oncology department at King Fahd Hospital, MOH in Medina, with a special interest in breast cancers. So I'd like to invite Dr. Aisha Al-Harbi to introduce the first speaker and the first abstract. Dr. Aisha?
Yeah, thank you, Dr. Sam Murshid. First of all, I would like to thank you and your team really for this great work. Such a great committee meeting will not be successful without good organization. Let's start with the first speaker, Dr. Sam Murshid. Beyond introduction, he's medical oncology consultant at Prince Sultan Medical City, and he's director of oncology department at Prince Sultan Medical City. That he will present in 15 minutes luminal A trial, that prospective trial, omitting radiotherapy following breast conservative surgery in T1 and 0 luminal A breast cancer.
Okay, thank you, Dr. Aisha. Thank you very much, and thank you for the attendees, either physical or online. The abstract that was chosen for me to present was almost like a breakthrough abstract during the meeting, which was presented in the local regional management session, and it's about radiation therapy. It's the Lumina A clinical trial, which is a prospective randomized clinical trial omitting radiation therapy following the breast conserving surgery in T1N0 M0 luminal A breast cancer, which was presented at the meeting by Dr. Timothy Whelan from Toronto Princess Margaret Hospital. As we know, adjuvant breast cancer is commonly given following breast conserving surgery. It reduces the risk of local recurrence by 67%, and at the same time, it's a bit inconvenient for patients because of cost and because of toxicity, acute toxicities such as skin erythema, irritation, and fatigue, late toxicity such as breast pain, induration, and destruction affecting the cosmesis and the quality of life. I know that cosmesis is a major concern for women, and over the past few years, it's a major concern for men. Rare life-threatening side effects such as cardiac disease and second cancers. The risk of recurrence has been decreasing, attributed to screen-detectable smaller lesion, which with the improvement of surgical techniques and adjuvant systemic therapy. The question is that, can radiotherapy for this group, for a group of those patients with very high risk, be omitted? And this is the whole question of this trial. So we know that clinical pathological factors alone, such as age, tumor size, and grade, have been limited in their ability to identify very low-risk patients who could be spared radiation therapy. Now we are in the genomic era, which provided a unique opportunity to understand the molecular biology of breast cancer. So Perot and his colleagues have used approximately 500 genes to classify breast cancer patients into intrinsic types. These types include luminal A with estrogen genes, non-proliferative approach, and luminal B, estrogen genes with high proliferation, and HER2 enriched, where the hormones are negative, but HER2 is positive or amplified and is highly proliferative disease. The fourth would be the ER negative with cell cycle control DNA repair, which is proliferative. Subtypes are prognostic for distant recurrence. Parker and his colleagues then developed the technique to classify intrinsic subtypes using 50 genes called the BAM50, followed by the identification or the development of an approach to classify intrinsic subtypes using immunohistochemistry analysis of 6 biomarkers by Nelson and his colleagues. Those biomarkers included ER/PR, HER2, Ki67, CDK4/6, and EGFR. Luminal A disease is defined as a tumor with ESR positive of 1% and more, PR of more than 20%, HER2 negative, Ki67 of up to 13.25%. And Vuduk and his colleagues have evaluated just above 1,400 patients treated with breast-conserving surgery. Intrinsic subtypes was shown to be prognostic for local recurrence, which is now as well as for metastatic disease. So luminal A, the risk of recurrence at 5 years was 2.8%. For luminal B, it was 5.7%. For HER2, it was 14%. And for basal type, it was 10.3%. And the whole aim of this trial, which is a and we know that there is something called the Toronto trial, which was a retrospective analysis evaluated whether combination of clinico-pathological factors and intrinsic subtypes could identify very low patient or very low risk patients. The Toronto trial, which was breast cancer, included patient with T1, T2, N0 post breast conserving surgery, randomized versus tamoxifen, randomized to receiving tamoxifen versus tamoxifen plus radiation therapy. The sample included almost 500 patients, and they analyzed using the immunohistochemistry signatures. Clinical risk group and intrinsic subtypes identified independently actually predicting the risk of local recurrence. Low clinical risk group among these 500 patients, which represented about 74 patients, have shown that patient who's older than 60, T1 N0 grade 1 to 2 and luminal A had the lowest risk of 1.3%. But unfortunately, this is very low numbers, and the analysis of the whole trial was not designed to detect the difference for such group of patients. Lumina A general objective is to determine the clinical unity of combining clinical pathological factors and luminal A subtypes to identify women with very low risk of local recurrence following breast conserving surgery with endocrine therapy alone, where radiotherapy can be omitted. So these patients should receive endocrine therapy. To determine if women with low risk clinical pathological factors of 55 and above with the T1 N0, M0, of course, of grade 1 to 2, and luminal A, as defined as per the definition of luminal A, treated with breast conserving surgery and endocrine therapy alone for 5 years. Without radiotherapy, have an acceptable risk of local recurrence of less than 5%. The research question here is related to the prognosis, not to the efficacy of treatment. So this is a prognostic analysis rather than treatment efficacy. We know that radiotherapy for breast conserving surgery is very effective in lowering the risk of local recurrence. Targeted to a very low risk group as defined before, which is a randomized clinical trial, could show, can we design this trial addressed to answer the question of effectiveness of radiotherapy in such population, but would require a very large sample size to detect the small difference. Carefully controlled prospective cohort study is a more efficient, yet can also be very precise. This is the design of the Lumina A. Patient included or recruited for the trial should have ER more than 5 or more, 1 or more percent, with PR of more than 20%, HER2 negative post breast conserving surgery, and all these patients either receive hormone therapy or were planned to receive hormone therapy. Ki-67 analysis was done centrally, and patient with Ki-67 of up to 13.5 were included in the trial, and those with Ki-67 level above 13.25% were excluded. The calculated sample size to detect the difference was 500 patients. Inclusion criteria, as it was said before, patients should be 55 and older with invasive ductal carcinoma, post breast conserving surgery and sentinel lymph nodes. So here, lobular carcinoma and other subtypes were not included. Margins of at least 1 millimeter or more with grade 1 to 2 disease, ER 1% and more, PR less than 20% with HER2 negative, and endocrine therapy either given or planned to be given. Exclusion criteria of this was multifocal and multicentric, extensive intraductal component of more than 25%, lymphovascular invasion. I will not go through this. This describes the process of the central testing for Ki-67 and the details and the reliability of that to ensure a unified figure of Ki-67 among all patients included within the trial. The primary outcome was local recurrence, any invasive or non-invasive local recurrence. Secondary endpoints included contralateral breast cancers, any recurrence, disease-free interval, and overall survival. Endocrine therapy, as you can see, patient actually received either aromatase inhibitors or tamoxifen for at least 5 years, and follow-ups was done every 6 months with the first 2 years and then annually with annual mammogram. The sample size was based on the precise estimate of 5-year local recurrence, assuming that the local recurrence of 3.5% and an upper boundary of the two-sided 90% confidence interval of a one-sided confidence interval of less than 5% up to 3.5%, which requires 500 patients, and the probability of local recurrence estimated using cumulative incidence function with death as a competing risk. Intention to treat analysis was planned at a median of 5 years. Results: patient occurred for the study from August 2013 until 17, 26 centers were participating and the median follow-up of 5 years. And this, the progress of patients since recruitment until the final patient included in the trial. Initially, they had 740 patients included. After going through certain factors like the sufficiency of the specimen and reconfirming the Ki-67, they enrolled 500 patients, 4 patients were ineligible, 1 withdrawn. The final analysis included 500 patients. Of those, 4 patients received radiation therapy, 8 did not actually receive hormonal therapy, and 21 withdrew the follow-up, but all were included in the intention to treat analysis of the trial. The basic characteristics of the trial were very balanced, with a median age of 67%, tumor size, which was almost evenly distributed between below 1 centimeter and above 1 centimeter. Almost 66% of patients had grade 1 and tamoxifen, and the majority of patients did receive aromatase inhibitor, 60 versus 40%. The local recurrence, the events calculated or detected at 10 years were, at 5 years were 10 events, and the 5-year local recurrence rate was 2.3 with a confidence interval of 1.3 to 3.8, so well beyond the boundary of 5% estimated from previous trials. As you can see here, this is the average and this is the boundary, and the upper boundary did not actually reach the 5% that we estimated from other trials. Other events included 8 patients developed contralateral breast cancers, accounting for about 1.9%. Any recurrence was 12%, which represent 2.7%. Disease-free interval was 89.9, which is almost 90 years. And the overall survival, they detected 13 deaths. 1 was only related to breast cancer, with a 97.25-year survival. So women above 55 years of age with T2, with T1N0 grade 1 to 2 luminal breast cancer following breast conserving treatment with endocrine therapy alone had a very low risk of recurrence at 5 years of average of 2.3. The rate satisfied the pre-specified boundary of the trial, and prospective and control nature of this multi-center study support such patients should not receive or actually safely we can omit radiation therapy from their management. What is the significance of that? According to the author, in North America alone, more than 300,000 patients or women are diagnosed with invasive breast cancer in North America alone, and the estimate is that 10%, around 10% of those 300, which is almost above 30,000 patients, can be spared of radiation therapy, reducing the agony of this patient, the inconvenience, the cost of treatment. And in our center, actually, if we manage to adopt this approach, it will reduce the burden on the health system. Thank you very much.
Thank you, Dr. Assam. It's really interesting data to see also this escalated treatment approach in radiotherapy. Now I will handle the mic to Dr. Munira Majid. Welcome, Dr. Munira.
Thank you, Dr. Aisha. We'll move now for the second session, which will be about a talk about overall survival with first-line palbociclib plus letrozole versus palbociclib plus letrozole in women with, versus placebo plus letrozole in women with estrogen receptor positive, HER2 negative, advanced breast cancer, analysis from Paloma 2 by Dr. Talib Bouhlega, who is a medical oncology consultant and his section of oncology at Prince Sultan Medical City. Dr. Bouhlega, welcome, and you may start.
Thank you, Dr. Majid. Bismillah ar-Rahman ar-Rahim, wa salatu wa salam ala ashrafil anbiya wal mursaleen, nabiyina Muhammad wa ala alihi wa sahbihi ajma'in. First, I would like to thank the audience for their attendees, either physically or through the line, and also to thank the organizing committee for this successful arrangement of this conference. My talk, as Dr. Majid said, I'm going to update on the Paloma 2 trial, which is the overall survival in the postmenopausal women hormonal positive HER2 negative advanced breast cancer. So this updated was presented last time in the ASCO 2022, and as a background of this trial, it was first time was approved the palbociclib, which is the oral CDK4/6 inhibitor in 2015 after Paloma 1 trial, which is a phase 2. This lead to accelerated phase to do the Paloma 2 trial, which is a phase 3 double-blinded randomized trial, multicentric, which demonstrate statistical improvement in the median progression-free survival and also confirming the data of Paloma 1 trial. After median follow-up of 23 months, the median progression-free survival was reaching up to 24 months in the combined arm between the palbociclib and letrozole versus the single use of letrozole, which is 14.5 months. And the final overall survival was released this time on the ASCO 2022 after follow-up of 90 months, and the number that's required for this event reached on November 2021. So before we seeing the result of Paloma, the overall survival, let's review ourselves about the Paloma 2 study design, which is it is a 2-to-1 randomized to 2 arm. The study arm, which is the palbociclib versus with letrozole versus the placebo with letrozole, and it was 2-to-1, and the number recruited in this trial was 662 patients. The study arm was 444, and compared to the control arm, which is 222 patients. The eligibility criteria was postmenopausal women with hormonal positive HER2 negative advanced breast cancer, and also no history of prior use of treatment for advanced disease. And they allow patients with the performance status from 0 to 2. The primary endpoint reached at that time, and it was progression, which is the progression-free survival, and the secondary endpoint was overall survival response safety. The stratification factor, which is the disease site, visceral, non-visceral, disease-free interval, like de novo metastatic, or less than 12 months from using of hormone therapy, or more than 12 months, which is very important. because less than 12 months, we consider this is a primary endocrine resistance. For the demographic and baseline characteristic of the PALOMA 2 trial, as you see, it is well distributed between the two arms. But if you look to the disease-free interval, okay, which is less than 12 months, it is constitute around 22% from that patient, which can affect actually the overall survival, and also the prior systemic therapy, which is prior endocrine therapy, which is around 56%. This is a slide just to show you how, the survival disposition and intention to treat population. As you see, the study arm, which is the palbociclib with letrozole, the number of death is 273, which constitute around 62% compared to the patient who is alive at that time, which is 112 patients, constitute around 25%. But there is a missing survival data, which is constitute around 13%. And of course, this will affect the overall survival. And now the overall survival, as you see in the Kaplan-Meier curve, there is no clear separation, but there is a trend actually to numerically improving the overall survival in the study arm between the palbociclib and letrozole compared to letrozole alone. As you see, the median overall survival after follow-up of 90 months is 53.9 compared to the single use of letrozole, which is 51.2 months. Unfortunately, this is did not reach statistical significance, and the hazard ratio is 0.956, and also the p-value is 0.33. This is the overall survival in the subgroup analysis. I will show you that there's some improvement in the overall survival in subgroup, like patient who had performance status between 1 to 2. There's a trend that the overall survival improvement in this group, and also patient who had disease-free interval more than 12 months compared to patient who had disease interval less than 12 months, which consider this as a primary endocrine resistance. And the primary chemotherapy, the bone disease itself even increased the overall survival, which favor the use of combined of palbociclib with letrozole. And this is the post hoc analysis for excluding patient with survival data not available, which was missing from the follow-up. And as you see, there is a trend numerically increase in the overall survival in the combined arm, as you see it in the blue line, compared to the yellow line in the Kaplan-Meier curve. And the number is around 51.6 months compared to 44.6 with hazard ratio 0.86. And as you see, the duration of treatment in the combined arm, there is increase in the median duration of the treatment. As you see, after 72 months, there's 16% actually patient use the combined palbociclib with letrozole compared to patient who use only single agent, which they constitute around 5%. And the same thing for the post-study systemic therapy. As you see, most of the patient, now I would not say most of the patient, a good number of patients, around 12%, after they discontinued the trial, they use the second line, again, they use this oral CDK4/6 inhibitor like palbociclib, abemaciclib, or ribociclib. And this actually can sometimes affect the overall survival data. For the time to the chemotherapy, which is the secondary endpoint, it showed that there is a clear delay use of first-line chemotherapy by around 38.1 months in the combined palbociclib with letrozole compared to the single use of letrozole, which reached only 29 months. So it significantly delayed the first use of first-line chemotherapy compared to single use of letrozole. The same thing for the common side effect. Still, it is the same after even follow-up of 90 months. There is no accumulative toxicity Most of the toxicity is neutropenia, leukopenia, arthralgia, stomatitis, but there is no increase in the percentage or the number of the patient or the grade. For combined analysis between the PALOMA 1 and PALOMA 2, the overall survival, it showed that numerically increased, but not significantly. It's not statistically significant. So the median overall survival was 51.8 months compared to the control arm, which is the 46.8 months. And the same thing for subgroup analysis between the combined between PALOMA 1 and PALOMA 2, the overall survival in the endocrine sensitive, which is more than 12 months, it showed that actually improvement, huge improvement by up to 64 months compared to the use of compared to the control arm, which is only 44.6 months. As you see clearly in the Kaplan-Meier curve, there's a clear separation between the blue line and also the yellow line. So in conclusion, we know now the PALOMA 2 trial meet the primary endpoint, which was designed for progression-free survival, but for overall survival, did not reach statistical significance, but there is a trend of increasing the median progression overall survival, and this is sometimes due to limitation of the study, as there's missing data from the follow-up around 12%, and also there is use after discontinuation from the PALOMA 2 other oral CDK4/6 inhibitor that can lead actually sometimes to change and affect the result of overall survival. Thank you.
Thank you, Dr. Taleb. It's a very interesting presentation. I will move the mic to my colleague, Dr. Majid Al-Jahil, a medical oncology consultant and the head of oncology department at King Fahad Hospital in Al Madinah Al Munawwara. Dr. Majid, the mic is yours.
Thank you, Dr. Munira, and thank you, Dr. Isam, and all the scientific and organizing committee for inviting me. It's my pleasure to introduce my dear friend, Dr. Abdullah Barry. Dr. Abdullah Barry is a clinical assistant professor in University of Arkansas and consultant in hematology and oncology at King Fahad Specialist Hospital in Dammam. He will present the abstract of alpelisib plus fulvestrant in patients with hormone receptor positive, HER2 negative advanced breast cancer, biomarker analysis by next generation sequencing from the SOLAR-1 study. Dr. Ahmed, the mic is yours.
Assalamu alaikum. Thank you, Majid, for the introduction, Dr. Isam, Dr. Amirvet, for the invitation. Now, let me apologize. My internet has been unreliable in the last couple of days. So please inform me if if my voice is being disconnected, and that's exactly why I did not on the camera. I don't want any disruption. So my talk today will be alpelisib and fulvestrant in the SOLAR biomarker analysis by NG. So we all know that the indicated in pathogenesis of breast cancer and hormone-positive breast cancer specifically, and has shown an improved progression-free survival by adding a PIK3CA inhibitor, alpelisib, with fulvestrant in SOLAR-1 that led to improvement in progression-free survival. I'm not going to go through all the details of the pathogenesis of the PIK3CA, but this cartoon just summarizes quickly that there is an interaction between multiple pathways in the nucleus between MAP, K, PIK3CA, and obviously the other ER pathway. Now, Solar One has two arms, as you know. One of the arms was the PIK3CA mutated, and the other arm was the non-mutated or PIK3CA. We'll focus on the mutated arm here. And we also know that there was a primary analysis, a prospective analysis by real-time PCR for the mutated pathway. And that obviously was presented in the initial trial and the intention to treat analysis. There is also here a retrospective analysis, this time by CDX. The number of patients here is a little bit less, is 237 patients with PIK3CA, ultra comprehensive, and that what we will talk about. Now, what was interesting also that there was many co-mutations of genes with different genetic signatures between the PIK3CA wild type as well as the mutated. As you can see here, this is kind of difficult to see from distance, but there are certainly clear differences between the mutation and no mutation in terms of PIK3CA and associated alterations. There are also genes with more than 2% alteration, the change between the PIK3CA mutation and no mutation. Notably, MAP3K, FGFR2, and TP53 were more with the associated with PIK3CA mutation, while the wild type has RAD21 and FGFR1, for instance, and MEK are more associated with the non-altered type. They can in both arms. Interestingly enough, that the free survival probability was similar in both the PIK3CA mutated in the intention to treat analysis, as well as this analysis that we will present today, a median progression-free survival of 11 months, and the placebo was also 5.7 and 5.6 months. So really it gives a confidence that this is a replication of what has been already presented, but there is more to it that we will talk about. Now, one of the interesting aspects of looking at this abstract presentation was the tumor mutation. We know from lung cancer that there was an initial signal that mutation may be associated with more new antigens and immune therapy efficacy. It wasn't really the case there in lung cancer, and certainly it really doesn't matter how you define tumor burden. They are all favor alpelisib cutoff or larger cutoff. They're all favoring alpelisib compared to the placebo. What we find, or what I find interesting, is that the FGFR1 and FGFR2, and we know that these two mutations are associated with CDK4/6 inhibitor resistance, have not altered the efficacy of alpelisib. In fact, alpelisib improves the progression-free survival in both FGFR1 and FGFR2. But when other mutation like c-MEK and RAD21 are co-mutated with PIK3CA, then there is a hindering of the efficacy of alpelisib. In fact, alpelisib, addition of alpelisib here did not improve progression-free survival, and you can see from the blue curve that really it looks like the placebo in the case of co-mutation RAD21 and MEK with a PIK3CA mutation. Other genes showed a trend toward improvement of adding alpelisib in PIK3CA mutation are TP53, ASR1, CC3K, and ARIDA1. 1A. And those are also, we know that these can happen the post-CDK4 acquired or primary after CDK4/6 use. Now, there are certain downstream mutation in the PIK3CA, like in the mTOR and PTEN and AKT, and that we're trying to find some, treatment and clinical trial for those mutations. These mutations can actually affect the probability of progression-free survival, although there was a trend to improvement with the alpelisib, with the commutation, but there is no specific, really, no significant improvement, as you can see in the right side curve. Now, as opposed to the MAPK, it showed there is an improvement, more than doubling of the progression-free survival with the addition of alpelisib. The genes that are closely studied in CDK after the CDK4/6 inhibitor era, shown to be really related to the PTEN, NF1, CDK, RB genes, CDK2 and AB. All of these have shown to be to induce resistance to CDK4/6 inhibitor, and there was a significant clinical benefit with the addition of alpelisib. The median progression-free survival was 7.7 months compared to 3.8 months in the placebo. So, in summary, alpelisib has shown a clinical benefit regardless of the status of mutation in certain pathways, including MAPK and CDK4/6 inhibitor resistance. There is an improvement with the FGFR1 and 2, which, as we mentioned earlier, associated with CDK4/6 inhibitor resistance. In the MYC and RAD21 mutation, there is limitation of the benefit of alpelisib. The clinical benefit was consistent, irrespective how you put the cutoff for tumor mutational burden. Now, this is a hypothesis generation or generating present. It will help us improve the clinical trials in the future and should not be the basis of patients in the clinic today. Thank you very much.
Thank you, Dr. Ahmed, for the nice presentation. Now I handle the mic to Dr. Aisha Harbi to introduce the next speaker.
Okay, well, thank you, Dr. Majid. Our next speaker will be well-known Dr. Ala Qandil. He's a well-known in oncology field. He's a professor of clinical oncology at the Alexandra School of Medicine. That he will present analysis from Keynote 522 about effective survival by residual cancer burden after a new adjuvant of pembrolizumab with chemotherapy versus placebo with plus chemotherapy for early triple-negative breast cancer. Exploratory analysis from Keynote 522. Welcome, Dr. Ala. You are muted, Dr. Ala. Dr. Ala, we cannot hear you. You are muted.
Can you hear me now?
Yeah, go ahead.
Okay. Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Aisha, for your kind presentation. It's my pleasure and honor, and I'd like to thank the organizing committee for giving me the opportunity. Can I have the slides, or should I present them from my computer, please? Is there anyone from the IT?
You can share your slide, Dr. Ala.
Okay, I will do. Sorry for that delay. I thought that they will be presenting the slides, but anyway, I already opened the file of the slides.
Okay.
Dr. Aisha, can you see my slide
No.
now?
Just pressing share screen.
To share screen.
Yeah.
Yeah, I will try to do that, but I can't find it. But anyway, I'll find it immediately.
Yeah, it's clear now.
Clear now. Okay.
Yeah.
Doctor,
Yeah.
share our slide.
Hmm?
Share our slide, Doctor.
Okay. Well, I have a message telling me you cannot start screen sharing.
Okay, we'll ask if you can share from there.
The other participant is sharing.
Share screen, Doctor.
Okay. حاضر. Okay. Can you already see my screen now?
Yeah, it's clear.
Already mentioned by dear chairman that we'll be discussing a pre-specified analysis of the 5T2 22 keynote triple negative breast cancer treated with neoadjuvant pembro plus chemotherapy. As I guess everybody is aware that the main results of the primary analysis of the keynote 522 told us that this is actually telling us that there is a primary analysis showing neoadjuvant pembro statistically significant and clinically in pathological complete response. And in that trial, complete pathological response was pre-specified as component allowing presence of DCIS and disease after the neoadjuvant. Also, the neoadjuvant pembro plus chemotherapy followed by statistically significant and clinically meaningful improvement in event-free survival. For all of the above, the FDA and EMEA have approved pembro in the combination specified with chemotherapy as neoadjuvant treatment and then continued adjuvant therapy for triple negative patients, high risk early stage disease. So the objective of this analysis, the most recent one presented at ASCO 2022, was to look at the relationship with the so-called residual clinic to evaluate the event-free survival by 0, 1, 2, and 3. And there are different analysis considerations as mentioned in the lower part of the slide, with a median follow-up duration of nearly 40 months. To remind everybody, this is the design of the main trial, where patients were randomized into 2-to-1 randomization between the investigational arm that contained the pembro with chemotherapy, as opposed to the standard treatment arm, which is chemotherapy plus placebo. And these are all eligibility criteria telling us what or who were the patients included in the trial. Again, there was another 1 to 9 cycles of adjuvant pembro for the patients who were specified in the investigational arm. This is the summary of analysis population, just concentrated the lower part of the slide, where analysis population included intent to treat 784 patients in the investigational pembro arm, with 783 eligible for safety evaluation. And on the other side, on the placebo, non-pembro containing arm, there was an intent to treat population of 390, and safety evaluation took place in 389 patients. This is the baseline characteristics of the intent to treat population. This is actually a relatively young age population, as you would expect with the triple negative breast cancer patients, roughly a median of 49 years of age. Good performance status was there in about 13%, 12.6% respectively. PD-L1 was positive in about 80-something% in both arms, and carbo was scheduled according to the treatment specified by the treatment physician, either weekly in about 57% of the patients or Q3 weekly in 42% of the patients. The majority of the patients, or 3/4, was T1, T2, and T3, T4 was only in 26%. Node positive was there in about half of the patients, node negative in the other half of the patients. And that was already shown, telling us that the PCR rate was significantly improved in favor of the pembro arm. As you can see, the hazard ratio is 0.63. This means about 37% improvement, and numerically 84.5 at 3 years and 76.8 at 3 years, respectively, between the pembro and the non-pembro containing regimen. This is actually the prevalence of the residual cancer burden categories in all patients. As you see, that mainly those are the patients who achieved complete pathological response, were 63% in the pembro, only 56% in the non-pembro. And within the category residual cancer burden 1, you can see actually other numerical differences between the pembro and the non-pembro in the blue and the violet colors, category 2 and category 3. But more importantly, when you look at the hazard ratio for the this pre-specified analysis in terms of event-free survival according to the residual cancer burden, we find an overall benefit for those patients with, as the same I already mentioned, 0.63 hazard ratio, 37% improvement in the overall intent to treat population of the patients. In 0.7, if you consider only 0, if you collectively look into the category residual cancer burden 1, which is actually meaning there is a good amount of disease still left, so the hazard ratio was not meaningful. Only 8% of the patients would, and the data was not statistically significant. But interestingly enough, residual cancer patients who have category 2, which is more than category 1, had a good hazard ratio. About 48% of the patients, it might be an incidental finding in the trial. And as you would expect, residual cancer burden 3 did not have any benefit of the addition of pembro. Actually, it was towards the other side of the non-pembro. So this is the category 0, the complete pathological response, already 0.7, 30% improvement. And in 1.92 hazard ratio, only 8%. 0.52, this is only the same data, but in graphical form, hazard ratio of 0.52, meaning 48%. And in cancer burden 3, there's no improvement whatsoever. Most importantly, if you look at the distant recurrence rate, with the first event-free survival event by residual cancer burden category, you would see a numerical improvement, statistically or not significantly. This is another issue for the patients who were in the investigational arm containing pembrolizumab. However, this is something that needs more time to tell. We need more time to evaluate actually the rate of distant recurrences in this pre-specified analysis. And for the above, the summary and conclusions told us that there is an association of increased residual cancer burden score with worse event-free survival, and this is already known. And among patients with residual disease, there was a lower percentage of patients in each residual cancer burden category in the pembro group, already mentioned before. An addition of pembrolizumab resulted in a fewer event-free survival in residual cancer patients with category 0, 1, 2, and the benefit was most pronounced in residual cancer burden 2, and I don't have any explanation for that. I think time will give us more explanation and understanding of this finding in the study. Taken together, these results already indicate that the event-free survival benefit with from pembro extends to patients who do not even achieve complete pathological response. So we should not only look at the complete pathological response rate, though we know that it's an important surrogate in triple-negative patients. We should also still look that there would be benefit from the patients who end up with no complete pathological response and some residual disease in category 1 and category 2, but not in category 3. And by that, these are the acknowledgements. And I'd like to thank you very much for giving me the opportunity. Thank you.
Well, thank you, Prof. Ala. Now we'll move the mic to Dr. Munira.
Abdullah Medical City, and he will speak about destination for Dr. Samani. Welcome, and you may start your presentation.
I hope you can hear me, Dr. Munira, now. Is it clear?
Yes, yes, your voice is clear.
Okay. Thank you very much, Dr. Munira, and I would like to thank the all organizing team for the invitation and the opportunity to join this meeting. And I would like to thank especially Dr. Assam Moshe, Dr. Mirvat Mahous, and all colleagues in the organizing team. So today, I have to talk about an important trial. In my opinion, this is a practice-changing trial, which is DESTINY-Breast04. This trial is addressing an important question. They are looking for the benefit of trastuzumab deruxtecan versus treatment of physician choice in patients with HER2-low advanced or metastatic breast cancer. As you know, traditionally regarding the HER2 status, patients with breast cancer are classified into two broad categories. HER2 positive, which is about 15 to 20% of patients, and HER2 negative, which is the remaining patients. HER2 negative is usually immunohistochemistry 0, +1, or +2, but FISH negative. But recently, we have an interest in classifying those patients into three categories: HER2 positive, HER2 negative, and the new category, which is HER2 low, which is patients with immunohistochemistry +1 or +2, in addition to being FISH negative, which is about 50% of patients. Why this is the evolving interest? Because recently we have a new group of medication that have important activity in the category of HER2 low breast cancer. And you know, I'm sorry, the majority of HER2-low breast cancer, as you can see in this diagram, are usually hormonal positive, and we have few hormonal negative HER2-low breast cancer. So after failure of the standard of care of advanced hormonal positive breast cancer, usually we have several treatment options like everolimus plus hormonal therapy, or alpelisib plus fulvestrant, and then later on you can give additional hormonal therapy or chemotherapy. But we have learned from recent data and recent real-world data that after failure of CDK4/6 inhibitor in the first line, we have limited treatment outcome. And in general, the BFS in those patients in the real-world data is about 3.6, 3.7 months of median BFS. And we have some better outcome with the use of alpelisib. However, not everyone is candidate for alpelisib for a variety of reasons. And even the outcome of chemotherapy in the later line is much less, is not great. So we are in an area of unmet need of after failure of CDK4/6 inhibitor in patients or the category of who are being recently classified as having hormonal positive HER2 low or even triple negative but HER2 low, as we know from our real world data and even my own experience. So that's why we have to look carefully to this important study, the DESTINY-Breast04. This is a design of the study. They recruited patients who have advanced metastatic breast cancer, who are classified as having HER2-low disease. And those patients should receive at least 1 or 2 prior lines of chemotherapy in the metastatic setting, and they allow the use of previous hormonal therapy if they are hormonal receptor positive. Those patients were randomized into 2-to-1 randomization between the control arm, which is treatment of physician choice of chemotherapy, and they allowed the use of variety of chemotherapy agents like capecitabine, erlobalin, gemcitabine, Bacli, and nab-paclitaxel, versus the experimental arm, which is trastuzumab deruxtecan. And the primary endpoint is BFS by central review in hormonal receptor positive, and they have a variety of secondary endpoints, as you can see in this diagram. And this is the method of statistical testing. It is in a hierarchical way. They look first so the BFS and hormonal receptor positive, and if found to be significant, they move to BFS in all patients, including hormonal receptor positive and hormonal receptor negative, and then overall survival in hormonal receptor positive, and then overall survival in all patients. And this is a patient disposition. They screened more than 700 patients, and the patients who were recruited are 557 between trastuzumab deruxtecan and treatment of physician choice. What's remarkable here, if you look to the number or the percentage of patients ongoing on the treatment at the time of this analysis, it is 15% in patients in the experimental arm compared to only 1.7% in the chemotherapy or the control arm of treatment of physician choice. So if we look to the baseline characteristics, they are more, in general, they are balanced between the two treatment arms, but here I need to highlight some points. First, patients who were classified initially to have +1, all of them are HER2 but +1 patients, about 60% compared to about 40% or +2 but FISH negative. Another point that we need to highlight is the majority of those patients, as expected, about 90% are hormonal receptor positive and about 10% are hormonal receptor negative. And we have few patients who have baseline brain metastasis. The next point that I need to highlight from baseline characteristics, we need to look for the prior number of prior lines of therapy. So this, in general, those population included in the study are heavily pretreated. About 2/3 of patients, roughly, we can say that they received the 3 lines or more, including, of course, chemotherapy and hormonal therapy. And if you look to the number of prior chemotherapy, if we stick to the chemotherapy, 60% receive 1 line and more than about 37 to 40% receive 2 lines of chemotherapy before. The point that I need to highlight as well, that the majority of patients who are hormonal receptor positive received the previous CDK4/6 inhibitor. 70% of patients receive CDK4/6 inhibitor in first line. Moving to the results, very impressive results. If we look to the primary endpoint, which is the PFS, for the PFS in hormonal receptor positive, which is a primary endpoint, we have clinically meaningful and statistical significant improvement in the PFS with a hazard ratio of 0.5 in favor of the TDXT, with absolute difference in median PFS of 4.7 months. If we move to the PFS in all patients, again, the same level of significance with a hazard ratio of 0.5. Very impressive results, actually. If we move to the second endpoint, which is overall survival, it remains significant as well, both in the hormonal receptor positive and even in all patients, including hormonal receptor positive and negative, with a hazard ratio of 0.64 in both analyses in favor of TDXT, where absolute difference in overall survival, median overall survival of more than 6 months, 6.4 and 6.6 months, as you can see in this diagram. Very good results in favor of the experimental arm. In an exploratory analysis, this is not one of the endpoints, but when they looked for the PFS and overall survival in HER2 but hormonal receptor negative category, again and again, this is going with the overall direction of the study. We have significant improvement in terms of PFS and overall survival with a hazard ratio of 0.46 and 0.48 respectively, as you can see. Moving to the subgroup analysis, clearly, across all subgroups, we have benefit in favor of trastuzumab deruxtecan. And if we highlight some important subgroup, if we look to the being previously treated by CDK4/6 inhibitor or not, the same magnitude of benefit generally. And even if you look to patients having visceral metastasis, they derive a good benefit as well, similarly to patients who did not have visceral metastasis at baseline. So the benefit is consistent across different subgroups. If we look to an important endpoint as well, which is overall response rate, we have a very good response rate with the trastuzumab deruxtecan arm, more than 50% response rate. Please remember that this is a heavily pretreated population of patients, and more than 2/3 received 3 or more lines of previous treatment. So this is actually a good achievement to have this response rate, this level of response rate with trastuzumab deruxtecan in this population of patients. Moving to the safety analysis. In general, nothing new, no new signal regarding the toxicity with trastuzumab deruxtecan, but in general, we have somewhat more nausea and vomiting compared to the control arm, but less neutropenia. But in general, there is no new safety signal. If we look to the overall number of grade 3 and 4, grade 3 plus toxicity, it is lower in the trastuzumab deruxtecan compared to the control arm, as you can see. And the most common cause of treatment discontinuation was pneumonitis and interstitial lung disease in trastuzumab deruxtecan, about 8%, while peripheral neuropathy was the most common cause of treatment discontinuation due to adverse events in the control arm. And if we look to some toxicity of special interest like having pneumonitis or interstitial lung disease, the level of this toxicity was about 12% in the trastuzumab deruxtecan, which is not far from the previously reported level in previous trials with trastuzumab deruxtecan, like Destiny 3, which was 10%, and Destiny 1, which was 15%. But the majority of these events was grade 1 and 2 toxicity, and even regarding the cardiac toxicity was of low frequency, as you can see in this diagram. So anyway, in conclusion, we can say that trastuzumab deruxtecan in this category of advanced HER2-low metastatic breast cancer, we can say that we could achieve with this medication a statistically significant and clinically meaningful improvement in PFS and overall survival compared to treatment of physician choice of chemotherapy. And the magnitude of benefit was consistent across different subgroups, even in patients who were previously treated with CDK4/6 inhibitors, where we know that after failure of those agents, we have limited treatment outcome. But with this new medication, we have very good treatment outcome. There is no new safety signal with the trastuzumab deruxtecan in this study. And according to the authors, and this is, I will share the same opinion with them, we can say that this is new practice-changing study, and it may set trastuzumab deruxtecan as a new standard of care in this population of patients. Thank you very much for your kind attention.
Thank you, Dr. Thank you, Dr. Sharif, for your presentation. It's my honor and pleasure to introduce our next speaker. Our next speaker is our president in the Saudi Oncology Society, Dr. Mita Bergheri. Dr. Mita Bergheri is a consultant medical oncology and assistant professor in King Saud bin Abdulaziz University for Health Science. He's also the head of the medical oncology department in Princess Noura Oncology Center in National Guard Hospital in Jeddah. He will present for us the data of TROPICS-2 trial for the trastuzumab govitecan versus treatment physician choice in patient with hormone receptor positive HER2 negative advanced breast cancer. Dr. Mita, the mic is yours.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Thank you so much, Dr. Majid, for your kind introduction. Is it clear, the sound?
Yes.
Yeah, and also I would like to extend my thanks to Dr. Isam Murshid, Dr. Mirfet Mahrous, as well as Dr. Talib Bouhega for their kind invitation. So I have been tasked over the next 15 minutes to discuss with you the TROPICS-02 with the primary result of this randomized phase 3 study of sacituzumab govitecan versus treatment of physician choice in patient with hormone receptor positive HER2 negative advanced breast cancer. So as you know, the breast cancer is a leading cause of cancer death, and the hormone receptor positive HER2 negative is the most common subset, representing approximately 70% of this disease. And for metastatic hormone receptor positive breast cancer, the international guidelines recommend sequential endocrine therapy, starting with first-line endocrine treatment in combination with CDK4/6 inhibitors. And when resistant to the endocrine treatment develops, sequential single-agent chemotherapy is recommended. but it is associated with sequentially declining efficacy as well as increased toxicity. So with this limited chemotherapy options in later lines setting, there is remain a high unmet clinical need, and the TROPiCS-2 is a global randomized open-label multi-center phase 3 trial in the later line setting for patients who have been heavily pretreated with prior endocrine treatment, with prior CDK4/6 inhibitor, and with prior chemotherapy for hormone receptor positive, HER2 negative metastatic breast cancer. And the sacituzumab govitecan is the first in-class antibody drug conjugate directed to the TROP2, which is a transmembrane calcium signal transducer linked to tumor progression and poor prognosis that is highly expressed in approximately 80% of patients with breast cancer. And the sacituzumab govitecan is approved, as you know, for patients with metastatic triple-negative breast cancer who have received 2 or more therapy with at least 1 line given in the metastatic setting. And in a single-arm phase 1/2 study, the sacituzumab also showed encouraging clinical activity in 54 patients with previously treated metastatic hormone receptor positive HER2 negative breast cancer. The objective response rate by the investigator assessment was 31.5%, and in patients with previously exposed to CDK4/6 inhibitor was 25%. The median PFS was 5.5 months, and the median OS was 12 months. And this study indicated that the sacituzumab could be effective for patients with previously treated metastatic hormone receptor positive breast cancer. So the TROPiCS-2 enrolled patients with metastatic or locally recurrent inoperable hormone receptor positive HER2 negative breast cancer. Patients were required to have received at least 1 endocrine therapy, 2 to 4 lines of chemotherapy for metastatic disease. In addition, patient had to have received a CDK4/6 inhibitor and a taxane in any setting. The eligible patients were then randomized 1-to-1 to receive the sacituzumab govitecan day 1 and day 8 of a 21-day cycle, or treatment of physician choice, including chemotherapy of capecitabine, vinorelbine, gemcitabine, or erbuline. Stratification included visceral metastasis, endocrine treatment in the metastatic setting for at least 6 months, and a number of prior lines of chemotherapy. The primary endpoint was PFS by blinded independent central review, and the secondary endpoint included OS, response rate, duration of response, clinical benefit rate, patient-reported outcome, and safety. Assuming a hazard ratio of 0.70 for the primary endpoint of PFS, 350 events were needed to detect a statistically significant PFS difference between treatment group at 2-sided alpha of 0.05 with a 92% power. For the first interim analysis of the overall survival, 272 events were targeted with a 0.036 alpha expected to be spent based on the Landemit alpha spending function that approximated a BOK approach. In the testing hierarchy, the overall survival would be formally tested if the PFS was statistically significant, followed by the objective response rate, and then quality of life outcome if each prior endpoint in the hierarchy was significant. And this presentation at the last ASCO actually focused on the final analysis of the PFS and the primary endpoint of the first interim analysis of overall survival. The second interim and final analysis are planned for the overall survival, and for this analysis, the median duration of follow-up is 12.2 month period. So 543 patients were enrolled, 272 patients in the sacituzumab arm, 271 patients in the chemotherapy arm, and in total 99% of the patients in the sacituzumab arm and 92% in the chemo arm received study treatment. And at the data cutoff of January 3rd, 2022, 18 patients in the sacituzumab arm and 4 patients in the chemotherapy arm remained on the study treatment. And the majority of patients in both arms discontinue their treatment due to disease progression. The demographic and baseline characteristics were generally well balanced across the treatment group. And in the intent to treat population, the median age was 56 years. 95% of the patients have visceral metastasis, and the median time from the initial metastatic disease to randomization was approximately 4 years, and patients were heavily pretreated, having received a median of 3 prior line of chemotherapy in the metastatic setting, with a range of 0 to 8 in the sacituzumab arm. The enrollment of 9 patients who had received less than 2 or more than 4 prior chemotherapy regimen for metastatic disease was discovered during the study monitoring, and these 9 patients are included in the intent to treat analysis. 86% of the patients had received endocrine treatment in the metastatic setting for at least 6 months, and 40% of the patients had received CDK4/6 inhibitor for more than 12 months. Approximately 3/4 of participants received the treatment in the adjuvant setting and 1/4 in the neoadjuvant setting, and all patients had received the treatment for advanced or metastatic disease. And in line with the study inclusion criteria, nearly all patients received the prior CDK4/6 inhibitor and endocrine treatment in the metastatic rather than early stage setting. The most common prior chemotherapy agent in the metastatic setting were capecitabine, paclitaxel, and eribulin. This study met its primary endpoint with a statistically significant improvement in PFS by independent review. The median PFS was 5.5 months in the sacituzumab arm, 4 months in the chemotherapy arm. The hazard ratio was 0.66 with a p-value of 0.003, corresponding to 34% relative improvement in disease progression or death. And a subset of these heavily pretreated patients had rapid disease progression in the first 2 months while they are on treatment. Therefore, the investigator analyzed the PFS at several key landmark time point. The Kaplan-Meier curve separated early and were consistent over time, with a higher proportion of patients alive and progression-free at all landmark time points. The PFS rate for the sacituzumab arm versus chemo were 46% versus 30% at 6 months, 33% versus 17% at 9 months, and 21% versus 7 months at 12 months. And the investigator also performed a subgroup analysis for the PFS based on the stratification factor and other predefined subgroup. And the PFS benefit for sacituzumab versus chemotherapy was consistent across these subgroup, including patients with visceral metastasis, patients who had received 3 or more lines of chemotherapy in the metastatic setting, and 4 patients aged 65 years or older. And in the first of 3 planned analyses, the median overall survival was 13.9 months in the sacituzumab arm and 12.3 in the chemotherapy arm, with a hazard ratio of 0.84 and a p-value of 0.14. These data are not yet mature and further follow-up is ongoing. And the objective response rate by the independent review was improved for the sacituzumab versus chemo at 21 versus 14%, with an odds ratio of 1.63. 2 patients in the sacituzumab arm and no patient in the chemotherapy arm achieved complete response. And similarly, the clinical benefit rate was improved for the sacituzumab versus chemotherapy at 34% versus 22%. And because the overall survival was not statistically significant, the response and the clinical benefit were not formally tested, but the nominal p-value are 0.03 and 0.002 respectively. The median duration of response was longer in patients treated with the sacituzumab versus chemotherapy, with the duration of response of 7.4 months versus 5.6 months. In regard to the safety, overall, the safety profile of sacituzumab was consistent with that observed in previous study. In the safety population of patients who received at least 1 dose of study treatment, discontinuation due to treatment emergent adverse event was low, with 6% for the sacituzumab versus 4% for chemotherapy. The most common treatment emergent serious adverse event were diarrhea, febrile neutropenia, and neutropenic colitis for the sacituzumab govatican, and febrile neutropenia, pneumonia, nausea, and shortness of breath for chemotherapy. There were 6 deaths due to treatment emergent adverse event in the sacituzumab arm and none in the chemotherapy arm, and only 1 death, septic shock, due to neutropenic colitis was considered by the investigator to be treatment related. The other 5 deaths included COVID-19 pneumonia, pulmonary embolism, pneumonia, nervous system disorder, and cardiac arrhythmia. And upon detailed review of the treatment emergent adverse event leading to death, there was no pattern identified specific of mechanism or etiology to the treatment drug. The most common treatment-related adverse event of any grade with sacituzumab versus chemo were neutropenia, diarrhea, and nausea, and the most common grade 3 or higher treatment-related adverse event were neutropenia at 51% versus 38%, and diarrhea at 9% with sacituzumab versus 1% with chemotherapy. The frequency of treatment-related febrile neutropenia was similar between the 2 treatment arms at 5% for sacituzumab and 4% for chemotherapy. There was no event of interstitial lung disease in the sacituzumab arm, no treatment-related adverse event for heart failure or left ventricular dysfunction in either arm. The patient-reported outcome were also assessed and using the European Organization of Research and the Treatment of Cancer Quality of Life questionnaire. The median time to deterioration of global health status, quality of life, and fatigue was longer for sacituzumab compared to chemotherapy at 4 versus 2.9 months, 2.1 versus 1.4 months, respectively, with a nominal p-value of 0.05 for global health status, quality of life, and 0.007 for fatigue. The median time to deterioration for pain in the sacituzumab arm versus chemotherapy was similar at 3.7 versus 3.4. So in conclusion, TROPICS-2 study assessed the safety and efficacy of sacituzumab govitecan in patients with heavily pretreated hormone receptor positive, HER2 negative advanced breast cancer, previously treated with endocrine treatment, previously treated with CDK4/6 inhibitor, and at least 2 prior line of chemotherapy regimen for metastatic disease. The sacituzumab govitecan demonstrated statistically significant PFS benefit over chemotherapy with a 34% relative reduction in the risk of disease progression or death. A higher proportion of patients were alive and progression-free at all landmark time point, with 3 times as many patients progression-free at 1 year mark when treated with the sacituzumab govitecan compared to those who received chemotherapy. And at the first planned interim analysis for the overall survival, a non-significant numerical trend for improvement with the sacituzumab govitecan was observed, but these results are not yet mature, and further follow-up for overall survival is ongoing. The sacituzumab also demonstrated an overall health-related quality of life benefit over chemotherapy with delayed deterioration for fatigue and global health status quality of life scales. The safety profile of sacituzumab govitecan in TROPiCS-02 was consistent with the other prior study. And in conclusion, and as per the author, the sacituzumab govitecan demonstrated significant and clinically meaningful benefit in patients with heavily pretreated treatment, endocrine resistant hormone receptor positive, HER2 negative breast cancer. And with that, I would like to thank you all for your kind attention.
Thank you, Dr. Mita, for the presentation. I will handle the mic to Dr. Aisha Al-Harbi.
Well, thank you, Dr. Majid. Now we'll move to the abstract discussion. As Dr. Walid apologized for some reason. So our next speaker will be Dr. Jahil. Jahil, he's a professor of medical oncology at University of Sorbonne and medical practitioner in the Department of Medical Oncology at Tenon Hospital, Paris. Is also director of University Institute of Cancerology, Sorbonne University, that he'll present about the practice of changing abstracts. Welcome, Dr. Jahil.
Thank you very much. I hope you can hear me. First of all, I would like to thank all the scientific and organizing committee for this invitation. It's always a pleasure. Thanks also my colleagues that have presented very nicely all the abstract, and a special thank to Mervat Mahrouz, Dr. Mervat Mahrouz, that invited me personally. So in the next I will say 20 minutes, I will go through all the different abstracts and try to look what are the key relevant points that will make us changing our practice regarding the future of treating breast cancer. And I have also put the abstract regarding the ovarian cancer. First, in metastatic breast cancer, we have several abstracts that were presented and discussed. And the first one was, in fact, the TROPiCS-02 that was presented. You know very nicely, it was presented a few minutes before the design of this trial. And sacituzumab govitecan, which is a standard of care in triple negative, was considered also to be potentially a very active drug in hormone receptor positive disease, metastatic one, when the patient could not receive more than overthink that chemotherapy. And it was compared to what was considered to be treatment of physician choice standard between capecitabine, vinorelbine, gemcitabine, and eribulin. I will not go through all the consideration out of first one, that this is the first interim analysis. It's an important fact. However, you will see that even if it's an important fact, I think it's potentially also an important fact for the conclusion that we might have regarding the TROPiCS-02 trial. And I think that even if we have 272 events, the signal is still important, and we can probably conclude from my point of view. So the important thing regarding the demographic and the baseline characteristic, what were already mentioned by my colleague, is that you can see here that there was a prior exposure to CDK4/6 inhibitor here, and about 2/3 of the patient have received previously also chemotherapy in the neoadjuvant or adjuvant setting. And when you see the distribution of the prior therapy, 100% of the patients, so all of them have received in advanced and metastatic disease. And regarding the type of anti-cancer drug that the patient have received, they have 2/3 of them received taxanes, 1/3 eribulin, and 80% capecitabine. That means 3 of the drugs that were considered to be treatment of physician choice in this trial. Regarding the primary endpoint and the assessed PFS per RECIST criteria in the intended to treat population, the trial is positive. However, I will say that even if we have an hazard ratio of 0.66, the absolute difference is 1.5 months. I know that Professor Rugo was enthusiastic presenting the results. However, my perception here is that if the endpoint is increasing PFS, 1.5 months is really, I will say, a tiny benefit here. And I will not consider this benefit as particularly relevant from a clinical point of view to be considered as a new standard of care. Moreover, when you look at the overall survival analysis, even if the data is not yet mature, there is no signal actually. The hazard ratio is 0.84, and there is clearly no particular signal of overall survival benefit. So regarding the results of TROPIC-02, is it a changing practice actually result? I will say no, not clinically meaningful for everyday practice, and I will not considering the integration of sacituzumab govitecan in our everyday practice, to use this drug as part of our treatment strategy in hormone receptor positive metastatic breast cancer. The second trial is a trial regarding alpelisib, so the SOLAR-1 trial. This was presented by Dejan Juric. It's a nice trial, you know very well, but some of the countries worldwide have not considered alpelisib to be a standard of care and even not reimbursed regarding the absence of benefit on overall survival. So the trial was not here, and the presentation was not here to just try to convince us with new results regarding the efficacy, but particularly looking at some, I will say, bad prognostic parameter that might be associated with a mutation of PIK3CA population. So they were looking here in the planned exploratory biomarker analysis on the baseline tumor samples. What are the different differential genes altered in PIK3CA wild type or PIK3CA altered population? And as you can see here, there's a difference regarding the type of alteration when you compare the NGS sequencing. And interestingly, the important messages are that regardless of, I will say, alteration in the PIK3CA pathway, of course, alpelisib is effective. If you have an alteration of FGFR1 and or FGFR2, which are considered to be bad prognostic parameters in metastatic hormone receptor positive disease, again, it seems that alpelisib could work. Third, if you have an alteration on MYC, on ROD21, again, it seems that there is a benefit from addition of PIK3CA. And the same thing if you have an alteration on the MAP kinase pathway. And all these kind of results showing that in general, alpelisib remains in patients with altered gene implicated in CDK4/6 inhibitor resistance as part of an interesting strategy. But this is very important. I think that it will not change actually your practice because this data is relevant regarding the future development of the drug and the position of alpelisib. However, we don't have overall survival data and prospective trial dedicated to, I would say, pre-exposed patient to CDK4/6 inhibitors and clear resistance to CDK4/6 inhibitor that have progressed with PIK3CA mutation, with a demonstration of alpelisib benefit regarding on PFS and ideally on overall survival. The third trial I would like also to mention, and was already discussed and presented by my colleague previously, is the PALOMA-2 study. And I will say that I was, and not only myself, I think that the majority of the community were not very happy with the presentation we have. PALOMA-2 study is an important one, comparing palbociclib letrozole to placebo letrozole in patients that were not previously treated with endocrine treatment in metastatic disease. And the primary endpoint was PFS. We know that this trial was positive for PFS, but in an intended to treat population analysis, there is no overall survival benefit. And moreover, when you look at the median overall survival, we are close to 50 months, which is actually what you might expect regarding the overall survival benefit or the overall survival that the patient have in hormone receptor positive metastatic situation. So I will say that, yes, this drug is probably active. However, I will not consider that there is an overall survival benefit here. Interestingly, the authors and Richard Finn presented several subgroup analyses or particular analyses. The first one was a post-hoc sensitivity analysis excluding the patient with survival data not available, which is a little bit pity because usually when you are in a phase 3 trial, you need probably to have this kind of data. How it's possible not to have this amount of patients that do not have survival data. So it showed that there is a trend for benefit in overall survival, but that's only the thing you can see here. The second is that when they have combined the PALOMA-1 and PALOMA-2 overall survival analysis, they didn't find a very clear signal regarding the benefit because, as you see here, even if you cannot do a statistical analysis, the stratified hazard ratio is 0.93. The only thing that they have found potentially is that combining PALOMA-1 and PALOMA-2 with a subgroup of disease-free interval more than 12 months, so the what's so-called the endocrine sensitive, the addition of CDK4/6 inhibitors seems to do better comparing to here the letrozole or the endocrine treatment alone. So in fact, I will say that in this general presentation, you have to remember that we have over data, Mona Lisa 2, Mona Lisa 7, Mona Lisa 3, that are with ribociclib, all positive regarding the overall survival benefit. We have also data regarding abemaciclib, that might be interesting here regarding the overall survival data in combination with fulvestrant. And I will say that for me, clearly PALOMA-2 is a negative trial regarding the overall survival endpoint. And maybe it will change the practice, considering that if there is a potential difference between the CDK4/6 inhibitors, and if this explains the difference in overall survival results, so do we need to continue to use all this drug at the same level, or we have to be careful and considering that the drug that we have to use are mainly the drug with an improvement of overall survival? In the early breast cancer, we have two very important and interesting abstracts to discuss. The first one, as it was presented, the keynote 522 study design that you know very well here. Again, the presentation concerns more the patient that do not achieve PCR and the impact of pembrolizumab. You know that this is considered to be actually, regarding the neoadjuvant phase, a new standard of care in the triple negative disease with stage 2 or more, and that we have an impact in event-free survival with the addition of pembro to chemotherapy. We have an increasing rate of the different, pathological complete responses. However, when you look at the RCB distribution, in green one, you have the pembro-chemo group. In the red one, you have the placebo plus chemo. You see that there is an increasing prevalence, of course, of RCB1, 2, and maybe 3, when you have placebo plus chemo comparing to pembro plus chemo. But the amount and the number of patients here, be careful, is a very low one, because you have less than 50 patients in the RCB1 group treated with a placebo, about 80 patients here for the RCB2, and 25 patients in the RCB3. That means that the population that is mostly represented in the non-PCR population is the RCB2 population, who is a little bit more than 200 patients that you can see here. Interestingly, what they found is that the event-free survival analysis according to RCB categories were always, in general, in favor of potentially continuing pembrolizumab, and particularly in the RCB2 group. And when you look at the level of and the incidence of the distant recurrence in the RCB0, RCB1, RCB2, and RCB3, the huge difference is seems to be, again, with a statistical, I would say, importance in the RCB2 group. However, there is a general, out of the RCB1, a trend of decreasing the risk of distant recurrence when you continue pembrolizumab in the adjuvant setting, even if you do not achieve pathological complete response. So I will say that this result might be, for the first time, a kind of changing paradigm of using the absence of PCR as a surrogate marker. It's first time when the absence of PCR with one treatment is associated with the benefit on event-free survival continuing the same treatment in adjuvant setting. But we have to be careful, it's just exploratory. However, it might be a very strong signal, I will say, to say that, of course, immunotherapy do not act exactly as chemotherapy, and that in absence of PCR, the fact that you maybe stimulate the immune system and continue to stimulate the immune system might participate in a better control and in a better outcome of the patient that do not achieve PCR, even if you have used an anti-PD-L1 in the neoadjuvant phase. Probably that if we have just to retain and look at one trial that will change the practice, and it was already mentioned by my colleague, it's the DESTINY-Breast04. There is no discussion. This trial was very impressive regarding the results. I will go very fastly because it was very well exposed. Previously, trastuzumab deruxtecan comparing the treatment of physician choice, that one might be, again, capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. In HER2-low population, 1 or 2+ish negative, metastatic breast cancer, treated with 1 or 2 prior lines of chemotherapy in the metastatic setting. And the primary endpoint was PFS. When you look here at the distribution of the population, they were mainly hormone receptor positive. We have just a small group of 60 patients per arm that were considered to be triple negative. But in general, these patients were, as you can see here, hormone receptor positive. And the interesting thing is that you have patients that have been exposed in general for more or equal to 3 lines in 2/3 of the situation. And the number of median line was 2 lines between 0 and 7 and 0 and 6, according to the different arm. But they were heavily pretreated, I will say. And 70% of these patients for the hormone receptor positive population were previously exposed also to a CDK4/6 inhibitor. So looking at the PFS, there is no discussion. 1, regarding the hazard ratio, 0.5. 2, regarding the absolute benefit, close to 5 months. So it's clinically meaningful, it's statistically positive, and it's really important as part of the new strategy and the new standard of care in this situation. Regarding the overall survival benefit, same thing. As a ratio of 0.64, an absolute benefit of 6.5 months, which is really impressive, again, in metastatic situation, hormone receptor positive, within patients that have been for, again, 70% of them exposed to CDK4/6 inhibitors. If now you look at the exploratory endpoint in hormone receptor negative, so the previously so-called triple negative but HER2 low, The PFS benefit is closely the same, 0.46, with an absolute difference of 5.6 months. And the overall survival benefit is 0.48, with an absolute benefit of close to 10 months. Again, a small number of patients, about 60 patients in these two arms. But in general, what you have to, look is that all the results are going on the same direction with this drug in the HER2-low population, improving PFS, 50% risk of reduction of progression, and improving overall survival between 1/3 and half reduction risk of overall mortality during the period of follow-up. No subgroup that will not benefit. Again, response rates are impressively more important within trastuzumab deruxtecan arm treatment comparing to treatment of physician choice. You see the best changes here, and I will say yes, there is no discussion regarding the results of the DESTINY-Breast04. It's a trial that permit to define a new entity with appropriate treatment strategy, the HER2-low population. We can discuss about the hormone receptor negative HER2-low subgroup. However, my perception is that the results are very strong and very important for everyday practice changing. Last but not least, I will go very fast because it was not presented for the ovarian cancer to the Mita 23 trial. It was a trial addressing the question, this drug, the trabectedin, comparing to treatment of physician choice, paclitaxel, pegylated liposomal doxorubicin, topotecan, gemcitabine, or carboplatinum in a patient with a recurrent epithelium ovarian primary peritoneal or fallopian tube cancer with germline BRCA mutation or BRCA-NES phenotype. And they were stratified according to the platinum sensitivity, measurable disease, number of previous lines of chemotherapy, and BRCA mutational status. And just to say that the patient were well balanced regarding the two arms, when you look particularly in the previous PARP inhibitor exposure and the PARP inhibitor exposure after the Mita 23 trial. You see here the patient enrolled in the control arm that received, for the majority of them, 1/3 carboplatinum, 20% weekly paclitaxel, and for the other 3, pegylated liposomal doxorubicin, gemcitabine, and topotecan, approximately the same number, about close to between 10 and 50%. When you look at the end of treatment, and particularly let's look at the overall survival, which was the primary endpoint, with a median follow-up of 80.8 months, there is no difference. So there is no benefit of using trabectedin comparing to the standard of care here regarding the overall survival benefit. If you look at the PFS, they are very close, so there is no discussion that there is no superiority of one strategy to another one. And in some exploratory analyses of trabectedin versus platinum or non-platinum therapy, there is even a strong signal for carboplatinum superiority comparing to trabectedin or non-platinum. This is just an exploratory analysis, and I will just say that looking to these results, I'm not sure the Mita 23 will change our practice in ovarian and cancer that are BRCA mutated or with a BRCA-NES. The primary endpoint was not achieved, and it's not clear signal for me of added value regarding the overall survival data. I would like to thank you for attention, and I'm ready to discuss with my colleague and answer to any question if there are any. Thank you again for the invitation.
Thank you, Professor. It was actually very nice review. And I'm really grateful to the scientific committee of choosing such strong abstracts, most with practice changing in the field of breast cancer, and possibly, though we are not sure yet, in ovarian cancer. I'd like to ask all the speakers, please, whether physical or online, to join us for the discussion session. And the floor is open for any questions or any comment from the speakers on the other presentations and the significance of such presentations, please. Okay, let's start with Mita. Mita.
Yes. Can I ask a question, or you want to ask me?
Yeah, yes, please. No, just would like two things from the speakers, your input on the other abstracts, and if any questions, of course, definitely are most welcome.
I would like to ask to Mita. Hi, Dr. Mita.
Go ahead, Mita, please.
Yeah, thank you so much for everybody. And I will take this opportunity to ask Joseph, and I would like also to thank him. And it's always a pleasure to listen to him. So in regard the tropics 2, do you think that I totally agree with you that despite Hope Rogo mentioned that this is a clinically meaningful, and she looked at certain time landmark points. But do you think that if this drug was tested earlier after the endocrine and CDK4/6 inhibitor disease progression, but I mean without exposed to different chemotherapy, because between 2 and 4, do you think that the future of this medication can be positive?
I think, thanks for the question. I think it's a very important question, and I agree with you that probably here the strategy was pretty late regarding the way the drug was used. There is one uncertainty, it's about the hormone receptor positivity regarding the status, because some of these patients, we know when they are very resistant, we don't know if there is a part of triple negative or not, what happens. So there is some uncertainty about the biology of the tumor, and I will be more confident to use it earlier in a trial to try to demonstrate that it works or not, or to be sure. I'm personally convinced that this is a very interesting and important drug. However, we don't have to use it too late, because even my perception with an early access in the triple negative is that even if you achieve some responses, usually you have very quick progressions, and the earlier you will use it, the better you will probably control, and the longer we will control the disease. So I totally agree with your comments.
Rassam, can I ask a question, please?
Yes, please, Sharif, go ahead.
Yeah, thank you very much for the opportunity to join this a very nice meeting, actually. So we have now the data of Destiny-04, and included maybe a small population of triple negative breast cancer, but more or less they are overlapping the population that have been enrolled in the study of sacituzumab govitecan in triple negative study. The hazard ratio more or less is not, there is no big difference between both medications in the 2 studies. So maybe we don't have the head-to-head comparison, but your personal opinion, Prof. Gligorov, about if you have everything available in your hands, what would you prefer, the sacituzumab govitecan or trastuzumab deruxtecan? Would you prefer the study that's included a higher number of patients, or would you go with trastuzumab deruxtecan despite having little population of triple negative in the overall cohort of patients? What do you think?
So this is, I would say, $1 million question. So in fact, I'm convinced that trastuzumab deruxtecan works in HER2-low disease, regardless of the hormone receptor status. However, I will say that from one part, we have the sacituzumab govitecan trial, the ASCENT trial, dedicated to triple negative, with an important amount of patients that were included here, and no discussion about the benefit. On the other part, we have an exploratory analysis. So I will say that if I have the 2 options, I will probably prefer to use earlier the sacituzumab govitecan, but I will consider to re-challenge with trastuzumab deruxtecan after progression if the patient are HER2-low, regardless of the fact that the payload, the chemotherapy, is very similar, to be honest. It's the same family. However, even if it's the same family, the fact that it's not the same antibody might explain that we can have some responses, even if we have progression after exposure to the same chemotherapy initially. So my preferred choice, but this is just a personal opinion, is one sacituzumab govitecan followed by trastuzumab deruxtecan in the triple negative population, even if they are HER2-low, I will say.
The other point that I need to ask you, the study of Destiny-04 did that the patient received at least one previous line of chemotherapy. Okay, so given this very strong data, and the limited benefit of different treatment lines after failure of CDK4/6. So would you go immediately after CDK4/6 inhibitor with trastuzumab deruxtecan and without using prior chemotherapy, away from the sticking to the inclusion criteria of the study immediately after failure of CDK4/6?
To be honest, it will depend of the duration of the disease control with the CDK4/6 inhibitors. There was some different also abstract that were interesting, but I know it's impossible to select all the abstract. There was one very interesting abstract, and you have seen probably, called Maintain, addressing the question of re-challenging the patient with another CDK4/6 inhibitor after progression on first line. So I will say that probably if the patient seems to be with a very endocrine sensitive tumor, with a huge benefit of addition of CDK4/6 in first line, I will probably try after that to continue with an endocrine treatment strategy. And if it's possible, why not even include in trial with a re-challenge of CDK4/6? If I don't have a very good, I will say, control of the disease regarding the duration, and that means less than 1 year, for example, I will probably try to switch earlier. And why not, if the patient is HER2 low, to trastuzumab deruxtecan, even if it's not the indication actually.
Thank you.
Thank you. Any other?
Can I ask a
question?
question?
Comment? Yes, please go ahead, Yatale.
Prof. Joseph, I want your comment about Paloma 2 trial. Hi.
Hello.
Do you have any characteristic to use any specific oral CDK4/6 inhibitor as a first-line treatment for hormonal positive HER2 negative breast cancer, with the new data now show that overall survival in the Paloma 2 is negative?
So I will be provocative, I will say. If a patient comes to me for a second opinion and she's actually, let's say, on first line palbociclib, I will not change it, because it's always difficult for a patient to think that maybe the drug that was delivered was not the optimal one, etc. However, my personal opinion is that we have to follow the level of evidence that we have with the clinical trials. And actually, I'm initiating my first-line treatment in the majority of the patient with ribociclib and sometimes with abemaciclib. The only consideration I have is sometimes with a very fragile patients and regarding the profile of toxicity of this drug, because these three drugs have not, very well, as I know, exactly the same safety, I would say, profile. So in some situation, I will probably prefer to use palbo if it's easier for some elderly population, etc. But in the vast majority, I will try to use the drug that have demonstrated an overall survival benefit.
Okay. I'd like to maybe ask a question, and this is the input of Professor Gilgoff and as well as Mita, because we have discussed this before, and the floor is open for others. Now, the role of pembrolizumab in neoadjuvant breast cancer as well as in metastatic is very wide and being adopted almost as a standard in the guidelines. We know that the toxicity profile of certain agents, such as we learned from the past, everolimus in renal cell carcinoma, the toxicity profile was different than in breast cancers. Tend to be a little bit more toxic in terms of mucositis. So what's your input on the toxicity profile in patient receiving neoadjuvant pembrolizumab, and what are the limitations apart from economical for using such agent in the management of patient with early breast cancer or metastatic? So we'll start by Professor Gilgoff.
Thanks a lot. This is also a very crucial question, and I agree with you. The results from Keynote 522 are positive. There is no discussion. This is a new standard of care for me. There is no discussion. However, using pembrolizumab is not so easy in this situation. In the majority of the cases, the patient do not have particular, I would say, difficult toxicity or high-grade toxicity, but it could be, and we have to be very careful. We have to follow this patient very, very, very frequently regarding the immune adverse events. And the second thing, my perception is that because we begin with a combination of taxanes and platinum in combination with pembrolizumab, and particularly the weekly regimen, they are very, very, there is a high rate of fatigue. There are nausea and vomiting is not so, I would say, rare, even if you do the optimal things. And it's not easy for the patient, but the results are very impressive. I hope that in the future, we will probably try to demonstrate or succeed to demonstrate that the shorter duration of treatment with this type of combination might be enough, and we don't have to treat them 6 months. Because if we can shorten the duration with the same results, it will help the patient to have a better, I will say, quality of life. But it's not an easy way. I use it. I consider it as a standard, but I not consider it as an easy standard, to be honest.
Okay, thank you. Mita?
Thank you so much, Dr. Assam, for this question. And to be honest, I totally agree with Professor Joseph. So, and I have been discussing this with you in the last meeting. So I think the pembrolizumab is very effective medication in the neoadjuvant setting. And at the time of the surgery, we can see the benefit is mainly by those patients who has residual disease with approximately absolute benefit of 10 to 11%. And those patients who has no residual disease, there is a benefit, but to be honest, it's up to 2%. And I have used this medication in the at least 5 to 6 patients. And really what exactly Joseph mentioned, those patients during the first 3 months, they have a significant fatigue, and they may have also skin changes as well as some nausea. So when I review the surgical pathology report, I just show the patient the benefit for those who achieved complete pathological response. I mentioned to them that unfortunately we don't have a longer follow-up. And I tell them also that we are going now to have another clinical trial, which is addressing this question of adjuvant pembrolizumab in the adjuvant setting. Thank you.
Okay, thank you very much, Mita. I see two.
Question, Dr. Assam.
Yes, Aisha, go ahead, please.
Yeah, if you want to. For Prof. Joseph, regarding the keynote 225, if a patient receives PCR, do you need to add immunotherapy in adjuvant setting? This is the first question. And the second, patient that didn't receive PCR, we see the percentage of distal recurrence and local recurrence. So should we add another agent like Xeloda, especially if there is no toxicity with pembrolizumab? So your opinion about that?
So usually we try to follow what happens and what were the rules on the clinical trial. So I will say that if there is no particular issue with the safety, a big issue, I will continue if they achieve PCR, the pembrolizumab. However, I agree with my colleague and Dr. Mehtab that the benefit seems to be very tiny because you use for close to 1 year this drug, but the absolute difference is very, 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 very small. The paradigm and the paradox is that it seems more important if you do not achieve PCR, which is really for us a new concept. And this is probably due to the fact that we are not targeting the tumor, but we are targeting the microenvironment and the immune system. Addition of capecitabine, why not? But we don't have a clear demonstration. I agree that probably it will not increase the level of toxicity, but my first choice will be in triple negative to be sure that these patients have not BRCA mutated status, because if they have a germline mutation, then I will consider strongly to use olaparib in the adjuvant setting because of the result of the Olympia trial. For the other one, I don't know. You know that there are several trials that are actually ongoing with a lot of, I would say, discussion. Do we need to put on the control arm capecitabine with pembrolizumab? Nobody knows. But sometimes capecitabine could be also a little bit complicated in some patients, particularly when you look at when you go in, I would say, Middle East, and when you go in Asia, the phenotype of the different, I will say, cytochrome and other type of metabolism of the drug is not exactly the same. So I will be very, very careful with the addition out of data that are not reassuring. Even if you don't have a small phase 1 or 2 trials showing that the combination is easy to do, I will not do it comfortably in a population that might be cured, because the issue here is not, we are not dealing with metastatic disease. We are dealing with patients that are potentially cured. So I will not be very favorable to increase the rate of toxicity.
Thank you. Just we'll take the last 2 questions from the online, though one of them is not related to the meeting, but I'm going to answer it very quickly about the use of chemotherapy in pregnant women. Usually after the first trimester is relatively safe, and we try to avoid alkylating agents. In the first trimester, actually, you try to postpone it by doing local treatment apart from radiation therapy. And if it's not possible, then you discuss with your patient the possibility of termination of pregnancy. This is the general answer without any further detail. The second question, I will just address it to our senior colleague, Dr. Mita Bergheri, which is about the advantage of ribociclib after the overall survival. I do believe that this might be a little bit biased, and we have to investigate whether Novartis paid someone to ask this question. Thank you very much. Mita.
So thank you so much, Dr. Issam. So when we look at all the clinical trial in the first line setting, it is actually the ribociclib is associated with both progression-free survival and overall survival. And when we look at the palbociclib in the last ASCO meeting, the PALOMA-2, it's actually what I can say that the overall survival was not achieved. And there was really, I can tell you that there was some clinical, you can mention why. So if you will look at the patient who has disease-free interval of less than 12 months, you can see at the PALOMA-2 that there was approximately 22% of those patients were enrolled in this clinical trial, and there was nil in the ribociclib Mona-Lisa 2, and there was less than 2% in the Monarch 3. But when I will be faced by a patient in my clinic, I will tend to use the ribociclib because now it is associated with overall survival benefit. And I totally agree with Professor Joseph that the palbociclib can be used for certain patients, which might represent now less than 10%, those patients who are elderly, who has multiple comorbidity of diabetes, hypertension, morbid obesity, some drug interaction. I think palbociclib still can be used in those patient population. I hope I was not biased.
Thank you, Mita. I'd like to hear also the input of Dr. Sammani. Sharif?
I would share the same opinion with Dr. Mita that he just mentioned. Actually, we have accumulating data now that we have improvement in the overall survival with ribociclib in all 3 trials that address this indication in advanced breast cancer. And we have improvement in overall survival, at least in one of the 2 studies of abemaciclib in the metastatic setting. And if we move, but we don't have any improvement in overall survival with palbociclib in the metastatic setting. And even if we move to the early setting, we have with short-term follow-up, we have improvement, at least in terms of the invasive disease-free survival with abemaciclib. But in the 2 trials of palbociclib in the early setting, we don't have any signal of improvement up till now. So I think after having all this data and putting all of them in the context, we can say that the old story of saying that all CDK CDK4/6 inhibitors are equal. I think this is not valid currently. And I share the same opinion with Prof. Bologrov and Dr. Mita that we have some differences and we need to take this in account when choosing the first-line CDK4/6 inhibitor. We need to put overall survival in consideration, and mostly I will use ribociclib unless a patient having an issue regarding cardiac toxicity also.
Thank you, Sharif. Finally, I'd like to hear from Abdullah Barry if he's on.
I am on. I'm listening.
The same issue about after the survival advantage of ribociclib and the Paloma 2 update presented in the ASCO, what's your view on the use of the optimal use of CDK4/6 inhibitors in the kingdom, bearing in mind this result? Would this change your practice?
Actually, it would. I think I don't have much difference of what Mita and Sharif have already mentioned. You know, the body of data of overall survival is significant with ribociclib, along with you know, the maintain trial. If you also want to put it in mind, although it's phase 2, yeah, I think that one should consider the evidence-based practice with ribociclib/abemaciclib, but for those who have endocrine-sensitive elderly population, probably palbociclib is a good option. Thank you very much.
Thank you, Ahmed. And we had the opinion of Professor Gilglov about the same topic. Thank you very much for all the speakers and the chairpersons. Thank you. And I'm going to call this session for an end, and we will reunite here after 10 minutes or 15 minutes. 15 minutes break, and then we'll go ahead with the satellite symposiums. Thank you very much.
Thank you so
Thank
much.
you.
Thank you. Thank you. Thank you.
Bye.
من هنا خلاص. You.
طيب بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته مرة أخرى. Good afternoon, ladies and gentlemen. It gives me a great pleasure to introduce the next session, which is a satellite symposium. Sponsored by Pfizer. And with great pride and pleasure, I'll present the speaker, Dr. Hashim Al-Hashim. Hashim is the Senior Consultant Medical Oncologist at King Saud Medical City with a special interest in breast and gynecological cancer. And he's going to talk to us today about the real-world data of efficacy in the first-line treatment. Dr. Hashim, the floor is yours for 30 minutes, which includes the discussion, if any. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Isam, for this very nice introduction. A special thank for organizing a scientific committee and for Pfizer for inviting me for giving this talk. Actually, I was attending the previous sessions, and all the discussion I will present maybe is already discussed in the previous discussion, but I will present real-world data that was not discussed. So I was given a task to talk about from clinical efficacy to real-world effectiveness in first-line setting Reality X trial. This is my disclosure. So I will talk first about introduction about the idea of real-world data and what is the difference between real-world data and randomized clinical trial. So all of us, we know that randomized clinical trial is testing can the drug work or not, and to provide information the efficacy on a drug in a controlled setting. It's designed to show causality. Patients are randomly assigned to treatment or comparator. Selected patient population with strict inclusion and exclusion criteria in randomized clinical trial. It is a protocol-driven treatment in highly monitored control environments. Intervention is strictly enforced and standardized. And data derived from pre-specified protocol-defined uniformly assessed endpoints. And in randomized clinical trial, there's significant difference between sample population and real-world population, which limit its generability of the result in clinical practice. But real-world data, does the drug work and provide information on the effectiveness of the drug in everyday clinical setting. It is unable to determine causality in contrast to randomized control trial. But a patient here, as you know, they are not randomized. It tests broad patient populations, broad set of clinical relevant measures and outcome. It reflects routine clinical practice as intervention is at discretion of treating physician. Data derived from assessment of clinical judgment with variability in patient care and adherence, and bias may be introduced by prescribing pattern and lack of informed assessment and outcome. So what is the strength and limitations of randomized clinical trial and real-world data? For randomized clinical trial, as all of you know, its strength is robust study design to meet regularity and payer requirements. It is the randomization, minimize bias, and blinding hide assignment from investigator, participant, and assessor, and is well understood and accepted by stakeholders. What is the limitation of randomized clinical trial? It's significant difference between sample population and real-world population, which limits generalizability of the result. It is a relatively small sample size compared to real-world treatment population. The study endpoints often focus on efficacy and safety. Other concurrent outcomes are not investigated. It's harder to assess rare and long-term events. And as you know, it is very expensive to conduct and take long time. On the other hand, the real-world study, the strength of it tests broader and more representative population assessed over a longer time frame. allowing assessment of subpopulation and patient underrepresented in randomized clinical trial, including patients with comorbidities and co-medications, investigations of rare long-term event or outcome. It assesses broad set of clinical relevant measures and outcome. Also, it investigates questions that cannot be studied experimentally for ethical reason. And as you know, it is very, it is inexpensive relative to clinical trial and faster to execute. But it has its own limitations. On the other hand, it has absence of randomization and blinding, higher risk of bias and the presence of confounding factor, varying level of data availability and quality, and fewer standards around the study design lead to a range of robustness. So for that reason, we have this trial, PREALITY-X, which is palbociclib real-world first-line comparative effectiveness study extended, which was presented in ESMO Breast of this year. This study, the objective of it is to evaluate the effectiveness of first-line palbociclib plus aromatase inhibitor as compared to aromatase inhibitor alone in patients with hormone receptor positive HER2 negative metastatic breast cancer treated in the real-world clinical practice in the United States. It is retrospective cohort analysis of electronic health system using Flatiron Health Analytic database. It includes patient postmenopausal women and men 18-year-old and older with hormone receptor positive HER2 negative metastatic breast cancer, around 2,800 patients. The index date started from February 2015 till March 2020, with follow-up from index date till death or study end. In this trial, they found 1,300 patients allocated to palbociclib plus aromatase inhibitor and 1,500 patients allocated to aromatase inhibitor alone, with primary endpoint overall survival and secondary endpoint real-world progression-free survival. So this is a slide just show you an idea about Flatiron Electronic Health Record database, which include over 3 million patients, record 75% from community hospital and 25% from academic center, including more than 280 community cancer center and 7 major academic center. So it's very easy to extract data with very details from this Flatiron Electronic Health Record database. So before talking about real-world data, we have to understand two terminology. The first one is stabilized inverse probability of treatment weighting, which is a statistical approach increasingly used in the retrospective real-world study where randomization is not possible. Patients are weighted differently in the sample to create two cohorts that have balanced characteristics, enabling a fair conversion across the two arms. This stabilized inverse probability of treatment weighting is calculated using probability score, which is a probability of subject being assigned to a particular treatment, given a set of observed key covariates, for example, age or performance status or other, that may impact on this treatment decision. So in other term, they match the treatment based on inclusion and exclusion criteria of the randomized clinical trial. So this baseline characteristics of PREALITY-X database, and just a minute because my daughter is calling me in FaceTime. Sorry. Okay, so the patient characteristics after IBTW and probability score matching, we noticed that all groups were generally well balanced, including age, sex, ECOG performance status, presence of visceral disease, and the site of metastasis, interval from initial breast diagnosis till metastasis, comorbidities, and number of metastatic site and others. So what is the result of this trial? As I mentioned, the primary endpoint is overall survival. And as we can see clearly here, that overall survival was significantly longer among patients who received palbociclib plus aromatase inhibitor versus aromatase inhibitor alone before and after IPTW and propensity score matching. As we can see here, it's for unadjusted populations, 53 versus 40 month with a hazard ratio of 0.6 with significant p-value. For IPTW, hazard ratio 0.76 with significant p-value, at the same for propensity score matching with significant hazard ratio and p-value. This is overall survival by subgroup analysis for IPTW. As we can see, for all of these subgroup analysis, that is, the overall survival is consistent, favoring palbociclib plus aromatase inhibitor compared with aromatase inhibitor alone in all subgroup examined. In most of subgroup examined, and overall survival benefit were observed regardless of race and among patients with or without visceral and bone metastasis. Same for propensity score matching for all the subgroups. It is a consistent overall survival benefit favoring palbociclib plus aromatase inhibitor. What about secondary endpoint, which is a progression-free survival? Again, here we noticed that real-world progression-free survival was significantly longer among patients who received palbociclib plus aromatase inhibitor versus aromatase inhibitor alone before and after adjustment for with a significant hazard ratio of around 0.7 with significant p-value. The real-world data for second-line anti-cancer therapy in this trial. So almost 50% of patients in palbociclib plus aromatase inhibitor arm were still in first-line treatment versus 30% in the aromatase inhibitor alone arm. Around 50% and 65% of patients in palbociclib plus aromatase inhibitor group and aromatase inhibitor group alone respectively received second-line treatment, of which 40% and 50% respectively received subsequent CDK4/6 inhibitor. So what is the strength and limitations of this trial? So the strength of PREALITY-X trial, it is the large sample size drawn from an extensive database comprising more than 3 million patients, recorded from more than 280 community hospitals and 7 major academic centers. The Flatiron database capture and process detailed patient-level data, the availability of comparative control arm that allow comparison of treatment similar to randomized clinical trial after adjusting for a potential confounder, and follow-up time is sufficient to obtain median PFS and OS estimate for both treatment arm. The use of statistical techniques such as IPTW and propensity score matching to balance patient characteristics to address bias due to lack of randomization. But on the other hand, it has own limitation, and the limitation of PREALITY-X that the study is retrospective database study and cannot determine causal relationship. Disease progression was based on the treating physician clinical assessment or interpretation of radiographic or pathological result rather than standardized criteria, while the adjustment for biases were used to balance baseline and clinical patient characteristics. Unobserved variable cannot be fully addressed through this method. Some subgroup analyzed may not have sufficient power due to sample size, and finding presented here may not be generalizable to patient population not presented in Flatiron database. So the author conclusion, which is Hope Rogo in ESMO Breast 2022, she mentioned that the real-world comparative effectiveness study is the largest conducted in metastatic breast cancer to date, demonstrated that palbociclib plus aromatase inhibitor versus aromatase inhibitor alone was significantly associated with both prolonged overall survival with hazard ratio 0.76 and PFS with hazard ratio 0.7 in heterogeneous population of patients with hormone receptor positive, HER2 negative metastatic breast cancer. So these findings continue to support the first-line palbociclib plus aromatase inhibitor as standard of care of patients with hormone receptor positive, HER2 negative metastatic breast cancer. But recently we have data for overall survival for PALOMA-2 in ASCO 22 this year, a few weeks ago, that was presented and discussed by Dr. Taleb and the panelist with Dr. Murshid in the previous session. But I will just mention some of the discussant points that were mentioned in ASCO 2022. That we know that the outcome with the CDK4/6 inhibitor in first line for both CDK4/6 inhibitor, palbociclib, ribociclib, and abemaciclib, all of these 3 trials, they reach its primary endpoint, which is PFS, with almost similar hazard ratio of 0.5. More recently, we have a data about MONALEESA-2, which use letrozole plus ribociclib, which showed significant improvement of overall survival with a hazard ratio 0.76 with significant p-value. Also, we have MONALEESA-7, which tests ribociclib plus endocrine therapy and ovarian function suppression. Again, it reached its primary endpoint, secondary endpoint for overall survival with a hazard ratio 0.7. The third trial for ribociclib is MONALEESA-3, which tests the endocrine partner as fulvestrant. Again, it has a significant overall survival benefit. But keep in mind that they include only patients who relapse after more than 12 months after completing endocrine therapy. Let's go back to PALOMA-2. So this is, as all you know, that this is the study design of PALOMA-2. To include patients with no prior treatment for advanced disease, randomized to palbociclib plus letrozole versus placebo plus letrozole, with the statistical assumption for overall survival as secondary endpoint that the median OS will reach 34 versus 46 months for palbociclib plus letrozole. But unfortunately, the data from that presented in ASCO, it showed numerical difference, but there is no statistical difference for palbociclib plus letrozole. So why there are overall survival difference between these studies? So we have to understand the inclusion criteria for these populations. As we see here clearly that 22% of patients in PALOMA-2 trial, they have disease-free interval less than 12 months. But on the other hand, for MONALEESA trial, the disease-free interval less than 12 months ranging from 0% to 7% only. And when this is unplanned subgroup analysis for patients with disease-free survival more than 12 months, including PALOMA-1, which include also 35% of patients with disease-free survival less than 12 months. When they exclude these populations, we found there is hazard ratio 0.7 with improvement with improvement for survival from 45 months to 64 months. But keep in mind, we have limitations for this analysis. It is post-hoc analysis and definition of missing survival data. As mentioned by Dr. Taleb, there is almost 22% of patients we don't have survival data on them. So in conclusion, why are there finding difference? Possible that reflect a difference between the approved CDK4/6 inhibitor, but the trial was unpowered for endpoints. Both arms significantly outperformed expectations. Distinct patient populations, as mentioned, 22% of patients, they have DFI less than 12 months, and there is lack of prospective trial comparing the CDK4/6 inhibitor. But we have one trial, which is Harmonia trial. We'll compare ribociclib to palbociclib in HER2 enriched subtype, but we don't have one in HER2 negative. And we are awaiting the overall survival data from Monarch 3 trial. And thank you very much.
Thank you, Hashim. Thank you very much for the very nice and comprehensive presentation. The floor is open for discussion, if any, or just let me address some to you. Okay. You have beautifully explained the rationale of why the survival advantage was different in terms of using ribociclib versus palbociclib, though this is not, of course, a direct comparison between both. But would you elaborate more, especially in the point of that it was a secondary endpoint rather than being primary, and the significance actually between the difference of powering a study for the primary endpoint compared to secondary endpoint?
Yes, thank you very much, Dr. Hassan, for this very important questions. As you know that, yes, they are the same class, CDK4 inhibitor, all of them, the ribo, palbo, and abemaciclib. But we looked at the structure of all of these, we find some different structure, and this may be reflected by the side effect of these all CDK4/6 inhibitor. So this is one of the points, maybe the structural difference between them. Second point, the inclusion criteria and exclusion criteria for all this trial is different. As we see, there is 22% of patients, they have what we call it hormone resistance, and Paloma-2, that all of them they're excluded from other trial, but we cannot say it is because of only this reason, because we cannot compare trial to trials. The third point, I'm sure it was mentioned by Dr. Taleb, the missing data. After they analyze the trial, they do post-analysis for the missing data, they found in Paloma-2 there is improvement in for overall survival. So this is the three main points reflecting explaining the difference between real-world data and the Paloma-2 trial.
And another point worth mentioning, and I want your comment on that. You remember that the FDA have carried a meta-analysis of the three drugs together, and they found almost minor, if no, differences between them. So would you elaborate this, although this was before the publication of the survival advantage as secondary endpoint for the ribociclib?
Yes, as you mentioned, yes, there is a meta-analysis including, I think, more than 14 trials, including CDK4 inhibitor in different setting, including first line, and phase 2 trial, phase 3 trial, and clearly show there is no difference between all of these CDK4/6 inhibitor. Does the overall survival data presented recently will change the outcome? Possible to change the outcome of this meta-analysis, but not necessarily, because we know that the meta-analysis will eliminate some of the differences that included in the inclusion and exclusion criteria.
Okay. Thank you very much. Thank you, Hashim.
My pleasure.
And it's an honor having you as usual. Thank you very much. And I think now we'll move to the second satellite symposium, which is for Novartis. That's beautiful. It's like seeing the Al-Hilal and Al-Nasr competing, but of course, we don't know who's Al-Hilal and who's Al-Nasr, and we know who wins us all the time, getting, wow, the Major League for the third time. Now, without any further delay, as I said, a satellite symposia sponsored by Novartis, which is going to be presented online by Dr. Aisha Al-Harbi. Dr. Aisha is a medical oncologist consultant at King Fahd Military Hospital in Jeddah, and she is going to present to us the update on the survival data of ribociclib in HER2 negative hormone positive advanced and metastatic breast cancer. Aisha, you have 30 minutes, including the discussion. Please go ahead.
Sure. Thank you, Dr. Isam, for this nice introduction. And thank you also, Novartis, for giving me this opportunity to present this presentation. Actually, it changed the topic to this living longer and better in patients with hormonal positive, HER2 negative. So that's reflect that ribociclib does not only improve overall survival, but also it's maintain quality of life. I cannot move the slide. I just want the screen. I think the previous star is still sharing, so anybody can. Luminal breast cancer, we know luminal breast cancer is heterogeneous disease, and this heterogeneity shifts the tumor from early stage to metastatic stage. Based on this study that published in 2017, that we see less patient from luminal A shift to metastatic stage, more luminal B, and more HER2 rich. And to that, there is no different treatment recommendation based on this luminal subtype. And also we know that interesting subtypes has prognostic role in breast cancer. So we'll discuss later in this presentation the role of or efficacy of ribociclib in each subtype. Actually, all we know the CDK4/6 inhibitor mode of action. Just I would like to highlight the role of CDK4 protein in breast cancer. CDK4 protein play a role in breast cancer tumorigenesis and cell proliferation. And the level of CDK4 it's really highly expressed, more than CD6 in breast cancer. And inhibition of that kinase leads to block ability of cancer cell to proliferate and lead to the cell death. So in brief, available drug penetrates tumor cells and bind to and inhibit CDK4. So when should we add CDK4/6 inhibitor to endocrine therapy? Actually, for many years, we stuck with monotherapy, endocrine monotherapy that improved PFS in first line up to 16 months, and in the second line up to 8 months. Then after development and discovery of CDK4/6 inhibitor, PFS become higher to up to PFS 30 months. Actually, the benefit much higher, and when we use CDK4/6 inhibitor in the first line setting and reach PFS up to 35 months. So the best chance for optimal response in the first line setting. So CDK4/6 inhibitor in hormonal positive HER2-negative advanced breast cancer, all the international guidelines, society like NCCN, ESMO, and ASCO recommend to use CDK4/6 inhibitor in combination with aromatase inhibitor or with endocrine therapy as preferred first line option. CDK4/6 inhibitors for premenopausal and postmenopausal women with hormonal positive HER2-negative advanced breast cancer. Actually, we have 3 CDK4/6 inhibitor, ribo, MIBA, and palbociclib. All these 3 CDK4/6 inhibitor approved in phase 3 trial data study the efficacy of CDK4/6 inhibitor plus hormonal treatment versus hormonal treatment alone in both menopausal patients, and only one trial was in premenopausal patient, which is Melissa 7. And all these trials showed PFS benefits with hazard ratio almost near identical. It's about 0.5, and showed higher overall response rate, reach up to 60%. What about overall survival benefits? Overall survival, actually, it's reported in most of these trials. The most interesting and interesting part that the ribociclib trial, the 3 ribociclib trial, Melissa 2 and 3 and Melissa 7 showed overall survival benefits, both in first and second line setting. And if we move to the amibaciclib, also we see that Monarch 2 in second line setting with a combination of fulvestrant showed overall survival benefit. Still, we are waiting for Monarch 3 data. Regarding palbociclib, also in the second line setting, failed to show overall survival benefits. And also Paloma 2 data presented in this last 3 weeks in ASCO 2022 actually failed to show overall survival benefit, and explained in detail by the Dr. Taleb and Dr. Hashim and other speaker. So let's move to Melissa 2. This is the study design, Melissa 2, that studied the efficacy of ribociclib 600 milligram, 3 week on and 1 week off in combination with letrozole versus letrozole alone in postmenopausal patients, hormonal positive HER2-negative advanced breast cancer with no prior therapy were allowed, randomized 1-to-1 with primary endpoint was PFS and secondary endpoint of overall survival. Actually, it showed impressive overall survival benefits with 12-month improvement in median overall survival, and increased from 51 in the control arm to 63 months with combination ribociclib and letrozole with hazard ratio 0.76 and a significant p-value. Actually, the survival rates extend to up 44% at 6 years. And this is the subset analysis from Las San Antonio. Overall survival benefit was independent of metastatic site, number of site, and prior therapy. And this is the longest overall survival seen in the first-line setting. So overall survival benefit with ribociclib increased over time. If we see here the absolute improvement in overall survival at 6 years, about 12.2 months, and at 4 years, 5.7 months. So as we mentioned that the 6-year survival rate in patient with systemic ribociclib reached up to 44%. So what about the subgroup analysis? All the subgroup analysis patients achieved or delivered benefit from ribociclib. It was regardless of liver or lung involvement, regardless number of sites, and regarding de novo and non-de novo. Also, ribociclib delayed time to chemotherapy up to 1 year. It was from 38.9 months in control arm to up 50 months in ribociclib and letrozole arm with hazard ratio 0.74. So the improvement with ribociclib is about 11.7 months. So we know there is no specific biomarker apart from estrogen receptors to provide benefit of CDK4/6 inhibitor, as I mentioned, as part of estrogen receptor. If we see here a subgroup analysis of PFS based on biomarker, if we see here protein level at the site of protein level, RB16 and Ki67, we see that ribociclib treatment benefit was maintained regardless, irrespective to the protein level. And if we move to the gene expression, such as ESR1 and PIK3CA, we see still that ribociclib benefit is still maintained regardless if it's wild or mutant type. What about premenopausal patient? All the 3 CDK4/6 inhibitors are active in premenopausal patients regardless of endocrine partner, but the largest study and MONALEESA-7, it was specifically for patients who was premenopausal, that studied tamoxifen or aromatase inhibitor plus ovarian suppression agent plus ribociclib versus endocrine alone. And also Monarch 2 that include about 114 patients are premenopausal. It was in the second-line setting. Similar to that, Paloma 3 that also include about 100 patients are premenopausal, and also in second-line setting. All these 3 trials showed PFS benefits. So we'll move to the MONALEESA-7, as I mentioned, that studied the efficacy of ribociclib plus endocrine therapy plus ovarian suppression agent versus endocrine therapy in the first-line setting of premenopausal patient. So showed also overall survival benefits. It's median overall survival 58 in ribociclib plus hormone treatment versus 48 in the control arm with hazard ratio 0.76. 10-month improvements with ribociclib arm. And what about the endocrine partner? Overall survival to analysis showed also overall survival benefits regardless of endocrine partner, either to use aromatase inhibitor and tamoxifen. Actually, we'd like to highlight some point here that we don't recommend to use tamoxifen with ribociclib as the QTC prolongation was higher in such a group of patients. Also, delay time to the chemotherapy from 36 months in the control arm to 50 months in the ribociclib and the hormonal arm with hazard ratio 0.69. And also increased chemotherapy-free interval or free survival from 26 in the control arm to 42 with combination of ribociclib and letrozole with hazard ratio 0.66. Also, PFS2 showed the benefit from regarding the ribociclib, showed the benefit in PFS2. That means delay progression in the second line, in the next line treatment. With that, we see that in the ribociclib and letrozole, BFS2, median BFS2, it was 44 versus 31 in the control group with the ratio 0.68. So what about CDK4/6 inhibitor in second line setting? Actually, we have three trials, PALOMA-3, MONARCH-2, and MONALEESA-3, and I would like some differences between these trials. As we see in MONALEESA, we know that MONALEESA-3 that include patients in the first and second line setting, and MONARCH-2 allow no prior chemotherapy, only one prior endocrine therapy. If we see PALOMA-3, that we see more resistant population at about 31 to 36 of patients that received prior endocrine therapy, prior chemotherapy, and also any number of line of chemotherapy were allowed. So we discussed the MONALEESA-3 that also showed overall survival benefits, as I mentioned, that include patients in the first and second line, and also the combination was with fulvestrant. So MONALEESA-3 updated overall survival here in overall population patient in first and second line actually showed overall survival benefits by 53.7 months in the ribociclib arm, 41 in the control arm. So a combination of ribociclib plus fulvestrant continue to demonstrate overall survival benefits. What about first line setting? Also the first line setting, which showed also overall survival, impressive overall survival benefits with 67 in the ribociclib arm versus 51 in the control arm with hazard ratio 0.76. And so we see clearly how the curve is separated and pull apart over time. As ribociclib also demonstrated 15.8 months longer overall survival and relative reduction of death about 33% versus the placebo arm. Also in the second line setting, with about overall survival in second line setting, it also showed overall survival benefits with the hazard ratio 0.78, as the ribociclib with fulvestrant median OFS it's about 39.7 versus 33 in the placebo group. So ribociclib plus fulvestrant demonstrates 6 months longer overall survival over placebo plus fulvestrant in the second line setting. So PALOMA-3 also better overall survival. This is very important data. If we go and see the table down, that a patient didn't receive a prior chemotherapy, we see median OFS 29 in the palbociclib group. Sorry, 39 in the palbociclib group versus 29 in the placebo with hazard ratio 0.72. In contrast to the patient that received a prior endocrine therapy, that almost didn't show any benefit of adding palbociclib. So patients get the benefit from sequenced endocrine therapy instead of jumping to chemotherapy or switching to chemotherapy without a specific indication or clear indication. Also, MONARCH-3 also showed overall survival benefits, 9.4 month overall survival benefits. It was in the abemaciclib plus fulvestrant 46.7 months versus 37 in the control group, and also delayed time to the chemotherapy from 22 up to 50 months with hazard ratio 0.62. Also, usually we are wondering, or we are wondering with the good endocrine partner with CDK4/6 inhibitor. Actually, these questions was answered by this phase 2 trial, which is a Barasfield trial, that studied the efficacy of palbociclib plus letrozole versus palbociclib with fulvestrant, and showed almost similar median overall survival. So we usually prefer to use letrozole. It's given orally and more convenient to our patient, especially the patient will stay for a long time in such treatment. So in terms of toxicity monitoring and management, we know all the three CDK4/6 inhibitors are well tolerated, and also the side effects usually are transient. We know also that the three CDK4/6 inhibitors, they differ in doses, half-life. If we see the dosage schedule of palbo and ribociclib almost similar, and amibat given as a continuous. If we move to the hematological toxicity, we see that neutropenia more with ribo and palbociclib in contrast to the amibaciclib is lesser percentage, and actually febrile neutropenia, it's very low. Regarding non-hematological toxicity, the area we see it's higher with amibaciclib, and usually in the first first cycle of ribociclib. So monitoring patient and detecting patient will decrease the risk of drug discontinuation or this drug dose reduction. Regarding QTC interval with ribociclib, it's very rare. And as I mentioned that it's higher with tamoxifen. Liver enzyme should be monitored with patient with ribociclib, and also alopecia, it's not more than grade 1. And also I would like to highlight that not listed here, one of the side effects not listed here, if patient presented with short breath or chest symptom, we have to consider pneumonitis. But in fact, it's very rare, but we have to consider that in our differential diagnosis if patient on CDK4/6 inhibitor. What about dose modification? I will like or emphasize on the ribociclib. We know that ribociclib has one string tablets, and this one string tablet is if patients that experience side effect or need dose reduction, that we can do dose reduction without additional cost or without writing a new prescription. So that thing that segregate ribociclib from other CDK4/6 inhibitor. So is that dose reduction or cycle interruption affect the overall survival benefit from ribociclib? And this is really assuring data that showed overall survival benefits from MONALEESA-3 and MONALEESA-7 in post-menopausal and pre-menopausal that showed dose reduction does not compromise overall survival benefits for ribociclib. So no difference between dose reduction versus no dose reduction in terms of overall survival benefits. Also, if we move to the PALOMA-3, that affect PFS actually is similar to the ribociclib. No difference in PFS in patients that has dose reduction versus no dose reduction. So, what make ribociclib treatment of choice for our patients with advanced breast cancer? So ribociclib, as we mentioned, active in both patient pre and post-menopausal, regardless of endocrine partner. Also, longest reported follow-up it was with ribociclib. With that follow-up, we found that ribociclib has a manageable safety profile, and as we mentioned that QTC it's very rare, and they mentioned that with the doses higher than 60 milligram per day, and it's not the dose for ribociclib even. So also it's the trial of all the 3 trials of ribociclib showed overall survival benefits, and also showed longest overall survival in the first line setting. And this is the MONALEESA-7 trial that we already explained before. So regarding the intrinsic subtype that we mentioned before, and also as I mentioned that intrinsic subtypes has prognostic value in breast cancer, and this is from the correlative analysis from MONALEESA-2 and 3 and 7 that showed overall survival benefit associated with ribociclib seen in the luminal A, luminal B, and here 2 subtypes. Actually, Basel-like it was a small size group, and no benefit was observed. So living longer and living better, ribociclib combined with endocrine therapy is the only first-line treatment with proven overall survival benefits. Longest reported median overall survival, as we mentioned in MONALEESA-2, is up to 63 months. And longer delay in time to the chemotherapy, it's up to 1 year. Maintain quality of life, also consistent and manageable safety profile. What about after CDK4/6 inhibitor? If patient progress in CDK4/6 inhibitor, would it have a specific strategy or specific or current guidelines that guide us to use next line treatment? But this is what option that we have. A patient has like a tumor harbor PIK3CA mutation with about 40%, and patient with that mutation facing poor prognosis. We can use a solar regimen that showed me the BFS 11 months versus 5.6 months in the control group. Also, patient with BRCA mutation, you can use a PARP inhibitor. Other option, which is mTOR with hormonal treatment as BRCA2. Also, we usually ask these questions is in the role of switching to the other CDK4/6 inhibitor after progression CDK4/6 inhibitor. Maintain trial will answer this question that we will discuss it after this slide. And also we have a new oral regimen which was called CDK7 inhibitor called semiracycline that study in also will highlight this trial. And the other option, the oral SERD recent trend, it was reported or that study in the phase 3 EMERALD study. So maintain trial that it's presented in ASCO 2022. It's randomized phase 3 trial that study the hormonal treatments, fulvestrant or exemestane with or without ribociclib after progression on hormonal therapy plus CDK4/6 inhibitor. CDK4/6 inhibitor with endocrine therapy is the standard of care. Ribociclib, we know that ribociclib with hormonal therapy improved PFS and overall survival in phase 3 trials. And antiproliferative effect of CDK4/6 inhibitor can reverse upon discontinuation. So this is study design. As we mentioned, that patient has a prior CDK4/6 inhibitor. About 80% of patient was in palbociclib. Patient was randomized to ribociclib plus endocrine therapy versus endocrine therapy alone, with the primary endpoint it was PFS. Actually showed PFS benefits with ribo plus endocrine therapy about 5.2 versus 2.7 with the hazard ratio 0.57, and was also at PFS at 6 and 12 months was also higher with ribociclib at about 41 and also at 6 months and 24 at 12 months. So ribociclib plus endocrine therapy lead to a statistically significant improvement in PFS compared to the placebo plus endocrine therapy to the patient has a prior CDK4/6 inhibition. Palbociclib, as I mentioned about it was the prior CDK4/6 inhibitor in about 87% of patients, and also 43% risk reduction of progression or death with ribociclib, higher PFS at 6 months and 12 months, as well as improved clinical benefits rate with ribociclib. And as we know that ribociclib plus endocrine therapy demonstrated a manageable safety profile. Also, this I would like to highlight this study, which is CDK7 inhibitor study of some ribociclib as a first line, as a first in class oral selective inhibitor of CDK7 in combination with fulvestrant. And this is CDK7 inhibitor mode of action. It's oral medication that block CDK7 oncogenic effect and leads to, as we see here in the cartoon, that it inhibits phosphorylation of other CDK and also inhibit oncogenic and anti-protetic gene. It's inhibited oncogenic genes and also inhibit activation of hormonal receptor such as estrogen and androgen receptor. And this is the study design. Patient that receive a prior CDK4/6 inhibitor were randomized to receive, it was single arms trial, received some CDK7 inhibitor, which is semiracycline plus fulvestrant, and actually showed a clinical benefit at 24 weeks, about 36%, and the benefit was higher in patients with no liver mets, about 55%, but still this is a phase 2 trial, and still we have a more and more and also a lot of movement in the static space, and really it's really world data. Also there is a role of selective androgen receptor modulator based on phase 3 ARTIST trial in third line setting, patient with androgen receptor positive, and it's really a small population, about 24 patients. Also, the other targeted therapy in patients with TMB or HER2 subtype mutation, we have a role for Bimbo and Nivo and Ipilimumab in patients with high TMB. And also in HER2 mutation, we have a triplet regimen, which is neratinib, fulvestrant, and trastuzumab. And we know that if GFR has amplification or amplification that is associated with resistance to the endocrine therapy and CDK4/6 inhibitor. So there is a study that studied the combination palbociclib, fulvestrant plus VEGFR inhibitor. And as I mentioned, there is several agents in early phase trial. We're waiting to see that results soon. So selection and sequencing of therapy for HER2 hormonal positive, HER2 negative advanced breast cancer. CDK4/6 and PIK3CA are affected patients with fissile bone dominant disease. Chemotherapy should be sequenced after all available endocrine therapy option, except in case of life-threatening disease. Sequencing depends on the prior treatment, the presence of other mutations such as PIK3CA, or the presence of BRCA mutation. So this is a summary of current hormonal positive breast cancer approach. First line, as we mentioned, CDK4/6 inhibitor plus hormone treatment. If in second line still we didn't have a specific protocol or specific strategy for such after a progression in CDK4/6 inhibitor. So in advanced breast cancer, no current agreed standard of care for treatment of women with advanced hormonal positive breast cancer who progress in CDK4/6 inhibitor. So with that, I will conclude. Thank you.
Thank you very much, Dr. Aisha. Now the floor is over for discussion, maybe, and the final thought from your side. The same point of discussion about the significance of this advantage in terms of overall survival, and how does it affect your practice or the practice of breast cancer, hormone-sensitive disease in the kingdom. So Aisha, please, I need your comment.
Okay, well, actually I have good experience with ribociclib and other CDK4/6 inhibitor like palbociclib, but I will not change my opinion from my previous senior consultants. Usually, with this overall survival data that reach up to 63 months will let me to think a lot about ribociclib. If I find a fit, healthy patient that can tolerate medication, despite the risk of QTC prolongation, it's very rare, but I have to consider it. Usually, a palbociclib for patients with comorbidities and elderly. Also, ribociclib, maybe we can use it for more patients with highly burdened disease with impending visceral crisis. Maybe this could be one of my options. That's all.
Okay, thank you, Aisha. And I'd like to mention something which was presented here, which is the role of CDK4/6 inhibitors after the progression of another CDK6 inhibitors. In the past, we know that we inherited the knowledge that this is not desirable, but now I think there is room for using others after the other when they progress, basically because of the limitations of second-line therapy, which includes those for PI3K positive. Then you have to go for alpelisib. And we know that it's only represent about 30% of patients with hormone-positive breast cancer who progresses, and nothing comes without a price in terms of side effects and the difficulty to manage these side effects. I do stress all the time on that the main management of, or the cornerstone of managing side effect is good follow-up, good communication with your patient, and to ensure that there is a continuous line of communication between you and your patient. And alhamdulillah, all the colleagues in Prince Sultan Medical Military City, they are maintaining this on personal basis and on departmental basis. And this is actually decreases the magnitude of side effects on the quality of life when you manage them as soon as possible. The other thing is that there is one name that I want to pay good attention to in the coming few years, which is Samura. This is how I just nicknamed the drug of samuraciclib. I do believe that this drug will have a bright future in the CDK4/6 group. Thank you, Aisha, and thank you, Pfizer, for the support. Thank you very much. I think now we'll take a break. Intentionally, it was for 15 minutes, but because we are way much ahead of time, which is almost like nearly 30 plus minutes, close to 40 minutes, we'll let you know about when to come back. Please don't go away, don't run away, okay? And we will just, and I'd like to ask everybody, Mirfat is keep reminding me of the group photo. So please, we want everybody to gather in for a group photo, and after that, اذهبوا فأنتم الطلقاء. Okay, thank you very much.
بسم الله الرحمن الرحيم. Assalamu alaikum jami'an. Welcome for this second session of our ASCO update and discussing mainly the breakthrough abstracts that has presented in the last ASCO this year. It is my pleasure to have sharing this session with our eminent physicians and professors, Dr. Mirvat Mahrous and Prof. Khalid Khattan, and myself, I am Ahmed Abdelwaris. I am medical oncologist. During this session, we'll have 5 abstracts discussing the role of immunotherapy in different stages and settings of lung cancer. We believe, as the scientific committee has chosen these abstracts, that they are practice-changing abstracts. We'll have an honorable speaker to discuss all of the abstracts after the speakers presenting them. Dr. Christian Grohe from Germany will have a deep insight of these abstracts and give us his opinion as an expert in lung cancer of what to do tomorrow in our sessions. So it is our pleasure to start with the first speaker talking about anti-PD-L1 therapy with or without chemotherapy in non-small cell lung cancer, where we have a PD-L1 score more than 50, a situation that we don't see in many patients in our routine clinics, but it is worth to know what to do for this patient, which they have a potential for long-term survival. This abstract will be presented by Dr. Rasha Hajjaj. She is associate professor in Zazi University and with a special interest in lung cancer. So, Dr. Rasha, please, the floor is you.
Thank you, Ahmed, for this presentation. First of all, I would like to express my thanks and gratitude for the organizing committee for giving me the opportunity to present this valuable data in this very scientific meeting. Actually, my task is to slides don't move. I have a technical problem, the slides doesn't move.
Connect by mouse. Connect by mouse.
Not responding. Still not responding. Can you help me?
Can you share another screen?
Okay.
Share screen.
Okay.
Move slide.
No, not moving. Not responding.
By mouse, doctor.
I don't have it. Can you help me? Can you change your side? Can you see the slides?
Yes.
Okay, my task today is to present the abstract presented by Professor Akemburo and his colleagues in the title of Outcomes of Anti-PD-L1 Therapy with or without chemotherapy for first-line treatment of advanced non-small cell lung cancer with PD-L1 scoring more than or equal to 50%. It is an FD pooled analysis. As we can see in this table, this is the FDA-approved regimens for advanced first-line metastatic non-small cell lung cancer not harboring tumor genomic alternation, and these drugs are based on the PD-L1 level and the histology subtypes. For those patients with PD-L1 level more than or equal to 50%, Pembro, Atezo, and Belimab was approved for non-small cell lung cancer and have had overall and progression-free survival. And for those with PD-L1 level more than or equal to 1%, Pembro and Nivo-Ipi combination was approved for non-small cell lung cancer, which had overall survival benefit. And for those with no PD-L1 data or low expression, the combination of IO plus chemotherapy for non-small and small cell squamous and non-squamous was approved in the form of Pembro, platinum bimetrexate, carbopaclitaxel for the squamous type, Atezo-Bev the combination with chemotherapy, Atezo-chemo, and Nivo-Ipi combination with platinum doublet was also approved with the progression and overall survival benefit. And for the group of patients with intermediate expression of PD-L1 from 1 to 49%, it is very clear that chemo-IO combination had statistically significant difference in favor of the chemo-IO combination regarding overall survival with hazard ratio of 0.6, and also for the progression-free survival with hazard ratio of 0.6. And this led to the guidelines to stratify the patient who are previously untreated advanced metastatic non-small cell lung cancer with PD-L1 assayed by immunohistochemistry with no tumor genomic alternation. They stratified the patient according to the PD-L1 expression level. Those with 50% level, the chemotherapy is preferred according to NCCN guideline was immunotherapy only, and also chemoimmunotherapy is an option. For those with intermediate expression from 1 to 49%, chemo-immuno combination and also immunotherapy only was an option. For those with low or unknown expression level, immunotherapy only versus chemoimmunotherapy was also an option for treatment. Regarding our study design, the pooled analysis population included patients with advanced non-small cell lung cancer. All patients should have PD-L1 TPS expression more than 50%, no sensitizing EGFR or ALK mutations, and the data collected from clinical trial support FD approval of IO-based regimen only, or there were 12 trials. The study design according to the treatment given to those patients was chemotherapy plus IO versus IO alone. The exploratory primary outcome measure was overall survival, and the other exploratory outcome measures was PFS and overall response rate. The subgroup analysis was stratified according to the age, ECOG-BS, and the smoking history. They used the statistical analysis used in this study was for overall survival and PFS. The median was estimated by Kaplan-Meier methods, and hazard ratio was estimated by Cox proportional hazard model stratified by the trial. For the overall response rate, odds ratio was estimated by allogistic regression model. And all analyses were covariate adjusted for age, sex, race, ECOG-BS, histology, and smoking history. These are the 12 clinical trials in which data was collected. On the left side, as we can see, they are the trials in which chemoimmunotherapy was approved as first line in this group of patients. They are very famous trials, used Pembro chemo, Atezo-Bev chemo, Atezo-chemo, and Nivo-Ipi plus chemotherapy. And on the right side, we can see the 6 trials used in this study design who give only immunotherapy without chemotherapy in the form of nivo, pembro, atezo, nevi, ibi, and semibelimab. And this cartoon shows the consort diagram of all patients collected from the 12 trials. The total number of patients was at first 9,000 patients, but after exclusion of EGFR and ALK mutation patients and those with no baseline PD-L1 information and those with PD-L1 scoring less than 50%, the total number of patients was 1,000. From which chemoimmunotherapy was given to 455 patients and immunotherapy alone was given to 1,300 patients. This table shows the demographic and the baseline characteristics between the treatment arms. As we can see for age, the median age was 64. About 50% of the patient was less than 65 years, but the elder population more than 75 years was only representing 11 patients. Most of the patients were male, 69% of them. For the rest, 80% of the patients from the white population and the black population represented only 1% of the patient. 98% of the patient had a history of smoking, either current or previous smoker, and the BS more than or equal to 1% was represented in 66% of the patient. Most of the patients, 70%, was the non-squamous cell type. From this table, we can see that elder population only represented in 11% of clinical trials, and the black population was represented only in 1% of the 12 clinical trials, which led the ASCO this year to give a recommendation to involve more this patient population more in further trials to find the best treatment option for them. And the result was as follows. For the overall survival, the primary exploratory point, the median overall survival was numerically but not statistically significant in favor of chemo-immuno versus immuno alone, 25 versus 21 months with hazard ratio 0.8. But regarding progression-free survival, the median progression-free survival was in favor of chemo-immunotherapy combination, 9.6 versus 7.1 months with hazard ratio of 0.69. For overall response rate, it was higher in the chemo-immunotherapy combination versus immunotherapy alone with odds ratio of 1.2. So the overall survival numerically advantage for using immunochemotherapy, but unfortunately it was not significantly different. For the exploratory progression-free survival, as you can see, the chemo-IO combination is statistically significantly higher than IO-only patient in non-small cell lung cancer with PD-L1 more than 50%. When we come to the subgroup analysis, as we can see, for overall survival in this group of population, all patients had the numerical superiority in overall survival. But surprisingly, the patients who are older than 75 years had significant better overall survival in when were treated by immunotherapy alone versus immunochemotherapy, and also this was presented regarding the progression-free survival. The hazard ratio for overall survival was 1.6, and for progression-free survival was 1.2. This study has many limitations as it is a retrospective exploratory pooled analysis in which the results were only hypothesis generating, and also it didn't explain the lack of concordance why there is no significant overall survival of the combination and there is progression and overall survival benefit. Is it due to subsequent therapies used in the IO only arm? Does the treatment, subsequent treatment will differ? And this is being studied in prospective insignia trial, this which is this still current trial, and this in concordance may be related Does it related to the death or treatment discontinuation due to the toxicity of adding chemotherapy to immunotherapy, and also the heterogeneity across the trials of the cutoff value of PD-L1 and the method of assaying. So the difference also, one of the limitations of this trials, it is a clinical trial population, not real patient, which may differ in the demographic criteria. So in summary, the advanced metastatic non-small cell lung cancer with PD-L1 more than 50%. Our pooled analysis doesn't suggest a difference in overall survival for chemo-immuno versus immuno alone. So there appears to be significant numerical advantage favoring of chemo-IO. The observed difference in progression-free survival and overall survival between the chemo-IO versus IO alone to be interpreted in the context of overall survival finding and the exploratory nature of this analysis. Also, the elder population who are aged more than 75 years may have better overall survival and progression-free survival with immunotherapy alone with the using of chemotherapy, which is very suitable to their age, their comorbidities, which may get benefit from using IO without chemotherapy to decrease the toxicity, and also we can keep the overall survival benefit. And this raises the issue that the decision making in selecting the therapeutic approach should be a discussion, long discussion between the patient and the caregiver to find the best treatment option and to find the best practice tool. In this slide, the author acknowledges his team, and by this I ended my presentation. Thank you for your sincere attendance and attention. Thank you.
Thank you very much, Dr. Rasha, for an excellent presentation. We'll keep the questions and the polls at the end of the session. It's my great pleasure to introduce our next speaker, and Dr. Marwan Al-Higeli. Dr. Marwan Al-Higeli is known to everybody. He is head of medical oncology in King Abdulaziz University, Jeddah. He will present important abstract, which is considered one of the changing practice as well, the Nadim trial, nivolumab chemotherapy versus chemotherapy as neoadjuvant treatment, a resectable stage 3 disease. Dr. Marwan, floor is yours. Thank you.
Assalamu alaikum. Thank you, Dr. Mervet, for the introduction, and thank you for the invitation. I'll go through my slides for now. I'm going to present the Nadim trial. Okay. So basically, the trial is looking into 2 arms. The first arm is the experimental arm, is the addition of nivolumab to chemotherapy versus the use of chemotherapy as a neoadjuvant treatment for resectable lung cancer from stage 2 and basically to stage 3A and stage 3B. All right, so we all know that actually most of the tumor that we see in terms of lung cancer, usually they present with non-small cell lung cancer, more than 80%. And in the stage 3 is usually considered to have 20% of those patients actually present with stage 3. They usually require multi-modality treatment. And still, even with all the treatment that we have, the outcome still actually poor, with a 5-year overall survival around 36%. We know that preoperative chemotherapy might improve the overall survival, and the number that we have from multiple trials, it looks like the 5-year overall survival benefit is about absolute benefit of 5%, which is not what we hope for. There's also a strong association between the pathological complete response and survival. So that's just, we can use it as a surrogate for better overall survival. We saw that in other cancers, and even in lung cancer, actually, we're seeing the same. And we know the hazard ratio for having a complete response improved the survival by 50%. However, the rate of pathological complete response is still low, and it's around 4%, ranging from 0 to 16%, which is still low. So overall, this is a very aggressive cancer. Getting an complete pathological response with chemotherapy is a smaller chance, about 4%. But we know if we get there, the survival will improve by 50%. The use of neoadjuvant immunotherapy showed promising actually benefit in multiple study phase 2. We also have the phase 3 Checkmate 816 that showed higher complete pathological response, as well as actually improve in the event-free survival, which led to the approval of the use of immunotherapy by the FDA. Nadim trial is a phase 2 trial, and it's looking into the use of Nivo plus chemo versus chemo alone as a new adjuvant, and basically looking at the outcome of pathological complete response and the safety data. This is the flow chart of the study, and if we see here, the patients were randomized into 2-to-1, favoring the experimental arm. After, of course, giving the 3 cycles of chemoimmunotherapy, patient goes to surgery. And after surgery, they will go into more adjuvant treatment with nivolumab to complete 6 months treatment. In the other arm, or the experimental, the traditional or arm, we have just patient receiving new adjuvant 3 cycles of chemotherapy, followed by surgery, then observation. At different time during the study, they collected blood sample actually for circulating tumor cells and tumor banking. This is just looking into the method and the follow-up of the study. Nothing major in there, just a traditional routine follow-up for all the patient. We know that every 3 months, they have different sort of imaging looking into the tumor and also into recurrence afterward. The primary endpoint, as I mentioned earlier, was the pathological complete response and the intention to treat population. Other secondary endpoint was the major pathological response, which means less than 10% of the viable tumor cells. And of course, looking into multiple adverse event and safety information in the study. So the statistical analysis of the study actually was basically looking at a p-value of 5% or an alpha level of 5%, statistical power 80%, and a dropout of 15%. They assumed that the PCR in the classical or traditional arm of chemotherapy alone will have just 10% versus 40% in the experimental arm. So a delta of 30% between the experimental and the traditional arm. The sample size actually came based on this calculation to have a 90 patient, 60 in the experimental arm and 30 in the control arm. And this is how we have the final actually flow chart of the study. As you see, about 57 ended up in the experimental arm and 29 ended up in the control arm. This is the patient characteristics of both study arms. And if you see, almost like equal in all parameters, but if we look here, adenocarcinoma is around 40% in both arms. And if you look at the squamous is around actually 40%. Other subtypes of non-small cell cancer were less than that, as you see. If we look at the stages of the cancer based on the TNM AJCC 8 edition, it looks like most of the patients had N2 disease, and the one that had N1 or N0, they had a very locally advanced disease, T3 or T4 disease. And the distribution was equal between the 2 arms. And of course, most of the patients had N2 disease, few had N1, and very, very few patients had actually N0 disease. Those are the ones with the T4 lesions. All right, if you look at the comorbidities, they were almost equal in both arms. As you see here, different comorbidities were data were collected for the study. And here actually, they're looking into the patient who ended up with definitive surgery. As you see, around 93% in the Nivo chemo arm and 69% in the chemo alone arm. So there was some difference in terms of who ended up with definitive surgery. If you look at the primary outcome of the study was pathological complete response, we had 36.8% in the Nivo arm or experimental arm and 6.9% in the standard arm or the control arm. This is a little bit different than what they had planned earlier. It was 10 to 40%, but the delta between the 2 arms is the same, is around 30%, as you see. The p-value was significant for this outcome, and as you see, the p-value is 0.068. And here they calculated the odds ratio, the odds of having actually a complete response increased by 7.8 folds, favoring the Nivo arm. If you look at the secondary outcome, which was the major pathological response, again, that means less than 10% of viable tumor cells. We have 52% compared to 13.8% with the odds ratio of 6.94 and the p-value that is 0.0012. If you look at the overall response rate, the delta between the two arms is close to 30% as well, with the odds ratio of 3.29 and the p-value is 0.023. In terms of adverse event, of course, if we add more treatment, we will have more side effects. And here, yes, there was an increase of 15% in terms of more grade 3 and 4 adverse event to the side or to the arm of the Nivo plus chemo. If we look at the side effects, I think we are seeing the same side effects that we've been seeing over the last 10 years with the addition of immunotherapy to chemotherapy. But just to bring your attention, in terms of febrile neutropenia, it doesn't look like there is much difference. And in terms of other side effects like fatigue, it looks like it was way, I mean, very and 12 degree and more. When they looked at actually predictive biomarker response for the patient who ended up with the experimental arm, the patient who received Nivo plus chemotherapy, if you look carefully here, with the PDL positivity was associated with more chances of complete pathological response. And here, if you see, as we go from 1%, 1 to 50%, and more than 50%, we have an additional benefit in terms of complete pathological response, 15, 41, 61. So yes, it looks like the PDL positivity is associated with more response when we give immunotherapy. So overall, Nadine trial confirmed the superiority of neoadjuvant nivolumab plus chemotherapy combination in patients with resectable stage 3 cancer. It showed actually significant improvement in terms of pathological complete response with a 7.8-fold increase in the odds of complete pathological response and a significant p-value. In terms of safety and tolerability, it looks like we are not seeing new signals, and everything is predicted when it comes to safety and adverse event, and we have acceptable actually grade 3 and 4 toxicity. And in terms of having a surgery after neoadjuvant immunotherapy, it looks like this was feasible, and we saw more patients ending up with definitive surgery after the use of immunotherapy. Another thing that we confirm that PDL positivity has a predictive value for pathological complete response, and this was again proven in this study. With that, actually, I thank you all, and I go back to the chairperson, Dr. Mervet.
Thank you, Dr. Marwan Jahil. Excellent presentation, and you give us a good insight about this trial. We are going to move to the next speaker, Dr. Abdullah Barry, a very known and very dear friend of mine personally. He is the chairman of medical oncology in King Fahd Medical City. We are going to hear from him the news about a second-line treatment after osimertinib that is very successful treatment, and we're looking for the answer of a question: what's after failure of this excellent drug? Dr. Abdullah.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you so much. It's always my pleasure, Prof, to be introduced by you. I would like to thank the organizer. Special thanks to Dr. Mervet for being at this meeting. So my abstract, I would say, is it may not be practice changing, but it's more kind of a window to the future, where we start to see those sort of combination of our non-chemotherapy combination, especially in a disease that have an oncogenic driven tumors, in a way to avoid chemotherapy in those patients, not in the first line, second line, but also as long as possible. So this trial is looking at the combination approach of two drugs, amivantamab, and probably you have heard about amivantamab is earlier in the exon 20 subtype, which is one of the EGFR mutant. And at that setting, we have looked at this, or it has been looked at this as a monotherapy, and it seemed to be working quite good in a disease that's quite resistant to the known EGFR TKI. This was a phase 2 clinical trial that have looked at the combination of this drug with another one of a third generation TKI or EGFR TKI in a phase 2 clinical trial called Chrysalis in patient who has failed not just osimertinib, but also failed chemotherapy in a way to know whether this combination also have efficacy in those patient settings. So amivantamab is not really a usual antibody. It's quite different. It's more kind of what we call it a biphasic antibody, which have two different targets. It's an EGFR as well as MET bispecific antibody. Lazertinib is also is one of the third generation EGFR TKI that's quite effective, more potent. It also have very high CNS activity in those patients. It also have activity even in the resistance acquired or resistance mutations that might be related to the T790 mutation and others. And there are a number of preclinical studies that have showed there are more kind of synergetic effect between both those two drugs that are proven in a preclinical setting, and the way they have done this trial is just to see whether this also translated in a clinical benefit. There are number of cohort with this trial, but maybe I will go over that in the next slide. But one of the cohort that give us a hint that this combination might be also interesting is the cohort that have include patient who has failed osimertinib, and then this combination has been used, and in such cohort we have seen the response rate is more kind of 36% with durable response. So this combination has been tested, and this is the update that we have from this trial is those who are I would say heavily pretreated, not just they failed osimertinib, but also they failed chemotherapy afterward. So this was a phase 2 clinical trial. We have 4 cohorts. The cohort of interest that we are addressing at this abstract is a cohort A, which include those patients who has failed osimertinib as well as platinum-based doublet in 162 patients. However, there are a number of cohorts, as you can see here, cohort B, C, and D. Cohort D, we already have some data about, which is the one that have looked at the patient who have failed osimertinib, but they did not receive chemotherapy. And in such cohort, we have seen quite interesting response that in an average of 30 to 40%. There are also a number of cohort. B is addressing this sort of combination in a exon 20, where we know that amivantamab is also working as a monotherapy. There is also cohort C, which is also addressing the uncommon EGFR mutation. So as you do expect with kind of phase 2 clinical trial, response rate is always the primary endpoint. However, there are other endpoints being looked at, including the duration of response, clinical benefit, PFS, survival, and the most important definitely is the safety, which is one of the main endpoint for a phase 2 clinical trial. So these are the baseline characteristic for the included patient. As you can see here, around 162 patients were included. Majority are female, different geographic subtype. Also, when you look at them, one of the important point that worth highlighting when you look at the baseline characteristic, given the fact that one of the main issue we have with an EGFR mutant lung cancer is the brain mets. And one of the, I would say, strength of this trial is they have not just included good amount of brain mets, which is almost 41%, but also they have enrolled untreated brain mets. So those who have not received any local therapy to the brain mets, and that's probably, I would say, around half of those patients were brain mets and are untreated. Those patients that were included are heavily pretreated, multiple line of treatment, median are 3 lines. There are also numbers, I would say around third of them were more than, or around 30% of them, they already have 4 or more line of therapy. So most of them are heavily pretreated. There are different also regimen or sequence of therapy that has been included in this phase 2 clinical trials. The common approach that we have right now is those who has been progressed on osimertinib followed by platinum-based chemotherapy. However, there are also quite proportion of patients who has been progressed on first, second, then third osimertinib, then platinum-based chemotherapy, and also there is a third of them, they already have different or multiple line of therapy that's probably exceeding 3 lines. What we have seen in this phase 2 clinical trial, that the response rate is there, though the fact that those patients are heavily pretreated, they have received chemotherapy, but this combination seems to work well. It's a non-chemo based combination, and you can see the response rate is exceeding 30%. The duration of response is quite durable for a treatment that you're given in a 3rd or 4th line non-chemo regimen. You can see the duration of response is more than 9 months. There are some patients who has complete responder, which is probably 2 patients. Majority are stable disease. Definitely when you look at them, who are the one who respond the best, you cannot really differentiate. When you look at the first plot, all patients have similar kind of response, regardless of the age, gender, ECOG, all others, definitely also the regimen that they have. And the same thing also when you look at the mutation type, the exon 19 or 21, all of them, they did quite well with this combination in this trial. This is the waterfall plot of the response rate, and you can see quite nice response across all patient subtype. Here they have categorized those patients based on the previous therapy sequence, either with osimertinib, then platinum, or they started with the first generation, or those who are heavily pretreated. Most responses is ranging from a 20 to 30% across the board. So all of them, I would say they have achieved a similar kind of response rate, given the fact that they have prior multiple line treatment. This is what they call it, the spider plot. And here you can see the importance of this plot is just to see the duration of response. And you can see that among the 54 responder, there are 30 patients that are remain on the treatment. The median duration of response also is really important, and it's probably here around 6.4 weeks. So the time to respond around 1.5 months. For also, even those who have the best response were only stable disease, they're still on the treatment. Almost around 8 patients, they remain on the treatment. So even those who did not receive regression of the tumor, they still maintain on the treatment for a longer period of time. One of the important fact, and I would say this is one of the important strength of this study, is because we know that lazertinib is one of the 3rd generation TKI that have a very high CNS activity. The other fact is this trial also they include good proportion of the brain mets, plus the fact that half of those brain mets are untreated. So it's really a proof of concept just to see whether this combination also have an activity on the CNS. And what they did here is they have looked at the subgroup of patients who are untreated brain mets. And when you look at the combination, it's quite effective. If you just look at the complete clearance or complete response or complete intracranial response, you can see that 7 patients, which is almost 26% of those patients, they have complete intracranial response. And that's really, I would say, amazing for such combination to see in a patient who are untreated. And probably this is one of the cases they have mentioned down in the slide, is one of those patients who had also brain mets, but this was treated with gamma radiation, platinum, osimertinib, and he has also complete response that was seen at 54 weeks. So they have complete response, or this patient have complete response, but the complete response also maintained even at 54 weeks time interval. The concern always when you think of combination is, does the toxicity is an issue? And what we can see here, given the fact that amivantamab is a quite different antibody, it have an EGFR and MET targeting, and so we are not surprised to see those 2 target adverse event related, like an EGFR where you see a skin rash, MET where you see an edema. Also one of them classical side effect, and sometimes is a bit concerned for amivantamab is this is the IV infusion or the infusion related reaction, which is happen. It's quite common, usually with the first or second cycle, but most of those are kind of a grade 1 or 2, very few grade 3. But overall, when you look at those side effects, whether with amivantamab as well as the combination approach, most of them are grade 1 or 2. Very few side effects. There are a number of dose interruption, reduction, but there are very few where patient has been discontinuation, and this is probably here, as you can see here, only 7% of patients they have been discontinued in the treatment. Also, one of the side effects which is happen is the pneumonitis or ILD, which is also have been seen in those patients in 7%, but very few were grade 3, and there was no fatality. However, this combination has been tested before, and the safety profile, it seemed to be what has been seen with the earlier clinical trial. So in conclusion, amivantamab plus lazertinib have durable anti-tumor activity for those patients who with an EGFR mutant non-small cell lung cancer, even though those are being pre-treated with both osimertinib and platinum, so they are heavily pre-treated, but still this combination was quite activity and durable of response. The activity is really comparable even for what has been reported with an earlier cohort that only include osimertinib with chemo-naive. The safety profile also is really important, and it's really matching with the earlier report. There is no new safety signal, and it's much tolerable than combination or compared to the chemo combination. So it's really important to look at this, and there we are still looking for more update from the other cohort, and also there are a number of ongoing clinical trials using this combination in a frontline in a phase 3 clinical trial where this has been looked at also in a combination with the chemotherapy, as well as also this combination, or maybe only the amivantamab also is being looked at in a different subtype, not EGFR, but also in MET, since it have both EGFR and MET targeting. So with this, I think I have reached to the last slide of my abstract.
Thank you very much, Dr. Abdullah. That was excellent presentation of the abstract. We'll keep the questions at the end, and please, you can join us. It's my great pleasure to introduce our Dr. Abdullah, can join us, please. It's my great pleasure to introduce my dearest friend and our next speaker, Dr. Hatoun Bagheri. Dr. Hatoun, she is medical oncology consultant in King Fahd Medical City, Riyadh. She will present the abstract of the phase 2 code break 100. Dr. Hatoun, please, the floor is yours. Thank you.
Okay, thank you, Dr. Mervet, for the introduction. I would like to share my slide. Okay. So, assalamu alaikum wa rahmatullahi wa barakatuh. Good evening to all of you. So, my talk is going to be like an abstract presentation in ASCO 2022, which is sotorasib and KRAS G12C mutant non-small cell lung cancer. And these are my disclosures. Before I start in the actual abstract, I'm going to give just like a quick reminder about the KRAS mutation. It happens in around 30% of non-squamous non-small cell lung cancer. And as you know, the standard treatment options do not provide great clinical benefit. And like when you look at the KRAS mutation in non-small cell lung cancer, I'll go to the next slide. You can see like the G12C occurs in around 42% of non-smoker or former smoker, and in around 12% to 13% in patients who are smokers. So the presentation was an overall survival and exploratory subgroup analysis from a phase 2 code break 100 trial evaluating sotorasib and pre-treated KRAS G12C mutant non-small cell lung cancer. So sotorasib is considered as like first-in-class irreversible selective KRAS G12C inhibitor. This drug was studied in earlier phase 1 and expansion cohort of phase 2 clinical trial and phase 2 code break that has demonstrated durable benefit of this drug in patients with such mutation. So this is the trial design. Like it's a phase 2 trial. All the patients receive the standard, the research drug, which is sotorasib at a dose of 960 milligram once per daily till disease progression. Patients who were enrolled in this clinical trial were with locally advanced or metastatic non-small cell lung cancer with the mentioned mutation assessed by central testing of tumor biopsies, progressed on prior standard therapies. Patients with stable brain metastasis were allowed. And the primary endpoint of this trial was the overall response rate by independent central review. And the secondary endpoints were duration of response, disease control rate, time to response, progression-free survival, overall survival, and the safety. There will also an exploratory endpoints, which is the evaluation of the biomarker. So this is the baseline characteristic of 126 enrolled patients. The median age was around 63. Patients were having good performance status. Smoker and never smoker were enrolled. Prior lines of therapy was like 1, 2, and like more of that, like 3 drugs prior to enrollment. The types of the previous anti-cancer therapy was platinum-based chemotherapy alone, or PD-L1 inhibitors alone, or chemo-immuno combination. So the tumor response was assessed in around 46 patients with objective response. And you can see from here, like the median time to response was around 1.4 months, with the duration of response of around 11.1 months. The best overall response were like complete response in 4 patients, partial response, stable progressive disease in 20, and no evaluable or missing scan in 4 patients. For the progression-free survival, the median progression-free survival was around, in 124 evaluable patients was around 6 months, 6.8 months. And you can see here from the Kaplan-Meier estimate of progression-free survival that 52.2% were seen at 6 months and 37.5% were seen at 8 months. Coming to the overall survival or the median overall survival in the 126 all enrolled patients was around 12.6 months. When you look at the safety, first of all, there was no fatality occurring in this trial. And you can tell that the most common treatment-related adverse events were GIT related, either like symptoms regarding diarrhea, nausea, fatigue, and vomiting, or the elevated liver enzymes, mainly ALT, and then AST and alkaline phosphatase. There were patients with maculopapular rash, I guess like any other TKIs. When we look at the efficacy in the subgroup by baseline characteristic, you could say that the response was like consistently observed across all patient subgroups, whether like of the age, the performance status, the prior lines of therapy. And I will consider here the prior lines of therapy. You could see that the benefit was even seen in patients who received like 3 lines of previous therapy, whether like chemotherapy or combination or immunotherapy alone. When we come to the exploratory biomarkers, they looked into this trial in the association between the response and the PD-1 expression, tumor mutation burden, and the common mutation that co-occur with KRAS, mainly TP53, STK11, and AP1 mutation. You could see like the slides here. If you look at the left side, you can see like the response was independent of the KRAS mutant allele frequency. The dots here represent the number of the patients, and you could see in this line that patients who are having objective response and patient with no objective response. So you can see the response like wasn't dependent on the allele frequency. So whether the patient is having high frequency or low frequency, the response was there. And also by the tumor mutation burden, they put here in this figure the cut point of more than 10 and less than 10, and you can see the similarity between the two groups. And then look at the mutation, maybe better in the next slide. You can see that the patients who get the most benefits were those who are having STK11 mutation with KAP1 wild type. So in conclusion of this trial, like sotorasib continued to provide durable clinical benefit in patients pre-treated with KRAS G12C mutation. At the median follow-up of 15.3 months, sotorasib demonstrated like median overall survival of 12.5 months and a median progression for survival of 6.8 months. Objective response rate was 37% with 4 complete responses. The median duration of response was 11 months, mostly low-grade treatment-related adverse event. So the efficacy of the sotorasib was seen across all patients group, no matter what was their baseline characteristic or what is the the mutation burden that they have had, or like the allele frequency, including those patients with CTK11 mutated tumor that exhibit an inferior outcomes with the standard care of other therapies. Dr. Skolidis, in his conclusion, confirmed that a phase 3 clinical trial is needed, like to compare sotorasib versus docetaxel, which is like the standard of care in patients who were pre-treated with G12C mutated lung cancer. The trial is published in the New England Journal of Medicine. And with that, I will come to the end of my presentation.
Okay, thank you, Dr. Hatun. Excellent as usual, very informative summary of this abstract. And we'll go to the next speaker, Dr. Mirvat Mahrous, our co-chairman for this session. She actually doesn't need an introduction. Very eminent physician in the field of medical oncology, always contributing to all of our scientific activities with very positive input in this. Congratulations, Dr. Mervat, for always having this extra effort to pursue these successful scientific meetings. Dr. Mervat will talk to us about the role of adding and augmenting the role of immunotherapy by anti-VEGF therapy, ramucirumab, in our field of non-small cell lung cancer previously treated with immunotherapy. Dr. Mervat.
Thank you very much, Professor Abdullah, for introducing me, and it's my pleasure that you are I'm sharing with you this session as well. And I would like first to thank you all for being here and all the attendees virtual. It was a great day since starting with the breast session, and I think we had excellent speakers who had introduced the top abstracts of the ASCO. One of the abstracts actually, I think it's draw a lot of attention that in the time now that all cases of lung cancer, we have patients giving IO therapy, and down the road, those patients, they will have refractory or patient progress. And it's always coming to the question, what you will do next for this patient, especially that we saw in the previous presentation that you can give it as an upfront, as a new adjuvant, and then of course, we do have the pooled analysis for the patient you can give with IO, with chemotherapy, or even as a single agent. So what do you do next? So this was abstract, was presented, this is my disclosure. So this was abstract presented by Karen Rekmab from Cedar Sinai Hospital in USA. It was phase 2 study. They looked at the overall survival, and it was the first study to address this question and has a significant, and will come to this point. So the study, it was mainly that combination of ramucirumab plus pembrolizumab for a patient versus standard of care of advanced non-small cell lung cancer, previously treated patient with IO therapy. So our patient population, who patient was exposed to IO therapy as an upfront, and they looked at this patient group, and this was by the LungMap. And LungMap, by the way, it's one of the projects to consider that it's about taking about 600 sites, and it's from the academia, so it's not impacted by the pharmaceutical company. The main point regarding this study, they looked at the patient that the frontline therapy for advanced non-small cell lung cancer, all the patients with PD-L1 inhibition, they have mostly non-activating mutations, and those patients, you should give this patient as an upfront single agent combination or as a subsequent therapy. And the acquired resistance to immune checkpoint inhibitor is a major area of unmet need. Developing therapies to overcome resistance will become increasingly important. When we look at this slide, we see that immune therapy alone, it can be for those patients not enough. Maybe if we are giving them or adding anti-angiogenic therapy, it may augment or may have a synergistic effect by the direct effect on the immune cells, indirect effect on the endothelium, or even from the point of vasculature, as we know. And in the meantime, we know that the combination between IO therapy plus anti-EGFR and plus anti-VEGF, we do have a good data regarding the first one to score. It was the RCC and axitinib pembrolizumab or axitinib avilo, or even cabozantinib plus nivolumab. And of course, we have the lenvatinib plus pembro for the RCC, and this is for poor risk patients. And we have a score for this, putting on facts that the combination between these two therapies, it can be applicable and it can be tolerable. And the second one down the road, it was the endometrial carcinoma. Of course, we have the lenvatinib plus pembro, proven the concept that for anti-VEGF and IO therapy. And the last, it was the hepatocellular carcinoma. And of course, we have the IM power 150, which is beva plus atezo. The main point that pembro is anti-PD-1 plus ramucirumab as anti-angiogenic therapy, it can have a synergistic effect. And this was based on the Roy Harpist. And we know, of course, Roy, he is the one who presented the ADORA 2 years ago, and it is still one of the hits regarding non-small cell lung cancer. And this study, you can see that even it was phase 1 study, but just give you a signal that those patients, even with heavily pretreated patients, you can see that the response rate 30%, and even you can see about CR 4%, and the DCR it was 85%. Again, it was a signal that the combination between ramucirumab and pembro, it can in previously treated patients can have an effect. As I pointed out, LungMap protocol, it's a master protocol for patients with a stage 4 disease or patient with recurrent. This was in about 600 sites, and they included about 4,000 patients. They have more than 50 publications and abstract. It's academia, and they are only looking at the unmet need for this patient populations regarding metastatic patient or recurrent patient. And almost they making like public bank for this patient. So the info regarding any of this protocols considered from the lung field is credible, because it's mainly they are looking at the unmet needs. When you look at this busy slide, you can see that the lung map, when you look at the green, it means activated. And when it's in yellow, it's temporarily closed, or in the blue one means that it's in developing. So our study is here. It's the S100. It's a here we can see that this is what we included on the study. So the S1800, it's non-matched subtype of lung map, patient not eligible for a biomarker match, design randomized as phase 2 study, the sample size about 130 patients. And we can see that this is the design of the study. They included first patients who received a PD-L1 as an upfront therapy as first line or as a second line. And patient has to be off of the treatment 84 days. And the second element regarding the performance status 0 to 1, all patients met eligibility to receive ramucirumab. So any patient with thrombosis or have risk of bleeding, they will be eliminated from the study, not eligible. So you can see that those patients, about 130 patients randomized, and one-to-one randomization. The standard of care is for the patient who receive IO therapy. Usually we are going for the second line, which is docetaxel ramucirumab, or docetaxel or gemcitabine, or the pemetrexed for non-squamous patient. And for this, the examined arm, it's pembro 200 milligram per flat dose, Q every 3 weeks, and it's for 35 cycles, plus ramucirumab 10 milligram per kg every 3 weeks. When we look here, we even look at the ramucirumab dose, you can see that 10 milligram every 3 weeks. It's not like a regular dose in GI, which is 8 milligram day 1 and 15. So they adapted to be with the pembro and every 3 weeks. The primary endpoint, it was overall survival, which is a strong one. And the secondary endpoint, and I have to point it out, this is patient who treated initial, and this is patient refractory. So looking at the overall survival for this patient, it's considered a strong point. And the secondary endpoint, it was response rate, DCR, and disease duration, and also PFS. When we look at the patient characteristics, you can see the majority of the patients that were white, 87%, the black about 9%, which is not considered a good representative in this study, and also the Asian population. So the majority of the patients were white, and in the meantime, the histology, 58% were adenocarcinoma, 40% were squamous. When we look at the PD-L1, about 41% was PD-L1 less than 1%, which can be expected, because most of the patients who have PD-L1 less than 1%, those patients, they can be refractory on the treatment or have a recurrence or this progression. And when we look at the 50%, it's quarter of the patient. And when we look at the tumor burden, about 40% more than 10 megabase. So when the study met the primary endpoints, you can see clear separation of the curve, visual and even numerical. It's 14.5 versus 11.6, almost 3 months gain between both groups. And you can see the separation of the curve starting after 2 months. And I have to remind you that the docetaxel plus ramucirumab, it was about half of the population. The number is 45 patients. So the majority of the patients, they receive the combination, not a single agent. And you can see that the hazard ratio 0.69. It's a significant study. And here we can see in the subgroup analysis, most of the patients, they benefit from the treatment. However, we can see that the squamous patient or mixed histology, they have a better comparable to non-squamous. The higher the PD-L1, as you are expecting, the higher, the better. But all the population with PD-L1 less than 1%, comparable to more than 50%, they will have a response. One of the other elements also, the the STK11, we know that those patients, they are refractory to IO therapy. And here we can see that the hazard ratio for this patient here is 0.54. This means that those patients, when you are combining them with anti-EGFR, maybe you can have a synergistic effect. Another element as well is the sequence of the treatment. You can see that IO plus chemo, they didn't have the same response. If you are a sequence of the treatment, chemo followed by the IO therapy, you can see that this patient has a better outcome, and it's significant as well. Regarding the progression-free survival, you can see that it's not significant, and the overlap between the two lines together. However, it starts to separate after 6 months, and this means that the patient who were responding to the treatment, they continue in the response. However, the PFS for this group, it's not significant, and it was 40.5 versus 5.2. And when we look at the response rate, we can see similarity and even better for the standard of care. And here we can see the stable disease 53 versus 44, and the response rate 22 versus 28%. But when we look at the duration of response, which is one of the main elements regarding IO therapy, it's almost double. So the duration of the response for this patient, 12.9 versus 5.6, mean that those patients, they may have a better outcome with the combination. And one of the main elements that those patients, they were receiving treatment as an upfront. So how about the subsequent? When you look at the toxicity, you can see that 60% of standard of care, and I have to remind you that majority of the patients, they were receiving combination, which is docetaxel plus ramucirumab, which is considered standard of care, or nantadenib plus docetaxel for this patient. And here we can see that the toxicity profile, 42% for the RP comparable to standard of care, which is a 60%. One of the main elements which is highlighted by Karen, that the limitation of the study, of course, it's a phase 2. We need confirmation with phase 3 study. And then the main point, the heterogeneity, because there is a heterogeneity about the type of the chemotherapy and also immune therapy, it may affecting the patient. And in the meantime, we can see that there is a signal regarding STK11. This patient may benefit from the treatment. And one also of the main limitation regarding that the NGS and PD-L1 expression was based on archived tissue, not in post-progression, and those patients may have a different outcome. So this is my last slide regarding the conclusion of the investigator. So ramucirumab and the pembro in patients with advanced non-small cell lung cancer in previously treated patient and prior platinum chemotherapy improve over survival compared to standard of care. Discordance of the response rate and PFS from overall survival has been reported, which is true. We know that in some studies, we can have overall survival without the response rate and PFS. And of course, those patients, they will receive IO therapy as an upfront. And the main time that this study included the patients with chemotherapy backbone and survival benefit. Further evaluation and phase 3 study is very encouraging. Thank you very much. And I would like to highlight as well that this, in the same time of presentation, the study was published in GCO, and it's available for more information. Thank you very much for your attention. With that, I would like to introduce our next speaker and my dearest friend, Dr. Christian Gros. Dr. Christian Gros, he is the head of Department of Pneumology and Medical Director of MC Clinic and Lung Clinic Berlin Hospital. He is one of the eminent names in the lung cancer field, and has plenty of publications, and he will discuss the top abstracts of this session. Dr. Christian, the floor is yours. Thank you so much for joining.
So, hello everybody. Can you hear me? Is that okay?
Yes.
Okay. So, see if that works. See. So this is moving, I hope.
Yeah, we can see it, and also we can hear you well, Christian.
Okay. So thank you very much for your very kind invitation. I was following your session, and I think this is a very interesting phenomenon worldwide. We are probably intrigued by the same new movements in our very fast-moving field. So this is very interesting to see. So overall, you had 5 abstracts, and I picked from the 5 abstracts some more information about the actual new entities we are interested in. And maybe we can start with the last one, and you please interrupt me whenever you want and let me know. And my total time, I try to follow that and give you some information about what we can do. I think the most important issue today will be that we can interact by question and answers, as you are very familiar and very well situated in the field. So I think that might be very helpful. So this abstract here by Karen Reckamp, you already have mentioned that, has 2 very interesting things we should know is about this, is the fact that this is a very, very common scheme now, how we can analyze in a very dynamic environment clinical relevant studies. So this is, I think, the most important information about this abstract, is that the current LangMap scheme will help us to initiate and to evaluate biomarker-driven sub-studies. And as you have mentioned already and pointed out, this is published in the JCO. So obviously in a phase 2 study, with a very heterogeneous background, you can publish these data because they are new and very informative on a very high level. So this is good news. The second part is, obviously, due to the recruitment process, we have a very heterogeneous background in this study. And this is somewhat we have to discuss. Due to the fact that in all different countries we are in, we have different kind of approvals for first line now. We have different kind of mono, triple, platinum doublet options. And therefore, in the situation post-IO triple or post-IO mono failure, we obviously have a situation that these patient cohorts can be very, very heterogeneous. So that might be a big problem. So if we go back to one thing I would like to show you is the current landscape. And for instance, at the ESMO guidelines here show that we have in this situation different kind of options we can use for these patients. And we can definitely combine different options. The problem is what to do after failure. And as you already have pointed out, in these patients, we have obviously a certain kind of sensibility towards the angiogenesis and the anti-angiogenic treatment option. So this, I think this is the key message for this phase 2 study, ramucirumab plus pembrolizumab in patients who failed, is the fact that obviously the angiogenic pathway plays an important role in the modulation of the process, which ultimately leads to progression of the tumor. So this is my key take-home message. Yes, the anti-angiogenic treatment option, either with ramucirumab or with a multi-kinase inhibitor like nintedanib in combination with another drug, might be helpful in this setting. The other thing we have to consider is the fact that what is the idea nowadays in second line? Obviously, and you probably have already encountered that if somebody in your field will do clinical studies, there are a lot of clinical studies at the moment still having as a partner or comparator docetaxel mono. This study clearly shows now that we need a doublet in second line. The doublet should contain an antigenic drug And you, depending on the approval status in your country, you can combine it with docetaxel and ramucirumab, or you can use ramucirumab and other drugs in certain countries, or you can use nintedanib and docetaxel. But saying that, it definitely shows that the new clinical studies, and in particular, there are a couple new studies coming on now with the antibody drug conjugates, a very high level form of interaction with the tumor, but the standard of care in most of these clinical studies will still be docetaxel. And I think this is definitely a clear sign, this study, that docetaxel mono is not the right option anymore after failure post-IO. I think that is definitely clearly the message we have here. Maybe there's certain kind of reasons why that doesn't work that well, but obviously VEGF overexpression might play an important role in these patients. In particular, in patients who have early failure. Early failure, that definitely means patients after 2 cycles or 3 cycles of triple IO. And there are new entities coming up to understand that. And for instance, if you have been familiar with a recent subclassification of adenocarcinoma, there are certain subgroups called so-called SMARC4 deficient cells. And obviously the angiogenic pathway in these new entities is driven by angiogenesis, and this is a poor outcome marker. So we have to learn more about it. And I think in particular, the angiogenic pathways has to be addressed in patients who do poorly in that context. The next step I would just address is the question, what we're going to do if these patients already fail in second line in a combination of, for instance, nintedanib and docetaxel. So if you have a patient, for instance, who failed first-line triple IO plus, for instance, pemetrexate and platinum, and then you put him on nintedanib and docetaxel, they obviously, if they do perform well and will encounter the option of a third line, you can re-challenge. So this is data now from Cappelletto, and there are new data and more data about this, the so-called Seneca trial from colleagues in Italy, showing obviously there is some sensitivities that you can re-challenge these patients in third line. Saying that, that definitely means that we do see more patients in later lines due to the fact that the overall survival benefit of triple chemotherapy option plus IO is so beneficial for our patient that they have second line options. And if you consider that as an option in third line, most countries do not have any approval committees for third line because we never ever had enough patients for third line regimens in clinical study protocols. Now I think we have the option in some of our patients to re-challenge them with an option with, for instance, with an IO treatment option. And I think this is very encouraging in our patients. Again, what you already have pointed out, what is the limitation of that clinical study of LungMap? This is mostly based on archival tissue. And this is definitely what I would like to say, a pledge. Please, whenever you have the chance, try to rebiopsy, because the learning curve for all of us is imminent to understand what to do next in our patients. Saying that, I would just like to conclude for this option is, what is coming next for this new clinical studies? There have been clinical studies. The old ones is what we have, ramucirumab and docetaxel, or our clinical prospective study showing docetaxel and nintedanib. Then we had data from Bessie and combining different kind of options. You see the clinical studies from Han in the Dublin 3, they combine now the second line treatment option. I think this is a take home message. And the other thing, what we have to do is that in this clinical context, obviously, we have to learn that most of our options are difficult to have for an interpretation because the first line is so heterogeneous. So whenever you plan to do that in the context of your country or in your setting, try to get as much patients from the standard of care in the first line to a second line treatment option to understand what is maybe the underlying mechanism, what is not working in this context. I think this is the most important issue for that. And then finally, if we look at the data here in our patients here, obviously, if you look at the PD-L1 status in these patients, we have a proportion of patients who have no PD-L1 at all. And in most countries, you know that pembrolizumab, for instance, has no approval in patients with no PD-L1 expression. For instance, in my country, we have nivolumab, which has an all-comer approval for second line, but both atezolizumab and pembrolizumab for second line mono do not meet these criteria. So obviously, this is something what we have to learn, and I would like to see, despite the fact this is a small group of patients, if this is really working in this group of patients. And then we have to come up with an explanation why it's working. So please be aware, whenever that gonna show up somewhere in whatever country's context that's gonna be, that has to be approved by the local authorities. So this is something, some kind of concern I have with this clinical study. Finally, if you look at the information we receive from our patients here, and if you look at the left side, the blue arrow indicating STK11, KEAP1, the Kelch-like protein, obviously this is a small group of patients, but anyway, this are the patients who are the poor performers. We do know this now from a lot of clinical trials and post-hoc analysis, that STK11, KEAP1 are obviously patient groups which do have a poor prognosis and do not perform on anything very nicely anyway. And so we have to learn about that too. And in particular, that's going to be very important also for the earlier stages and the idea to use IO in the neoadjuvant and adjuvant setting. This is my pledge. Again, if we do systemic treatment, nowadays, we obviously need extensive molecular testing, not only for classical driver mutation, but also for poor outcome cohorts to understand what's going on and the failure, what to do. We have a plethora of new medications, but the new medications should be used in the patients who do have a high benefit. And definitely these new medications are no all-comer medications anymore. So let's see, I would like to, you mentioned that before, so I would like to stop here for this first abstract. Are there any questions regarding that topic?
Thank you, Chris, but we'll keep the questions for the time of the voting as well. Thank you.
Okay.
You can keep going.
Is that fine? Yeah, okay. Should I go on with the NADIM-2 trial? Or do you want something else?
We are good. Please continue.
Yeah. Let me see if we can back to. So if that's okay with you, I would like to discuss the NADIM-2 trial. Is that fine with you?
Yeah,
okay.
Definitely. Yes,
so
keep going.
So the NADIM-2 trial is... Pardon? Okay. So the NADIM-2 trial is...
Keep going.
Yeah, the NADIM-2 trial is an extension of the first NADIM trial from Provencio Bula and other colleagues from Spain. And this year's at the ASCO meeting on the Sunday morning, this was a session about neoadjuvant treatment options. And we had an excellent presentation by Nasser Atoki from New York, who definitely told us a lot about the surgical perspective and the thoracic surgeons, what to do in this situation. Saying that, the NADIM trial made it to the orals and made it to the best sessions we had at the ASCO meeting for lung cancer. Why is that? You know, the problem overall was the neoadjuvant treatment options we had so far, that the outcome of these clinical trials were very poor. And most guidelines had to look at data coming from 15 to 20 years ago. Now we have 3 trials which are worth discussing. One is the Checkmate 816, then the NADIM-1 and the NADIM-2 trial. All 3 studies were highly rated, very controversial, highly debatable. But to be honest, within our local context, we have to discuss with our thoracic surgeons what are the right patients to use for these kind of treatment options. This is definitely the most important issue, in particular, because as we see at our lung cancer center, the surgeons like to operate, of course, as early as possible. And what we have learned, and I didn't show you the data here, there were data from Brendan Hayden at the same session, who had the cumulative data set from the Veterans Administration's organization, showing one of the most important issue for overall survival and outcome of the patient is a very, very short time period between time of diagnosis and surgical procedure. If you delay that, that's no good. So basically that means we have to bring our patients as soon as possible into a board and then discuss what to do with these patients. And I think this is the most important issue right after diagnostic procedures, to discuss that in a multidisciplinary board and bring them to the attention to the thoracic surgeons, or to the option that we might use a neoadjuvant treatment option. So how does the neoadjuvant treatment option look out these days for stage 2B or 3? We can combine nivolumab with paclitaxel and carboplatin, and then you can have that up to three cycles. And again, the overall numbers of that clinical study compared to a stage 4 clinical trial are very limited. We have to be honest. And if you look at the neoadjuvant setting, for instance, our institution, it's less than 10% of the total cohort of patients who undergo surgical procedures. So obviously there's there's definitely more space to cover, and definitely something we have to discuss with this cohort. Why is that a problem? To indicate these patients and to recruit these patients. And in the clinical setting, you have to look at the left side here. Obviously, in these patients, this is stage 3A, 3B, patients who definitely usually don't go for surgery or are very, very limited patients in terms of surgery. And then we have to downstage these patients. And as we have learned now, at least for Europe, the EMA told us we have to exclude EGFR and ALK mutations. And that is a concern for the surgical procedure, saying maybe we have a delay now and the patients should be operated on right away, and therefore we don't want neoadjuvant treatment. I don't think so. It's just basically if we use the first biopsy specimen we will obtain from this patient at the very beginning, we can do molecular testing in these patients. Why is that important? I'll show you some data. From this, I have to apologize. This is in German, but this is from the German Society of Respiratory Medicine, the meeting we had 3 weeks ago. And this is data from our institution about 370 patients we operated on and obtained molecular testing. We do that now within the Charité National Network of Genomic Medicine platform. We have that as a scientific goal to analyze all patients. So the total cohort of patients is 370. And if you look at, for instance, EGFR mutation, this is cohort, only operated patients, surgical procedures, and surgical specimen, you see obviously in these patients, they have 6%. This is the standard we have in Germany. If you only look for adenocarcinoma, we have 10%. This is what we have in our region. And in rebiopsy rates, it's pretty much the same. So obviously, we have EGFR mutations in about 10% of our adenocarcinoma patients, and they shouldn't undergo surgical procedures in terms of neoadjuvant treatment in terms of being treated with nivolumab. Yeah. What's more interesting is even if this is a prognostic marker, and we have the recent approval for that, KRAS G12C, sotorasib, has been approved in Germany. Then I've seen that you had data on G12C new compounds at your session. This is about 10 to 15% of our population. You know, if you have 15% in adenocarcinoma alone, this is the lower bar. Obviously, in our population, we have a substantial proportion of patients who might not benefit from neoadjuvant treatment, or in the adjuvant setting should be considered as maybe as a patient cohort with a driver mutation. Why do I mention this? And the question is, P53 is the same, is the fact that obviously if we try to move into the first option to have all patients also in earlier stages to be evaluated for systemic therapy, then we should also consider this is a very costly form of treatment, both the neoadjuvant as well as the adjuvant setting. Then we have to consider who's going to pay or reimburse for a screening for driver mutation in this cohort, which definitely will ultimately lead to exclude certain patients from IO treatment, both for EGFR or other things. So I think this again would be something to consider. You know, if we move with our new compounds into the earlier stages, there are two things to consider. Both the multidisciplinary board with our surgical colleagues is of utmost importance, a very close collaboration. We should include the radiation oncologist as well. And the second thing, if we try to implement next generation sequences at the later stages, then we should consider, if we use systemic therapy in our patients, we should use that in the long run also for the earlier stages. Not only just to exclude patients who very likely do not benefit from that, but also to find some kind of tools in our registries that we can identify patients at risk. Patients who do not perform very well despite best surgery, best radiation oncology, or best systemic therapy. And we have to learn that. We are running into a very complex overall situation in terms of treatment options. It's very complex now in lung cancer, and it will become more complex. With the addition of the new drugs like the antibody drug conjugates or other drugs, it's getting more and more complicated, and we need more information next to performance status, age, and gender to understand what patient cohort has the highest benefit from that. So the NADIM trial, if we look at the NADIM trial at the very beginning of that, then we obviously have in these patient cohorts the situation that these patients do perform okay, but the problem with with this cohort was that I skipped that. Let's see if we come back to that. Wait a second. We have to consider that this obviously is a situation that, despite the fact that the checkmate 816 has ultimately led to approval in neoadjuvant treatment options in our patients in Germany, we still have to consider that to be something where we can warrant some attention in terms of excluding the mutations, discussing the patient with the surgical colleagues, and in particular to understand that obviously that is going to be something in stage 3A and 3B for patients to be downstage. And again, finally, we do not have the situation that we have data in the long run in terms of understanding what is the outcome after 2, 3, or 5 years. And we have to just like to understand that in the combination of treatment options in these patients. So finally, I would like to come to one thing which is at something which does play an important role, is the discussion of the third abstract, the outcomes of the treatment option we have in patients above 50%. You know, this is the ultimate debate between having monotherapy or triple therapy. What is the right patient cohort for what? And the real problem is, despite major efforts from most clinical, very active PIs worldwide, from wherever you come from your country, from other countries, from Spain, from Italy, from Germany, from the US, there was no company interested in having a head-to-head clinical trial looking at that. So we don't have data for that in a prospective fashion. This is not very good. And due to the delay of approval for the triple therapy compared to the monotherapy, obviously our data sets are different. So Akinbo showed data, and this data are very interesting. And I think there are two things we have to learn from here. First of all, obviously, due to the different kind of approval times, we have different kind of options for these patients. Again, as I mentioned before, that ultimately will lead to a heterogeneous group of patients, but overall, the overall survival for these patients were there. And he could show in a large cohort from hundreds and sometimes thousands of patients that obviously there is no major difference between IO mono or triple. So that was somewhat sobering. But I think personally, if you look in more detail to these patient cohort, I will show you something which is very interesting. First of all, this is in a repetitive fashion, very important news, the never smoker story. So as we already have learned from the driver mutation patients, they do not perform very well with IO. Never smokers obviously have a higher benefit if you combine pembrolizumab with two other drugs, the platinum doublet. So this is very safe. There has been data from this large retrospective cohort. There has been data at the ASCO meeting from the Dana-Farber Institution showing the same. And this, I think this is safe. Never smokers or very light smokers, I think that you should go for the triple. The second thing, age. Age is above 75. We should offer pembro mono, for instance. I think this is something we have to consider. In most of our countries, we do not have the option to escalate the treatment, starting with IO mono and then escalating to triple. I think that's definitely would be an option. I think especially if you use carboplatin with a lower AUC, I think that would be something we would love to have, but this is definitely in the pembro patient cohort above 75. I think this is very helpful. We have data from our registry here in Berlin where we definitely show that, especially in the poor performance status brain mets, pembro is safe, and I think we should have a monotherapy for these patients. So what is the third option? And he didn't show that, and we contacted him, Akinbo, from the German group of internal oncology people, gender. There is a difference in response to the pembro mono patient cohort between male and female patient. And this time, that's the only time we have so far, is that we do see that women do poorly with pembro mono compared to men. And I think this is something we can reproduce in our cohorts too. And that would be the very first time, I think, that we can discuss that obviously based on the biology, due to hormonal effects, even also in postmenopausal women, obviously the response to pembro mono does have a difference between male and female patients. The full paper hasn't been published yet, but we personally believe, and we have discussed it in our group of lung cancer specialists in our country, that that would be something, a clinical marker next to age, smoking status, something we should consider if we use pembro mono in certain patients which are not older than 70 years old. If that would be true, and again, we do not have prospective data, but good clinical retrospective data sets, that would be the very first time in lung cancer medicine that we can clearly show there are differences in terms of responses between male and female patients. And we should stress that point. You know, we should stress the point that certain patients should receive certain treatment options. And that is something, again, a call to everybody. in all countries to understand that. And that would be very helpful if that paper by Akinbori would show that obviously we can base on certain kind of clinical parameters what would be the best option. I think due to the restriction of that clinical study here, he cannot really show everything in terms of PD-L1 expression, genetic markers, etc. But based on the clinical situation, tumor burden, age, never smoking status, and sex, it would be very helpful if we can use these markers in a respectable large cohort of patients we do see in our countries, in our outpatient clinics.
Chris,
so
2 minutes.
I would like to stop here.
Okay.
For the
Okay, we'll go for the polls. Okay, so when we need to go for polls. Can you please scan by your phone? Thank you, Chris. That was excellent discussion. Thank you so much. We'll go for polls and questions, and in between, can I please invite all speakers to be online as well? We'll go for voting, and then we'll consider the Q&A session. Polls, please. So the first questions, you can guys go for the scanning, and so you can vote as well. So the first question, did you attend the ASCO this year? Physical, virtual, none of the above. Can you please vote? So we have almost 4,000. Now it's 5,000. They are in the voting process. So physical about 13%, which is great. 49% virtual, and none of the above 38%. And do you think ASCO data is still leading our practice? Agree, disagree, abstain. Can you please vote? So 88% see that ASCO is leading our practice. It's 88%. Disagree about 3% and abstain about 9%. Third question, in non-small cell lung cancer with PD-L1 more than 50%, do you prefer, based on the pooled analysis, which is presented by Dr. Arasha and discussed by Christian, that single agent Pembro or combined IO chemotherapy? What do you think? Can you please vote? So 60% went for the combined IO chemotherapy and 40% went for the single agent Pembro. So most of the people in favor of the IO plus chemotherapy, even for the patient with more than 50%. So what do you think, Christian?
I think, as you are probably right, that we have to bring more information to everybody to understand why that is. But as I pointed out, there are certain subgroups of patients who definitely need triple. And the average age at my country at the moment for the diagnosis of lung cancer is 71. So we are getting close to 75 here. And we do see a lot of patients, unfortunately, who do not do very well on chemo. And for that reason, I think I would be happy to have options not using chemo backbone in these patients.
What do you think, Dr. Rasha? I think you made it clear that for a patient who are more than 75, this patient, we can go for single agent and we can stratify the patient based on their age, performance status. And in the meantime, the combination has the benefit for the PFS and the response rate. So what do you think? Dr. Rasha, you are muted.
I think it is a broad question. Now working. I think if I am asking the question for all the patient population, it would be unfair. These trials prove that overall survival and progression-free survival was in favor for those elder population. If I need more data for more prospective trials to give a real world population based on which I will give this decision. But until now, if I am aiming to improve the overall response and PFS, I should choose the IO plus chemotherapy if the patient can tolerate without any comorbidity and good peace.
Thank you. So the next question is Checkmate 816 and Nadim study. And we know that the Checkmate 816, it was phase 3 study, and Nadim is a Spanish trial, and it was presented elegantly by Dr. Marwan. And it was proven the concept as a new adjuvant therapy for patients with stage 3A and B as well. So in those two studies, are changing practice as a new adjuvant therapy in non-small cell lung cancer? Single choice, agree, disagree. I am a believer of conventional therapy, which is surgery upfront followed by adjuvant therapy based on the staging. Can you please vote? We have a lot of believers. Dr. Marwan, you are with us?
Yes, Dr. Mervat. Yes, I think Dr. Grohi had a good insight about, presented a good insight about all the approach or this kind of approach of what to do in the neoadjuvant setting. And he clearly mentioned that the risk of delaying the surgery, the problem with the surgical procedure and so on. I think those are like very, very important factors that comes into mind when you decide whether to go with neoadjuvant treatment or not. But really, I like in the NADIM 2 trial is actually, they're talking about a very, a patient that actually we argue a lot whether they should go for surgery or not because they have a huge disease, a very locally advanced. We're talking about N2 disease. We're talking about multi-level, multi-stationary lymph node disease. Really, the question whether to go for surgery or not actually is difficult, and it has to be presented in the tumor board. You have to have an excellent surgeon and even an excellent surgical thoracic surgery center to tackle those issues. So I think the option is there, and the data that shown in Nadim and also in the Checkmate 816, I think it's in favor of giving new adjuvant to those patients with a very high likely chance of going into a definitive surgery.
And it looks like maybe also we have a progression or event-free survival that looks better as well. So it's there, it's an option. Also, if you have a patient with a higher PDL, it might be working better, but the problem, how quick you can get the PDL testing done for those patients. So really, there are many factors that can affect your decision. But for me, I think, yes, it's a practice changing. I think we can use it sometimes. I'm sorry if I took longer, sorry.
Problem. Thanks. Thank you very much for your comment. So for the result of the voting, 69% were agreed about the neoadjuvant as an upfront. You were being very convincing, Dr. Marwan, and about 24%, quarter of the population, I'm a believer of the conventional therapy. So Chris, we do have in the Nadim study, it was proven the concept of the neoadjuvant. And in the meantime, they included patients with 3A and 3B into disease as well. So do you think that 3B patients, they have patients should go?
First of all, I think Dr. Marwan excellently pointed out what kind of patients we are discussing at the moment. And this is the cohort of patients in stage 3, 3A, 3B. And we would like to use these patients to be seen in the tumor board and then downstage these patients. I think this is the patient cohort we would like to operate on. And what we do see from our clinical studies and from the patients we have enrolled in clinical studies, that is working. You know, if the benefit of the patients will be long-standing, we don't really know, but we definitely can downstage patients we have seen, which we haven't considered to operate on earlier before. Now we discuss these patients and we use these patients. And I think this is very helpful. You know, overall, it's just bringing us all together. And at the very end, you know, the overall survival rates of all patients undergoing surgical procedures definitely could be better. And that's what we're going to do together.
Perfect. Okay, yes, please.
Dear Chris, I'm Professor Abdullah Barry. I have interest also in lung cancer, but not as much as you. I just want to comment about the Nadim study. Sure, it is an option, but my thoughts is, should we limit this to patients with N2 disease like in the future studies, or stage 3B? And my second comment that I think still this is a phase 2 trial. Should we wait for a phase 3 trial to make it like practice changing? And the third comment is, should we combine this with post-operative immunotherapy, as we have data from the durvalumab in stage 3 patient, non-resectable patient following chemoradiation? Your comments, please.
Excellent questions. So I try to do one after the other. First of all, you are absolutely right. The Nadim trial, and is in particular the first Nadim trial, enrolled patients you probably would never ever operate on. And they ended up having a pneumonectomy. And a pneumonectomy, you know, these days, today, is not an option for us, because this is a disease. You know, the patients will have a long-standing problem left with one lung. So patient selection in a phase 3 study would be very helpful. I wonder if we're going to have these data. There is another trial with pembrolizumab, the Keynote 671 for neoadjuvant options. That's the phase 3 studies. We will see these data. The overall problem, and you really pointed that out already, is patient selection. Patients who end up in a neoadjuvant trial are different from the real world scenario. So the second part of your question would be, what kind of patients to pick? The N2 patients, the patients maybe with a small margin, the patients who have maybe a close infiltration into the mediastinum. I think here we can at least try with our local expertise to downstage these patients. And I think definitely we have to do a learning curve. what our colleagues from surgery said, the lung looks and behaves different under preparation during surgery. And the pathologists say, well, yes, we have a major pathological response, but we already know from these patients in the long run, they probably need a very thorough surveillance program afterwards. It's not over with the surgery. You need probably a certain kind of adjuvant treatment, and that's a multimodality treatment option. You know, neoadjuvant treatment, surgery, recovery from surgery, and maybe afterwards immunotherapy. And the dropout rates from immunotherapy in the adjuvant setting, for instance, in the IMpower 010 study, are very high. So this is complicated in terms of management of the patient. And the patient, to say that at the very last thing I would like to say, the patient who addresses to come to a surgeon thinks he will operate me, and after that, everything is fine. And that has to change. You know, we have to discuss that from the very beginning. That's going to be a long distance run with a lot of hurdles for the patient, you know, the complicated issue.
Thank you. So we'll go for the next question. Chrysalis 2 is an important study, as it was presented by Dr. Abdullah, that for amivantamab plus lazertinib for the patient who progressed on osimertinib, and those patients, they had a good response. So they consider it is important study, agree, disagree, I need more data. Can you please vote? So 81% of the population, they agree about it. You are very convincing, Dr. Abdullah, and about 4% only disagree, and 15% they need more data. You don't think that this combination is a little bit toxic? And of course, it's totally unmet need, specifically that we now have the osimertinib on the adjuvant setting, and also lazertinib is third generation, high CNS involvement. So what do you think, Dr. Abdullah?
Yes, thank you so much. I agree with the survey that I think it's important, but it may not be practice changing, given the fact that the nature of this study is a phase 2 clinical trial where in a common disease, which is an EGFR mutant. So it's a proof of concept, but it's not really practice changing. The important fact when you look at this combination, although it's two different combinations where you put antibody as well as with the one of the third generation TKI, is the concept of combination or non-chemo combination is really important and valid in a disease where we try to target or in the disease where we have an oncogenic driven tumor, in a way to avoid chemotherapy or at least delay chemotherapy as soon as possible. Also keep in fact that when you look at this phase 2 clinical trial, it also looked at the role of newer generation TKI, where not just those are more potent when it comes to the disease activity, but also they have more CNS penetration. And this is also was seen in this phase 2, where almost a third of those patients, they have complete intracranial response. Definitely the main concept of phase 2 is just a proof of concept, and just to see whether this combination can be looked at in a phase 3 in a more frontline setting. And I think this study was positive, and that's why there are now a number of clinical trials addressing this combination in a first line setting. I agree with the fact that when we move to first to second to third generation in a front line, we end up with a dilemma that we don't know what we should do subsequently, but definitely I think we always have to keep the concept of best drug should be used first, and I think we at some point we have to deal with resistance mechanism, and more clinical trial will be addressing those patients at some point. So
thank you, Dr. Abdullah. So next question, code break 100 for cetracep in KRAS G12C mutated non-small cell lung cancer is very promising. And we know that those patients they were treating upfront, and then they were treated with cetracep. So do you agree, disagree, waiting for phase 3 study? Can you please vote? Can you please comment, Dr. Hatoun, about the what is your choice? And if there, when we have a patient with driver mutation, we know that the KRAS patient, they can respond to IO therapy plus combination. And in the meantime, how about upfront therapy with cetracib? Dr. Hatoun,
do you want me to comment now or after the voting?
Okay, so the voting agree that it's a promising about 69% and disagree about 6% and waiting for the phase 3 study only quarter about 25. So they are convincing that even for phase 2 study, you can go ahead and give the patient as a subsequent therapy. Go ahead, Dr. Hatoun.
Well, it depends on the practice. So if you are enrolling a patient with KRAS mutation in a clinical trial, you know, I would look for the trial that is tackling this mutation as the first line. But if I'm giving the treatment as a standard of care, I will just follow the approved or the trials that I have available in front of me. So as of this point, if I have a patient with KRAS mutation, I will start with a standard of care, and upon progression, probably after first line, I will switch to cetracib.
Perfect, thank you. Last abstract, lung map study with ramucirumab plus pembro after IO progression is a good signal. Agree, disagree, I will go for chemotherapy plus ramucirumab as a standard of care. Can you please vote? So the study gave overall survival and there was no significance regarding PFS or response rate. And we agreed that it may be a good signal. So 83% of the voters agree about it, 5% disagree, and 12% go for chemotherapy plus ramucirumab. I think I was very convincing, and Christian as well. And because I have to run for the time, we'll go for the last question in the voting. Which abstract or abstracts, in your view, is a changing practice? Can be more than one choice. The pooled analysis for the pembro versus IO chemotherapy, or Nadim study as a new adjuvant, or Chrysalis 2, or the code break 100, or the lung map, or none. Can you please vote? So who is the winner? Okay, so the winner is the pooled analysis, 26% versus the neoadjuvant 17%, the Chrysalis 22%, 12% for code break, and 19% for lung mab, and none about 5%. Thank you very much. That was a lovely contribution, and thank you very much for all the speakers. Do you have any questions for the speakers before closing the session? Yes, Dr. Professor Abdullah, go ahead.
Actually, again, for my dear friend, Dr. Christian, again, about your last presentation, the abstract of ramucirumab. Do you think, Christian, that we should go over the RECIST criteria for evaluating response when we are using the biologicals? And this is a message for everybody. The authors were having like a question about concordance between the objective response rate and duration of the response. And I found no reason for that, because we are not after the size anymore. It is the activity of the tumor, the same size, but not active. Should we combine our evaluation with a PET scan, for example, or something in the future to look about the activity? Your comments, Chris.
You did a very close observation of the presentation of that study. In my opinion, he didn't show all data sets and not all statistical analysis. And it's obvious that certain kind of statistical parameters were not shown. And especially the two you pointed out, there seem to be not to be very, we don't understand that properly. And I would like to see a full paper here. And the JCO paper, I haven't read that, to be honest. Should help us to understand what's the situation. It doesn't make any sense in terms of what we have presented here. The abstract we have seen and the presentation does not completely explain the findings and the hypothesis based on these findings. So I need more biostatistical analysis to make sure that this is really working. We have a data set, we will present that at the World Lung Cancer meeting now this summer, where we have a study in Germany using nintedanib and nivolumab in a certain similar settings. And that's difficult in terms of interpretation for this data. So I think overall, it needs more data to understand. To argue this is a very good study and something very solid we can use.
Perfect, thank you. Because we are running out of time, first I would like to thank my co-chair, Professor Abdullah Barry, for sharing this session with me. And I would like to extend my thanks to all the speakers, Dr. Rasha Haggag from Egypt, Dr. Marwan Al-Higeli, Dr. Abdullah Barry, Dr. Hatoun Bakhariba, and of course, last but not least, Dr. Christian Groh. Thank you very much for joining us, and they're always happy to have you. I would like to thank you all for attending this session, and it's my pleasure to go for the last, for the slide symposium. And I would like to introduce our moderator, Dr. Abdullah Barry. He is known for everybody. He is a medical oncology consultant in King Fahd, the medical city. His main interest is breast and breast and lung, and he will chair the BMS Satellite Symposium. Dr. Abdullah Barry, the floor is yours. Thank you very much.
Thank you so much, Dr. Mirfat, and thanks really for being in this event. Definitely, and I would like also to thank BMS for being part of this satellite symposium, and it's really my pleasure to introduce our satellite speaker for tonight event, Dr. Samah Al-Ruhaili. She is also a medical oncologist at Prince Noura Hospital in National Guard Jeddah. She will try to highlight an ASCO recap for immunotherapy and thoracic tumor. And you know that immunotherapy, especially when it comes to lung cancer, is really changing. And now we are moving from single to combination, and there are different approach. There are a number of ASCO also update, and I can assure you that Dr. Samah also has been attended physically at ASCO meeting, so definitely she will tell you something that she has seen with her eye. So, Dr. Samah, I think the floor is yours.
Thank you, Dr. Abdullah. Assalamu alaikum. Happy Friday, everyone. I would like to thank the organizing committee for actually giving me the chance to present today, and also PMS for inviting me. So, today, I'm going to talk about a few updates in the ASCO in terms of the immunotherapy. So I'm going to go over the Empower 010, Keynote 091, and then the ASCO update about the Checkmate 816, 9LA 227, and then conclusion. So the beginning of my presentation will be about resectable, and then we'll end with metastatic setting. So as we all know, when we treat lung cancer, all the treatment that we offers is trying to improve patient survival. And the overall survival at 5 years for stage 1B is 68%. So we have still a group of patients where actually they are going to die from lung cancer. And when we look at stage 3A, the 5-year overall survival is 36%. So we have around 64% of the patient will actually die from lung cancer. When we add neoadjuvant and adjuvant therapies to treatment options, we are hoping, or the goal or the main is actually to improve the patient outcome and improve their survival. When we look at neoadjuvant and adjuvant treatment options, both add between 4 to 5% absolute benefit in the 5-year survival rate. When we look at our approach, if the patient is upfront resectable, and this was up to ASCO 2021, when we look at the patient, if he's upfront resectable, we go with resection followed by chemotherapy. And then we had we had a few years data now about using EGFR TKIs in the adjuvant setting. But then more recently, we are now having approval to use IO in the adjuvant setting. The other approach was if the patient is actually, he is not upfront resectable, he's resectable, but surgeons and radiation with medical oncologists in MDT discussion, they offer concurrent chemoradiation and then followed by surgery is another approach. But now we have a lot of data and also ongoing trials about the perioperative approach, either neoadjuvant chemo-IO or neoadjuvant adjuvant chemo-IO. And hopefully in the near future, we'll hear about the neoadjuvant adjuvant approach. In this slide, you can see the advancement. So for many years, we did have few trials in the resectable or curative intent non-small cell lung cancer. And then since 2018, we're having more and more approval of medication in the curative intent. What we have is from December 2020, osimertinib from ADAURA in the adjuvant setting. And then October 2021, we have atezolizumab from IMpower010 in the adjuvant setting. And in this year, March 2022, we have neoadjuvant nivolumab in combination with the platinum doublet chemotherapy as an FDA approved as well. So the goal of adjuvant cancer immunotherapy is to prevent relapse by targeting micrometastases. This is a very elegant paper where they actually took tumor cells, lung cells, and blood from the patient, and then they barcode it, and then they actually follow it post-surgically, and they found that there is a lot of tumor immune microenvironment changes that will actually predict response to immunotherapy, and that's why is the hypothesis behind using adjuvant immunotherapy. This is also another paper discussing the different surgical, post-surgical changes that will actually impact the tumor microenvironment, which will lead to increased PD-1, CTLA-4 expression, which will enhance the response to immunotherapy. We have two trials in the adjuvant setting. We have atezolizumab, IMpower010, and we have PEARLS, pembrolizumab KEYNOTE-091, and I will go over them quickly. So ASCO last year, IMpower010, they actually included patients with completely resected stage 1B to 3A, excellent performance status, lobectomy, pneumonectomy, and then patients were offered platinum or cisplatin plus pemetrexed or gemcitabine, docetaxel, or ven, and then they randomized patient after that to atezolizumab or best supportive care. No crossover was allowed, and the primary endpoint was DFS. Their statistical analysis or testing was based on hierarchical. So if DFS in PD-L1 more than or equal to 1 is positive in stage 2 to 3A, they go to all randomized 2 to 3A. And then if positive, they go to the DFS in the ITT population, including 1B. And if positive, they analyze the overall survival. Baseline characteristics were well balanced. And they had 60% of the patient, or 2/3 non-squamous. They had around 47-50% stage 3A. And when we look actually at the results, so the DFS and the PD-L1 TC more than or equal to 1, the median DFS was not reached in the atezolizumab versus 35.3 months in best supportive care with hazard ratio of 0.66. When we look at the DFS in all randomized 2 to 3A, the median DFS was 42.3 versus 35.3 with hazard ratio of 0.79. And then when we look at including stage 1B, the hazard ratio is 0.81 with atezolizumab arm not reached versus 37.2 in the best supportive care. When we look at the subgroup analysis, current smoker did cross 1. When we look at the EGFR, I will comment about it later, but when we look at the ALK rearrangement status, it did cross 1 as well, questioning or no benefit in adding atezolizumab in the adjuvant setting. And keep in mind, this is a subgroup analysis. When we look at the PD-L1 status, the lowest hazard ratio is when the TC more than or equal to 50 with a hazard ratio of 0.43, and if the PD-L1 is negative, it's 0.97. So this is suggesting that majority of the group who actually, or the benefit was actually mainly driven in the PD-L1 positive. Then we had a more update in ESMO last year when actually they divided to negative, positive, or low positive and positive, and the lowest hazard ratio with most significant benefit is PD-L1 more than or equal to 50 with hazard ratio of 0.43. We had an update as well about local regional versus distant recurrence. Group who received atezolizumab had more local regional rather than distant recurrence, and the opposite in the best supportive care. Time to relapse was longer in the atezolizumab compared to the best supportive care. Overall survival data is very immature, and I cannot comment about it, hoping that we'll get more updates from the result. In terms of the safety summary, it's very similar to what we already know about the atezolizumab data, and nothing is actually new. And FDA approved atezolizumab in the adjuvant setting in the PD-L1 positive, regardless of the PD-L1 status. So when we look at the pearls or the keynote 091, it was presented in the ESMO virtual plenary session, and it's a randomized triple-blind phase 3 trial. Eligibility for registration, confirmed stage 1B to 3A, complete surgical resection R0, and they did PD-L1 testing, and then they did an eligibility for randomization, no evidence of disease, excellent performance status. Adjuvant chemotherapy considered for stage 1B and strongly recommended for stage 2 to 3A, and then they randomized patient to pembrolizumab versus placebo for 1 year, and the primary endpoint was DFS in overall population and DFS in PD-L1 positive. When we look at when they randomized patient, discontinuation of treatment in the pembrolizumab arm was mainly because of adverse event, while the main reason for discontinuation of treatment in the placebo was for disease progression rather than adverse event. When we look at the baseline characteristics, so 85 and 88% current or former smoker, non-squam 2/3, 14% stage 1B, 55 and 57% 2, and 30 or 27% 3A. And then when we look at the group who did not receive adjuvant chemotherapy, it was around 14%, and the PD-L1 negative is around 40%. The DFS of overall population, the median was 53.6 versus 42, and at 18 months, the rate was for DFS in the pembrolizumab arm 73 versus 64 with hazard ratio of 0.76. When we look at the PD-L1 positive, it was actually the hazard ratio was 0.82, 71 versus 70. And then when we look at the subgroup analysis, so the lowest hazard ratio was in the current smoker. And when we look at the pathologic staging, in fact, stage 3A had the highest hazard ratio of 0.91. When we look at the group who did not receive adjuvant chemotherapy, it did cross 1. And when we look at the EGFR mutation, as you can see here, the lowest hazard ratio is for patient with EGFR positive, it's 0.44, but the confidence interval is wide as well. But it's something to keep in mind. And also, again, this is a subgroup analysis. The overall population, the overall survival is very immature, hazard ratio 0.87. And the adverse event is very similar to what we know for pembrolizumab from the previous data. So pembrolizumab provided statistically significant clinically meaningful DFS improvement versus placebo in the overall population, and the data suggest pembrolizumab has the potential to be a new adjuvant treatment option for patients with stage 1B to 3A non-small cell lung cancer following complete resection and adjuvant chemotherapy when recommended, regardless of PD-L1 expression. Then we have more update about the potential impact of the type of surgical resection baseline disease burden and the use of adjuvant chemo on the DFS. So when we look at the type of surgery, there was benefit regardless of the type of the surgery. When we look at the node status, it did cross 1 in N2 disease. When we look at the who received not received adjuvant, there was actually it did cross 1.25 hazard ratio if no chemotherapy. And then when we look at the type of chemotherapy, it seems that people who received carboplatin paclitaxel did cross 1 with a hazard ratio of 1.21. Then when we look at compare the two trials, it's very important to keep in mind that when we actually compare the trials, there is a lot of differences between the two trials before randomization. So it's very, it will not be fair to compare trials this way, but this is the only way we have. So when we look at Empower and Keynote 091, best supportive care was the control arm in the Empower versus placebo in the Keynote. Then both trials is actually, so the primary endpoint similar DFS. When we look at its randomized, large number of patients, staging percentage is slightly different, as well as the PD-L1 status. And then chemotherapy was required in the Empower, cisplatin is required, and in the Pearl, chemotherapy recommended and carboplatin permitted. If we look at the overall result, so the primary endpoint, hazard ratio is quite similar. Hazard ratio is 0.79 from the Empower and 0.76 from the Pearl. When we look at the PD-L1 expression as a prognostic or predictive factor, as you can see here, the PD-L1 more than or equal to 50 had the most benefit. When we look at actually PD-L1 positive from the Pearl, there's a question if there's a benefit. Personally, I think the data is still immature, and we should wait for more update from the Pearl before saying that maybe there was no benefit in the PD-L1 positive group. When we look at the EGFR mutation, Pearl did show that there is benefit in EGFR positive. Empower 010 showed that there is no benefit in the EGFR mutational status EGFR positive. We know generally immunotherapy does not work if there is genomic alteration, but again, I think we need to wait for the data to mature. Then for patients who did not receive chemotherapy, they actually hazard ratio was 1.25. This is a small group who did not receive the chemotherapy, and again, the data again is immature. So what about markers? From the Empower 010, there is actually an importance of the ctDNA. If the ctDNA is positive, the DFS is actually better compared to the ctDNA positive. So ctDNA negative, either if received atezolizumab is the best, followed by best supportive care, and then ctDNA receiving the atezolizumab, and then the least is best supportive care. So atezolizumab is FDA approved as an adjuvant treatment following resection and platinum-based chemotherapy for adult patient with stage 2 to 3A whose tumor have PD-L1 expression on more than or equal to 1. We are still questioning if, or we're not sure if DFS is going to translate to overall survival benefit. There is more questions about the PD-L1 level, about the driver mutations, about the adjuvant chemotherapy, and hopefully in the near future we'll have more updates from the trial. The other thing is we have a lot of ongoing, so with a lot of ongoing trials, we'll have more data and more questions to come. Switching gears to the new adjuvant versus adjuvant, we have the Checkmate 816. Checkmate 816 is a neoadjuvant nivo plus chemo significantly improved the primary endpoint, which was the event-free survival and the pathologic complete response versus chemotherapy in patient with resectable non-small cell lung cancer. Nivo plus chemo is now indicated in the United States as neoadjuvant treatment for adult patient with resectable tumor more than or equal to 4 or node-positive non-small cell lung cancer. In the last ASCO, they actually presented a post-hoc analysis evaluating the association between pathologic regression and event-free survival from the Checkmate 816. So when we look at the EFS by pathologic complete response, when they look at nivo plus chemo versus chemo, actually the group who had pathologic complete response had a higher EFS, 93 versus 58 in the Nivo plus chemo, and 100 versus 52 in the chemo. And then the EFS was also improved in patient with MPR in the primary tumor compared with those without. So when we look at the based on actually the staging EFS by pathologic complete response and baseline stage, the complete pathologic response correlate to with a higher EFS rate compared to no pathologic response in stage 1B to 2, 90 versus 56, and in stage 3A, 96 versus 59. When we look at the EFS also by PD-L1 status, there was benefit regardless of PD-L1 status. If PD-L1 is negative, it is 86 versus 47, and in the PD-L1 positive, 97 versus 72. Then they did comment about the event-free survival by depth of pathologic regression. They based on a ROC curve analysis, the depth of pathologic regression measured by percent RVT as a continuous variable in the primary tumor. And so if the RVT is 0 to 5, 45%, if it's more than 5 to 30, 17%, more than 30 to 80, 18%, and more than 80, 21%. And then they actually analyzed the EFS by percent RVT, and they found that the RVT 0 to 5 is 90, followed by 60 for more than 5 to 30, followed by 57 for more than 30 to 80, followed by 80% for 39% for more than 80. Then in terms of safety, there was no new safety signal. And the conclusion from this post hoc analysis from Checkmate 816 provides the first in-depth assessment of pathological regression and EFS in a phase 3 trial with neoadjuvant immunotherapy. EFS was improved with neoadjuvant Nivo plus chemo and chemo in patient with PCR or MPR in the primary tumor relative to those without. In the Nivo plus chemo arm, EFS improvement in patients who had a PCR was observed regardless of baseline stage of disease or tumor PD-L1 expression. Patients with deeper pathologic regression in the primary tumor with neoadjuvant Nivo plus chemo appear to have a better EFS outcome at 2 years, and the neoadjuvant Nivo plus chemo showed a similar safety profile, and the result, along with the previously reported data, continue to support pathological response as an early indicator of EFS benefit with neoadjuvant Nivo plus chemo. So the other thing is, which we need to keep in mind, that there is unique features in the neoadjuvant treatment toxicity, like canceling surgery, delayed surgery, length of hospital stay, exposure to standard of care systemic therapy, pre-operative or perioperative death. And then we need to ensure that therapy does not negatively impact timing and safety of definitive surgery when we are actually thinking to consider neoadjuvant treatment. Switching gears to metastatic setting, Checkmate 9LA. So we all know the Checkmate 9LA, which is 2 cycles of chemotherapy plus Nivo-Epi versus chemotherapy. And the primary endpoint was overall survival. And in the recent ASCO, they actually presented the follow-up of 3 years update. So the 3-year update of the overall survival in all randomized patients has a ratio 0.74, and at 3 years, 27% of the Nivo-Epi plus chemo were alive compared to 19%. When we look at the overall survival by PD-L1 expression, there was benefit in the combination compared to chemo arm in all group, regardless of the PD-L1 status. When we actually, if we look at the PD-L1 negative, 25 versus 15, with hazard ratio of 0.67. If we look at the PD-L1 positive, it is 28 versus 19, with hazard ratio of 0.74. When we look at the PD-L1 positive, 33% versus 24, with hazard ratio of 0.75. Then when we look at the PFS, overall response rate and duration of response in all randomized patients and subgroup by PD-L1 expression. So as you can see here, the PFS is 13 in all randomized is 13% versus 5, in PD-L1 negative 17% versus 3, and in PD-L1 positive is 12 versus 6%. And when we look at a duration of response, more durable response was observed in the combination versus chemo arm, and as well as the overall response rate. Then they looked at the mutational analysis population, and they evaluated mutations such as KRAS, TP53, STK11, and KEAP1. And what they actually found that similar trends of overall survival benefit was seen with nivo-IO plus chemo versus chemo in the KRAS G12C mutation, KEAP1 mutation subgroup. So there was no difference actually when they analyzed it with the different mutations. And the conclusion from this update at a 3-year minimum follow-up, first-line nivo plus epi, plus 2 cycles of chemotherapy showed long-term durable overall survival benefit in patients with metastatic non-small cell lung cancer. 3-year overall survival rate was 27 versus 19 in the combination versus chemo arm. PFS and duration of response benefit were also maintained at 3 years. In the exploratory analysis in patient with non-squam histology, a trend of overall survival benefit was observed in the combination versus chemo, regardless of KRAS, TP53, STK11, and the KEAP1 mutation subgroup was small, limiting data interpretation, no new safety signal, and these updates result further support the use of the nivo-IP plus chemo as a first-line treatment option for patients with metastatic non-small cell lung cancer, regardless of their PD-L1 expression or histology. Then Checkmate 227, we had from the recent ASCO the 5-year update. So they presented, which is the longest reported follow-up of a phase 3 trial of first-line combination immunotherapy in the metastatic setting. So at a 5-year overall survival in patient with PD-L1 more than or equal to 1, it was 24% versus 14%, with a hazard ratio of 0.77. When we look at the PFS, it was 12 versus 2%, with a hazard ratio of 0.79. Duration of response, it was 28 versus 3%, with actually duration of response is 24.5 months. When we look at the 5-year overall survival in patients with PD-L1 negative, it was 19 versus 7%, with a hazard ratio of 0.65. When we look at the PFS as well, it was 10 versus 2%, with hazard ratio of 0.75. And for the duration of response was 21 versus and the median duration of response was 19.4 months in the combination arm. Then in a 5-year survivors treated with nivo plus epi versus chemotherapy, 62% versus 20%, PD-L1 positive, and 64 versus 17% PD-L1 negative remain treatment-free 3 years after discontinuation of the study treatment. And in 5-year survivors treated with nivo plus epi, they also had a good quality of life. And the conclusion from this, in this landmark 5-year analysis, the longest reported follow-up of a phase 3 study with a first-line immunotherapy combination for patients with metastatic non-small cell lung cancer, nivo plus epi demonstrated long-term durable benefit versus chemo. The 5-year overall survival 24 versus 14 for PD-L1 positive and 19 versus 7 for PD-L1 negative. Median duration of response 24 versus 6 months for PD-L1 positive, 19.4 versus 4.8 in the PD-L1 negative. Nivo plus epi led to increased 5-year survivorship among these 5-year survivors, and regardless of PD-L1 expression level, responses were maintained for more than or equal 5 years in more than 40% of those who responded, and the majority remained treatment-free for more than or equal to 3 years after treatment discontinuation. Quality of life was similar to the general US population. And these long-term results from the Checkmate 227 further support nivo plus epi as an effective first-line treatment for patients with metastatic non-small cell lung cancer, regardless of tumor PD-L1 expression level. And by this, I actually conclude my presentation from pictures from Chicago. Thank you.
Thank you so much, Dr. Samah, for highlighting the ASCO abstract. So when it comes to immunotherapy, I have probably 1 or 2 questions. The first one is about the abstract that you have highlighted in the early disease setting, the adjuvant and the new adjuvant both trials that have addressed the adjuvant, the Empower, as well as the BERS have proved the fact that immunotherapy add to the adjuvant setting in those patients. Also, we have you have highlighted the data of Checkmate 816, and also in the earlier session, also we heard more about other trial in the new adjuvant, which also highlight the fact that immunotherapy is really added to the outcome in an earlier disease setting with a new adjuvant or adjuvant, whether this will be translated in an overall survival. I think that the time will tell. But the question is, and both trials really did not address the appropriate timing for those treatment, whether immunotherapy might be useful in early in a new adjuvant versus adjuvant, giving the fact that all those trials did not really properly answer the timing, the same concept that we have in the past about the new adjuvant and adjuvant chemotherapy. What is the appropriate time? The other fact is or maybe the argument for the new adjuvant therapy is the fact that the importance of PCR and whether the no PCR have an impact on the treatment subsequently. The story probably we have in breast cancer where you might change the treatment in the PCR. So how to select, since we have positive in new adjuvant and positive in adjuvant, how you select patient for both approach? What's really the factor that help to decide the appropriate timing of immunotherapy, whether single or combination in the new or adjuvant setting with this disease?
Thank you, Dr. Abdullah, for your question. Again, the field is very evolving. We have a lot of data. It's actually giving us more questions than answers. Number one, I think discussing every case in the multidisciplinary team is very, very important. Because I think with these data, now it's not only a decision of a medical oncologist or a surgical, I think it should be a shared decision. The other thing is, personally, I really think, so number one, for the adjuvant setting, we have Atezo approved, pembrolizumab is not yet approved, but I really think, again, we have to wait for the data because I think when the data is getting more mature, we'll have actually more approval medication. I think if I have an early stage and the patient is upfront resectable, then I think going with surgery followed by adjuvant chemotherapy followed by adjuvant immunotherapy atezolizumab is a reasonable approach. If I have a patient with N2 disease, I think in this situation I would actually prefer to go with a new adjuvant chemo immuno, and then going for surgery after, just because, again, it's a decision in the multidisciplinary, because I need also to hear from my surgeons what they think about the surgical resection as well. But for N2 disease, I would favor neoadjuvant over adjuvant immunotherapy. The other thing is the depth. So now a lot of people are talking about complete pathological response. So this is going to translate to overall survival, and we need time to know. But also, I think if you have an event-free survival, I think it's a meaningful clinical benefit, because you're delaying treatment, you're delaying morbidity, you're actually giving the patient more time of treatment. So it is actually a clinically meaningful outcome, but also an overall survival benefit will add to this as well. They commented on the major pathologic response is how deep is the major pathologic response can impact. Again, I don't think we have a standard definition of what's the major pathologic response. I don't know how the pathologist is going to measure it. So I don't know if it will actually translate to a clinical benefit, because again, it's not standardized yet.
Yes, thank you so much. I agree with you 100%. And let's switch gear to advanced setting, where you have highlighted the update that we have with the 9LA and 227, and both have addressed an important concept of a dual immunotherapy with or without chemotherapy. And it seems that it's innovative in a way. It not just have response, but also have a durable response. But My question is why Navy-AB? Why this combination comes, or the success that we have is only with this combination compared to other dual immunotherapy that you might have seen, like Durva, Trimi, and others. Is it AB as a backbone is probably have to do with this, or is it a synergetic effect between both immunotherapy? Why we have this success only with such combination?
Excellent question. I don't know if I have a perfect answer to it. I think it's a synergistic effect, and we see the same data from melanoma as what we are seeing in the lung with Nivo-Epi, but I really don't have a clear answer why Nivo-Epi and not the others.
Thank you so much. I'm not sure if we have any more question, or if we have no more question, probably it's the time to close Satellite Symposium. Thank you so much, Dr. Samah, and thanks everyone who has been there. And probably I will leave the final comment by Dr. Mirfat, if you would like to close the session, or Dr. Assam Murshid, he will close the session. Thank you so much for that.
Thank you.
Okay. So now we'll start with the third session, okay, which will last until انتوا قديش قدامكم؟ احنا جالسين هنا. Anyhow, thank you very much. The day have reached the end, and it's the new beginning, inshallah, for tomorrow. And thank you for staying here so late on a weekend. Except if you are running away of your children from your children and your wife, this is really appreciated, or your husband at the same time. So see you tomorrow, inshallah, at 10 o'clock with the GU session, followed by the GIT session. Thank you very much.